with support of Eternal Hospital Jaipur and CIPLA. Today's program is designed to combine expert talks with interactive sessions to enhance the knowledge. I hope this program is informative and engaging. To begin with, I call upon Dr. K K Sharma sir, the man behind this program, to give the orientation about the PH course. Thank you.
So good morning everyone. On the behalf of organizing committee, Eternal Hospital, CIPLA, I welcome you all. So today we are going to discuss about pulmonary hypertension. And as you are aware that pulmonary hypertension remains one of the most challenging condition in respiratory and cardiovascular medicine. Early recognition, systematic evaluation and timely referral can significantly improve patient outcome and improve the lives of the patients. So today's course has been carefully designed to bridge the gap between guidelines and day-to-day clinical practice. Throughout the day, you will participate in expert lectures, interactive case-based panel discussions, and most importantly, at the end of that, a hands-on right hat eco masterclass with ample opportunity to learn hands-on how to recognize pH with just putting a probe on patient's chest. So I encourage everyone to actively participate, challenge ideas and make the most of this unique learning opportunity. I am confident that you will leave with practical knowledge and skills that you can immediately apply in your clinical practice. Thank you for being here. I wish you all an enriching, interactive and enjoyable course. Welcome once again and let's begin. Thank you.
To begin our first session of the day, I call upon Dr. Devesh Kanungo sir, Dr. DC Gupta sir, Dr. Shabd Prakash sir, and Dr. Anirudh Seni sir to chair the session.
Hello. A very good morning to everyone. So without wasting time, I would like to start the session. I would like to invite Dr. Nitin Jain for the topic current definition and classification of pH.
Hello. So good morning, everyone. First of all, thank you, Dr. KK Boss, for giving me this opportunity. When I was giving this topic to deliver a talk on the definition and the classification, I thought that it is just the definition and the classification, but unfortunately, it is not like that. It is the entire process to understand the pulmonary hypertension. If you know the definition and the classification of pulmonary hypertension, you will learn a lot. Because pulmonary hypertension has undergone one of the biggest paradigm shifts in the last decade. It is a progressive disorder with high morbidity and mortality. Frequently under-recognized in the clinical practice, it represents a spectrum of the disorders rather than a single disease. Accurate classification guides the prognosis, research, and therapeutic strategies. Classification is no longer simply descriptive, but forms the basis for the diagnosis, risk stratification, and individualized therapies. Global prevalence is roughly around 1%, and around 3.7 cases per 1 lakh are confirmed by right heart catheterization. Group 2 and 3 accounts for 90 to 95% of the cases of PH worldwide, and as per the Pro-Kerala registry, Group 2 was the most common etiology noted, followed by Group 1 PH. So when we go for pulmonary hypertension, it is very important to know about the pulmonary hemodynamics, because knowing the pulmonary hemodynamics, we will definitely get an accurate and precise definition and the classification of the pulmonary hypertension, which will lead to a better prognosis and management. So the key parameters are, there are three main things to learn: the mean pulmonary artery pressure, pulmonary artery wedge pressure, and pulmonary vascular resistance. The pulmonary artery pressure is the average pressure in the pulmonary artery during a complete cardiac cycle, normal value being 8 to 20, and when it is more than 20 mm of the mercury at rest, it defines the pulmonary hypertension. And pulmonary artery wedge pressure is an estimate of the left atrial pressure, which reflects the pressure in the pulmonary capillaries. Normal range means 6 to 12, and when it is more than 15, it suggests the post capillary, that is the left heart involvement and the contribution to pulmonary hypertension. Pulmonary vascular resistance, this is the resistance offered by the pulmonary vasculature to the blood flow. When it is more than 2 Woods unit, it indicates the increased resistance in the pulmonary circulation. So knowing all these three things, we will learn a lot. These parameters are essential for accurate diagnosis, classification, and management of pulmonary hypertension. So definition of pH, it evolved in 1973 with mean pulmonary artery pressure more than equal to 25 millimeters of mercury, while in 2018 it was proposed to have a definition of more than 20, and which was adopted in 2022 at ERS, and in the recent classification the definition was retained. And this change from 25 to 20 was done because the range between 21 to 24 have shown the increased mortality and disease progression, so a minimum cut of 20 was taken. So pulmonary hypertension is a hemodynamic condition that is characterized by the elevation of the mean pulmonary arterial pressure above the upper limit of normal, which is considered to be as 20 millimeters of mercury. So pulmonary hemodynamics, to understand, is an increased pressure in the pulmonary circulation leading to resistance and right heart strain. In the normal pulmonary circulation, there are low pressures and low pulmonary vascular resistance in the artery, arterioles, capillary bed, and the veins. While in the pulmonary hypertension, due to vasoconstriction, vascular remodeling, and in situ thrombosis, there is high pressure and high pulmonary vascular resistance being seen. And when it is measured by right heart catheterization, we got to know the mean pulmonary artery pressure, wedge pressure, and we calculate the pulmonary vascular resistance, which defines the before the capillary bed, that is the pre, and after the capillary bed, that is the post capillary. So we will learn that like this. This is very important. Mean pulmonary artery pressure is like mean pulmonary artery pressure more than 20 mm of mercury. This is one constant thing which is there in everywhere. Then pre-capillary pH, here the mean pulmonary artery pressure will be more than 20, whereas the pulmonary artery wedge pressure will be less than equal to 15, and the pulmonary vascular resistance will be more than 2 Woods unit. In the isolated post-capillary pH, it has been seen that pulmonary artery wedge pressure is more than 15 and the vascular resistance is less than equal to 2 Woods unit, and in the combined pre and post capillary, all the three parameters will be increased. So there are other entities like early pH. The patients with a risk condition like reverse cirrhosis, systemic sclerosis for pulmonary hypertension, the mean pulmonary artery pressure ranging between 21 to 24 millimeters and PVR 2 to 3 may be at risk of hemodynamic progression on the follow-up, and this condition is called as early pH. The exercise pH, where it describes as a normal mean pulmonary artery pressure at the rest with an abnormal increase in the mean pulmonary artery pressure during exercise, and is defined as the mean pulmonary artery pressure via cardiac output slope more than 3 between the rest and exercise. Unclassified pH, where the patient exhibited elevated mean pulmonary artery pressure, but their normal vascular resistance and the arterial wedge pressure, and they do not meet the criteria of the pre and the post capillary pH, and the main pathology is the elevated pulmonary blood flow, which is commonly being seen congenital heart disease, liver disease, hyperthyroidism, and alcoholism. So the classification of pH is evaluated in 1973. The first classification was divided into the primary and secondary pulmonary hypertension based mainly on the etiology. Then in the third symposium, the 5-group classification was introduced, and in the fourth, it is refined the categories, and in the fifth one, they incorporated the genetics, like BMPR2 mutations, pathology, and imaging was accepted in these classification. Then the 2018, the sixth symposium was another changer in the pulmonary hypertension, where the definition of the pulmonary artery hypertension was refined to mean pulmonary artery pressure more than 20. They also emphasized on pulmonary vascular resistance more than 3 Woods unit, and diagnosing for pre-capillary pH, which in 2022 at ERS was again updated, and there the pulmonary artery wedge pressure less than 15 and Woods unit was bring to more than 2 Woods unit. So the recent one in the 24-25, the 7th World Symposium, they retained the 5-group clinical classification while refining the disease phenotypes, genetics, emphasizing precision medicine, multimodal risk assessment, updated recommendations for pH associated with left heart disease, lung disease, and CTPH with the subsets in their specific classification, and evolving concepts of exercise pH and early pH. So why should we revisit the classification? Because old classification was disease-centered and now moving towards hemodynamic, molecular, genetic, imaging, and therapeutic phenotypes. The 7th World Symposium categorizes the clinical conditions associated with the pH according to similar pathophysiological mechanisms, clinical presentations, hemodynamic characteristics, and therapeutic management. So when we come to the clinical classification, group 1 is the pulmonary artery hypertension, group 2 is pH associated with left heart disease, group 3 is pH associated with the lung disease, hypoxia, group 4 is the pH associated with pulmonary artery obstruction, and group 5 is the pH with unclear or multifactorial mechanism. So when we talk about the group 1, here this is the idiopathic, and there the long-term responders to calcium channel blockers were added, heritable, where the mutations are added associated with drugs and toxins like mitomycin C, amphetamines, and the toxins like cocaine and other things, associated with CTDs, HIV infection, portal hypertension, congenital heart disease, schistosomiasis, pH with the features of the venous and capillary involvements, and persistent pH of the newborn. So when we go for the group 1 pulmonary artery hypertension, it is the disease of pulmonary arterioles where the increased pulmonary vascular resistance is there, causing the right heart failure because of the endothelial dysfunction, vasoconstriction, which is the reversible component, and the vascular remodeling, that is the medial hypertrophy and in situ thrombosis, ultimately leading to increased PVR, increased mean pulmonary artery pressure, causing right ventricular hypertrophy and ultimately leading to the right ventricular failure. This is the only group where the pH specific drug classes are present, and pre-capillary pH, as we have seen, the pre-capillary pH, the MPAP will be 20, pulmonary artery wedge pressure will be less than 15, and pulmonary vascular resistance will be more than 2 Woods unit. So it's a pre-capillary pulmonary hypertension characterized by increased PVR with normal arterial wedge pressure confirmed by right heart catheterization, and now in the recent times the MR, cardiac MR. Treat early with risk-guided therapies, regular follow-up improves the outcome. This is only one group where the drugs are available for the entire process. The group 2, with the pH associated with the left heart disease, which is subdivided into the heart failure with preserved ejection fraction, with reduced or mildly reduced ejection fraction, cardiomyopathies with the specific etiologies, valvular heart diseases like aortic valve, mitral valve, mixed valvular diseases, and congenital and acquired cardiovascular conditions. Here, the pH due to left heart disease is the most common form of the pulmonary hypertension caused by increased left-sided filling pressures transmitted backward to the pulmonary circulation, where due to the systolic or diastolic dysfunction or the valvular diseases, it increases the left atrial pressure, increases the pulmonary artery wedge pressure. Because of the backward transmission, there is an increase in the mean pulmonary artery pressure, causing the pulmonary arterial remodeling and pulmonary venous congestion, and ultimately causing the right heart failure. And elevated pulmonary artery wedge pressure is seen here, then more than 15 reflects that this is the post-capillary origin. And when we look ahead, that in this, the management goes for the treating the underlying left heart disease, manage the congestion and comorbidities, and pH-specific drugs are not recommended in this subset. So the pulmonary hypertension is a consequence and not the primary disease here. And the key to improving outcome is treating the left heart disorder rather than lowering the pulmonary artery pressure with the pH-specific drugs in this group. Group 3 pH associated with lung diseases and or hypoxia, where COPD and emphysema, interstitial lung diseases, CPFE, other parenchymal lung diseases, non-parenchymal restrictive diseases like hypoventilation syndromes and pneumonectomy, hypoxia without lung diseases like high altitude developmental lung diseases. So here when we see there is the hypoxic pulmonary vasoconstriction, loss of pulmonary vascular bed due to destruction, rarefaction, endothelial dysfunction and imbalance of vasoactive mediators, inflammation and oxidative stress, vascular remodeling causing medial hypertrophy, intimal fibrosis, and polycythemia and hyperviscosity causing the increased pulmonary vascular resistance, causing pulmonary hypertension. The group 3 is typically there is mild to moderate pH is seen, and severe pH suggests the additional or alternative pathology or the advanced disease. So worsening dyspnea that is disproportionate to the severity of lung disease should prompt for the evaluation of pulmonary hypertension. Severe pH in COPD or ILD is associated with poor outcomes. The priority is treating the lung disease and the hypoxemia. Pulmonary vasodilators are reserved for carefully selected patients in the expert centers. In selected patients with the pH associated with ILD, inhaled treprostinil has demonstrated improvements in the exercise capacity in the recent articles, and we should incorporate pulmonary rehabilitation, smoking cessation, and vaccination in the management. Group 4 and 5, the group 4 is the pH associated with pulmonary artery obstruction, that is CTPH and other pulmonary obstructions. Group 5 is unclear or multifactorial, which includes hematological disorders, systemic disorders like sarcoidosis, pulmonary Langerhans cell, metabolic disorders like thyroid, chronic renal failure, pulmonary tumor, fibrosing media stenitis, complex congenital heart diseases. And when we look for the group 4, there is an organized thrombus causing the vascular remodeling and causing the increased pulmonary vascular resistance, causing pH and eventually right heart failure. This is also a precapillary pulmonary hypertension. So key features are that CTPH is a potentially curable cause of pulmonary hypertension. Ventilation perfusion scan is the screening test of the choice. Early referrals to CTPH center should be essential. Pulmonary end atherectomy is the potentially curative in certain cases, and which are non-operable, persistent or recurrent pH, where we can go for balloon pulmonary angioplasty and pH-targeted therapies like Rioshia-Gout, and long-term anticoagulation is needed in these cases. So timely diagnosis, expert evaluation, and appropriate therapy can normalize the hemodynamics and significantly improve the outcome in this subset. So persistent dyspnea, even after the adequate anticoagulation in pulmonary embolism, should always prompt the evaluation for CTPH. Group 5 is pH with unclear or multifactorial mechanism. So this is a heterogeneous group with variable mechanism, and this is also a precapillary pH, but with the high risk. Variable contribution are proliferation of the vascular cell, inflammation and immune dysregulation, endothelial dysfunction, fibrosis and remodeling of vascular pulmonary vasculature, thrombosis or NC2 thrombosis leads to increased PVR, causing mean pulmonary artery pressure and eventually right heart failure. Now, this is again a precapillary pulmonary hypertension, and it is a in this treatment approach is treating the underlying disorder and pH-targeted therapies in their individual basis. So group 5 is a heterogeneous group with unclear or multifactorial mechanisms. Always exclude group 1 to 4 before making the diagnosis for group 5. Focus on treating the underlying disease and comorbidities. pH-targeted therapies may be considered in severe cases only at the expert centers, and prognosis depends on underlying condition and severity of pH. So early recognition and multidisciplinary management in expert pH centers are essential for optimal outcome in this subset. So there is no one-size-fits-all therapy in group 5. The underlying disease dictates the management. So to conclude, when we look in all the groups, the group 1, 3, 4, 5, they all are the precapillary pH, where the mean pulmonary artery pressure is more than 20, pulmonary artery wedge pressure is less than equal to 15, and pulmonary vascular resistance is more than 2 Woods unit. While in the group 2, which is due to the left heart disease, there is the pulmonary artery wedge pressure, which is more than 15. So pH is not a single disease, but is a final common pathway of the multiple conditions. Hemodynamics, including all the parameters, helps classify and guides the management. Treat the cause, not just the pressure. Right heart catheterization is essential for accurate diagnosis and subclassification. And in certain centers where this is not available, we should go for MR, cardiac MR. So early recognition and disease-specific management improves the outcome. So we will just have a self-scrutiny that what we learned from this. So what is the current hemodynamic definition of pulmonary hypertension? It's very easy. Right. So which of the following parameters is required to define pre-capillary pulmonary hypertension? Right. Which pulmonary hypertension group is potentially curable with pulmonary end arterectomy? Right. A patient has mean pulmonary artery pressure 28, wedge pressure 18, and PVR 4 Wood unit. This patient has, exactly. Which hemodynamic profile represents isolated post-capillary pulmonary hypertension? Right. A 45-year-old woman with systemic sclerosis undergoes right heart catheterization. Mean pulmonary artery pressure 24, wedge pressure 10, and PVR is 2.5. What is the correct interpretation? Right. A male patient who presented, so I hope this is done. So thank you. An early recognition and timely intervention will lead to better lives. And I hope my presentation was good because everyone has given the right answer. Thank you so much.
Thank you, Dr. Nitin, for elaborating about the current definition and classification of pH. Now, I would like to invite Dr. M.K. Gupta, Director, Aach Hospital, to deliver lecture on screening and evaluation of suspected cases of pH. Dr. M.K. Gupta, please.
Good morning to everyone, and thanks to Dr. KK and team to invite me here. Today my presentation is on screening and evaluation of a suspected case of pulmonary hypertension. Dr. Nitin have already discussed about the definition and classification of the pH. In the pH is not a rare disease. It is the late diagnosis disease, basically. In our practice, we miss our diagnosis of pH. So, today our need to how to suspect a patient of the pH, to when to suspect or to whom to suspect. So, patient who have progressive exertional dyspnea, the most common our misdiagnosed, misattribute condition. The patient who is the exertion progressive dyspnea, we should thought about the pH. But in our practice, we saw that is the disconditioned condition. So we missed our diagnosis. If patient have fatigue and exertional chest pain, near syncope or syncope on exertion, lower limb edema and palpitation, or the most important, the disproportionate dyspnea versus spirometry. Our spirometry is normal, but patient has the severe dyspnea or disproportionate dyspnea, we should think about the pH. These are the common symptoms where we can suspect the patient may have a PH. There is some high-risk group population where the PH is most common. The systemic sclerosis ILD group, the CTD-related ILD, especially the systemic sclerosis, where the limited systemic sclerosis have the more chance of the PH than the diffuse systemic sclerosis. So any patient who have systemic sclerosis related ILD or who have the systemic sclerosis, we have to analyze, we have to screen for the PH. There the detect algorithm where the 6 variable is there. If FEVC DLC ratio, anti-proBNP, serum uric acid level, anti-centromere antibody, telangiectasis, and right heart strain on ECG. These are the 6 variables. If they are present, then we should step 2 where the right heart catheterization is the advice. So if the patient of the systemic sclerosis and have these of the symptom, we have suspect the PH. Because 8 to 12% of patient of systemic sclerosis develop PH. Second is the post-PE patient who is the acute PE. After the 3 to 6 months have the symptoms of the existing dyspnea, we should suspect about the PH. HIV, portal hypertension, and CHD patient also have more suspected to the PH. So these type of the patient, we should suspect about the PH, and we should analyze our patient according to the guideline. History and physical examination are very important to suspect the PH patient. The key history is the dyspnea onset and prior pulmonary embolism or DVT history. If patient have the dyspnea, especially in the exertion, we should calculate the, ask about the duration, about the symptom. If the patient is not responding to our bronchodilator therapy and our diagnosis is not fit in character, then we should think about the PH. If patient is treated for the PE and after the 3 to 6 months he have the symptoms of the dyspnea, we should think about the PH. Second, CTD related symptom. Patient who has the Raynaud phenomena, Sika syndrome, joint swelling, and photosensitivity, oral ulcers. This type of the CTD symptom is patient have, we should record in our history and suspect about the PH patient of the dyspnea. Respiratory history, patient is suffering from the COPD, ILD, and chronic asthma. Drug and toxin exposure. Some drugs may cause the PH, especially the destinanib used in the CLL, amphetamine, interferon. These are the drugs, if patient taking for a long time, we can suspect about the PH. So these are the point where in our history we should record and we can suspect about the PH. Second, the physical examination. If the patient have the loud P2, right ventricle heave, TR murmur, and these are the symptoms. If they are the signs, if they are present during the examination, we can show that there is the right heart failure or there is the pulmonary hypertension. So we should proceed further investigation. If there is the CTD symptom like sclerotomy, telangiectasia, calcinosis, malar rash, digital clubbing, and persistent cyanosis there, we should think about the PH and analyze for the further. So these are the basic symptoms and signs where the PH may be present. So our initial evaluation is the non-invasive, where the ECG, X-ray, biomarkers, PFT, and 6-minute test will add to our diagnosis. The simple test ECG, if there is the right deviation, right ventral block, P pulmonale is there, if the ECG shows the right ventricle strength pattern, we can think about the PH. Chest X-ray, simple is the pulmonary artery diameter, especially by the HRCT, if the diameter is more than 29 mm, we can think about the PH is there. BNP and anti-proBNP, if the value is more than 300, we should work up for the pH. Anti-proBNP very specific and test for the right ventricle strain and right heart failure. If there are anti-proBNP more than 300, we should think about the pH. If the anti-proBNP less than 300, the risk of the pH is very low. But if the more than 1400, the risk is very high. So BNP and pro-BNP, pro-anti-BNP is the very simple and important test to rule out pH in our COPD ILD patient or pH patient. Pulmonary function test, DLC or 6-minute walk test. We do in our routine practice. If the patient of the pulmonary hypertension, group 1, if the spirometry is normal, but DLCO is decreased, we should think about the pH first. In pH patient, the spirometry may be normal, but DLCO is very low. The TLC is normal, DLCO is very low. 6-minute walk test is very sensitive and prognostic test for the pH patient. If the distance less than 300, that prognosis is very, very poor. So these are the simple tests, PFT, DLCO, and 6-minute, where we can judge the patient may be suffering from pH, or we can also judge the prognosis. If the 6-minute walk test less than 300-meter distance in 6 minutes, the prognosis is very poor. So PFT, DLCO, and 6-minute we should do in our practice daily, and we should think about the pH also. 2D echo. 2D echo is the cornerstone of the pH screening, but is not a confirmatory test. It tells about the probability of the pH. The confirmatory test is the right heart catheterization. So in pH, we have the 3 steps. First is we also discuss about the suspicion, then the probability detection by the 2D echo, and confirmation by the right heart catheterization. It is non-invasive, non-radiation, real-time right ventricle and left ventricle assessment, and identify the structural causes. So 2D echo is the very important and very simple test in our practice to rule out the pH. In 2D echo, we can discuss in our workshop detail, but in 2D echo, by 2D echo, we can judge the probability. If the pH chance is low, intermediate, or high. If the TR velocity is less than 2.8 meter per second, then the probability of pH is low. If it is 2.9 to 3.4, the chances of pH is intermediate. Or if the more than 3.4 meter per second, the probability of pH is very high. So TR velocity we tell that what is the probability of pH in our patient. Second parameter is the TEPSE. If is less than 17 mm, it shows the right ventricle exclusion. If this is less than 17 mm, the chances of the pH is very high. Ratio of RV and LV ratio is more than 1. Means the right ventricle hypertrophy is greater than the left ventricular. The diameter of the right ventricle is high. There may be sign of the right ventricle failure, or there is the chance of the pH. D-shape, left ventricle, if the shape of the left ventricle become the D-shape, the chances of the pH is high. So these are the parameter in 2D echo we can suspect of the pH, but the confirmation is the right heart catheterization. These are the additional echocardiogram sign where the pH probability is high. If the PA dilatation is more than 25, if there is the inferior vena cava dilatation is more than 21 mm, right atrial enlargement more than 18 centimeter, pericardial effusion, very important sign. If the pericardial effusion of the systemic sclerosis patient, the chances of the pH very high. This show there is the right heart failure. So if any patient of your systemic sclerosis related ILD or systemic sclerosis, if there is the pericardial effusion is there are chances of the pH is very high. So these are the additional echo sign where the pH is probability is very high. Third is the identify the cause. if we suspect and then we probability is the pH high, or what is the cause? These are the 5 group of pH, but in every group have the other cause. So cause identification is very important. So in as a pulmonologist, we are very easy to diagnose our patient related to the pH group 3, the HRCT and CT pulmonary angio. The HRCT tell about the ILD, patient may be suffering from the ILD, or there is the some COPD patient we can also identify by our imaging. Dr. Megha Saini will tell about the how to interpret the imaging pH, how to identify the pH in the by the imaging. So HRCT tell about the cause the patient may suffering from the parenchymal disease, or some pH specific finding like the diameter. Enlarged PA diameter is more than 29 mm, the sensitivity 69% and the specificity the 92% of the pH. PA pulmonary artery and aorta ratio is more than 1, the chances of the pH is very high. So these are the 2 findings where we can suspect the patient may be suffering from the pH. So HRCT is very important tool to diagnose our patient who is suffering from the lung disease and have the pH together. CT pulmonary angio to identify the structural diseases, and it also identify the pulmonary embolism and the CTPA. So in patient who is suffering from the pulmonary embolism or chronic thromboembolism, we can advise the CT pulmonary angio, or we can easily diagnose our patient. The sensitivity is 96 to 100% and specificity to 95 to 98% in CTPH patient. VQ scan, sleep study, and autoimmune profile. There is also the additional testing where we can suspect our patient, we can identify the cause of the patient. The VQ scan is the gold standard for the CTEPH patient. Sometimes the CTPA is normal in the CTPH patient, but the VQ scan is the gold standard test for the patient who is suffering from the CTPH. Sleep study, if patient have symptom of the obstructive sleep apnea related and have the pH, so sleep study is the important tool to diagnose our obstructive sleep apnea, and then we can suspect the patient pH is due to the sleep apnea. So autoimmune profile, we all know the patient who is suffering from the systemic sclerosis have a chance more to pH, and other our ILD patient like SLE, polymyositis, these are the diagnosed by the autoimmune profile. So in routinely, we will advise the ANA by IFA and autoimmune profile to diagnose if patient suffering from the autoimmune disease and related to the pH. Confirming the diagnosis, right heart catheterization is the confirmatory test for the pH. They have the detailed lecture on the right heart catheterization by Dr. Neeraj. But in right heart catheterization, there is a gold standard because it is assessed and what is the basic defect, and after the right hand catheterization, we can start the anti-pulmonary hypertension therapy. Otherwise, we should not start of the pH therapy without the right heart catheterization. So right heart catheterization is the very important tool, and we should confirm first the pH by the right heart catheterization and then start the anti-pulmonary hypertension therapy. So it is a stepwise evaluation of the algorithm of suspected pH. First we suspicious, what is the patient have the history. Then our initial workup by the ECG, X-ray, ProBNP, 6-minute test, echocardiography, very important tool. If there is a probability high, then we go for the right heart catheterization and confirm our diagnosis. So this is the basic algorithm of the patient who is suspect to pH. These are the red flag sign where we should alert about our patient who have the exertion dyspnea disproportional to spirometry. We think about the pH. If there is a loud P2, right ventricle heave and TR murmur. If main pulmonary artery diameter is more than 29 mm on our CT scan. Anti-pro-BNP more than 300 pg per ml, we should think about the pulmonary. These are the red flag signs we should keep in our mind when we see the patient who is suffering from the PH. So my take-home message is patient, first we suspect the pH early. If we suspect early pH, we can diagnose early, we can treat early, and then the complication may be low. So if you should suspect a patient have the history and sign of the pH, and then we further work up our patient. Echo is the gatekeeper. Echo is the very important tool, easy to perform, and it is non-invasive, simple to diagnose our patient of the pH. We can, there is a probability this patient may be have high probability or low probability. Never skip right head catheterization. Right head catheterization is the main confirmatory test, and without the confirmation of by the right head catheterization, we should not start the pH therapy. As well exclude CT, pH because it is the only disease that we can cure by the surgery or method. Risk, you should know about the specific trigger. If patient have the any CTD or some ILD, we should confirm first that and treat the cause, and we can treat our patient suffering from the PH. Thank you very much.
Thank you, Dr. M.K. Gupta, sir. You nicely presented the how to recognize the early pH and how to further evaluation for early diagnostic methods and advanced workups. Now I invite Dr. Nitin Jain to answer the questions of the audiences.
Any questions?
Good morning, sir. I have a question. Like in patients of CTD ILD, we commonly encounter pulmonary hypertension. In that case, whether that's a group 1 or a group 3, how to differentiate whether it's a group 1 or group 3?
Repeat your question.
My question is, in CTD ILD patients, we usually encounter pulmonary hypertension. Now, that pulmonary hypertension is because of the group 3 etiology or because of the group 1, like CTD itself can cause a pulmonary hypertension. Then in which category should we put that patients?
So this is a very interesting question. It's possibly the toughest situation in pulmonary hypertension. So patients with CTD can have kind of IPH kind of a thing, and patient can have a lung disease, ILD, and that can also produce PH. Clear, critically good pulmonary function test assessment, a good radiological assessment by expert radiologist, and a right heart catheterization and an echocardiography by a cardiologist is a must. So these three things are important. So now the critical question is whether the pulmonary artery hypertension is proportional to the lung disease, lung destruction or lung disease is the critical question. That also needs an ABG also. So you do everything, and then this is what has to be matched like. So you match the pulmonary hypertension, the degree of pulmonary hypertension and the right heart problems to the lung disease. If that is matching, that's I think with experience you can all make out, like it's not rocket science. So if ILD is not extensive, pH is significant, you are going to put the patient onto this group, classical group A, group 1. So if it is significant lung disease, lung destruction is there, improvement with oxygen is there, and in such a patient, the cardiologist should also be sounded to do an oxygen testing in the cath lab. So how much oxygen response is there, how much hypoxia gets relieved, that also can be tested in the cath lab, how much reduction in PVR happens after oxygen also can be tested there. So all these things you can make up a mind in at least 90% of the patients, clear cut you can make up a mind this is because of CTD and this is because of possibly ILD. So then if not, for the rest of the 10% where there is a benefit of doubt, don't start dual therapy, start with single therapy and closely observe the findings, closely monitor the findings and then go ahead.
Thank you, sir.
So great question. You heard the cardiologist perspectives. Let me put the pulmonologist perspective. How do we evaluate those cases? If the patient of CTD ILD goes on to develop PH, And if the lung function, FVC, is above 40%, the first thing that we see is the FVC by DLCO ratio. If your FVC by DLCO ratio is more than 1.6, it is an indirect indicator of the pulmonary vascular involvement, that is group 1. But it loses its sensitivity when your FVC goes below 40%. So when it goes below 40%, then the real dilemma starts, whether it is a group 1 or group 3. In those cases, we have some clinical indicators for the risk factors. The most common CTD associated with both the ILD and higher incidence of PAH are systemic sclerosis and mixed connective tissue disorders. If these patients do have digital vasculopathy, for example, if they have nail fold capillaroscopy abnormality, or they have Raynaud's, or they have digital ulceration, or they have certain antibodies highly associated with PAH, then I think these are the risk factors which suggest that these patients are probably having additional pulmonary vascular involvement, that is group 1. I think this is how we do it in our clinical practice. Thank you.
To have a group discussion among the radiologist,
Yes, and MDT.
Cardiologist and the pulmonologist, along with the cardiologist, before you take a decision in such patients. I think we at times encounter at least 1 or 2 patients like this in every year, where there is a confusion, and ultimately if the confusion is not clear, it's better to treat the single drug and see the response.
Pulmonary hypertension itself is a multidisciplinary approach. So we should, rightly said by you, that we should involve everyone for this in the cases, or specifically in the cases of the dilemma.
Any other questions? I think we are running out of the time and we should conclude this session. Thank you, Dr. Nitin. Thank you, Dr. MK.
Thank you so much for the great session. So to start the session too, I would like to invite to chair the session Dr. S.K. Madhukar, Dr. Lokesh Maan, Dr. Kush Kumar Bhagat, and Dr. Vinod Sharma.
Good morning to all. I would like to invite Dr. Hemant Chaturvedi. He will talk on echocardiography as a screening tool in pulmonary hypertension. Welcome.
So good morning, all of you. So after detailed definition about the pulmonary artery hypertension classification, and there is a detailed algorithm of the screening of all the tests we are diagnosing for the pulmonary artery hypertension. Now I am just focusing on the echocardiography as a screening tool to diagnose and evaluation of the pulmonary artery hypertension. Yeah, okay. So as an introduction, as you all know about the definition, I am just briefing the definition about that. The pulmonary hypertension we are diagnosing as a hemodynamic and the pathophysiological condition where there is an increase in the mean pulmonary artery pressure is more than or equal to the 20 millimeter of mercury. Previously, it was the cutoff for the 25 millimeter of the mercury, but in 2022 ESC ERS guidelines, the World Symposium, it has been cut down to the 20. So now the new definition is the mean pulmonary artery pressure is more than or equal to the 20 millimeter of the mercury at the rest, and PVR, that is a pulmonary vascular resistance, that is equal more than 2 Woods units. It is assessed by the right heart catheterization. Next slide, please. Okay. So nothing to further going for this slide, as classification has already been discussed. So now coming to the transthoracic echocardiography, it is a non-invasive and a widely available tool and very easily doable and easily available to all the hospitals and even in the peripheral centers also nowadays. And comparing with the gold standard right heart catheterization, it has a sensitivity of around the 90% and the specificity around 70%. So it could be used as one of the important tool to diagnose the pulmonary artery hypertension, and it can assess the contribute to the left sided also. So not only for the pulmonary artery and the right heart, but simultaneously you can also diagnose the diseases of the left heart of the disease also, and the diastolic dysfunction, valve functions, and the congenital lesions. And it's quantitate the PA pressures also, and prognosis also can be defined by the transthoracic echocardiography. Now coming to the what are the signs, and the first I am going point by point, and I am just touching the basics so that you can't confuse, and there is an indirect 2D echo signs in the pulmonary hypertension. So first thing, that is the right atrium. So right heart and now the right atrium. So I am going just slide by slide and the point by point how to diagnose and how to suspect that the patient may have a pulmonary artery hypertension. So in this slide, you can see there is a right atrium. It's a four apical four chamber, and the right atrium, the major and the minor dimensions. So the major dimension is cutoff value is less than 54 millimeter, and the minor dimension is at 42 millimeter. These are the cutoff values. More than this, then suggestive of the right atrium dilatation, and the RA area, that is the right atrial area, that is less than 19 square centimeter. So these are the cutoff value. Above these cutoff value suggested or suspected the pulmonary artery hypertension. Next thing is the right ventricle morphology. In the right ventricle morphology, we are you can see on your left side of the slide, there are the two types of the right ventricle. One is the normally structurally normal, and another is a abnormal. And you can see, so these are the cutoff values that the basal part of the right ventricle is more than 42 millimeter. If the mid level is more than 35 millimeter and the longitudinal is more than 85 millimeter. So these are the cutoff values that suggesting of the pulmonary artery hypertension. Again, in the right side of your slide, you can see there is a right ventricle free wall thickness. If it is more than 5 millimeter, this is again the cutoff value to suspect or suggest the pulmonary artery hypertension. Now coming to the parasternal long axis view. In the parasternal long axis view, that is a RVOT dilatation. So in the plex view, if there is a more than 33 millimeter, and in the short axis view, if the RVOT proximal is more than 34 millimeter, and in the distal part of the RVOT, if it is more than 29 millimeter, then that is suggestive of or suspecting the pulmonary artery hypertension. Now coming to the LV eccentricity index, this is the degree of the distortion of the LV and the IVS arising due to the increased pressure in the RV during the diastole and the systole. So you can see on the left side of the side, in the pressure overload or the volume overload. In both the situations, LV can be D-shaped LV. So in the pressure overload, you can see there is a end systole level, there is a septal flattening here seen, and in the volume overload, there is in the end diastole. So how to differentiate between this is either it is a pressure overload or the volume overload. In the volume overload, there is the septal flattening seen in the end diastole, and in the pressure overload, the septum flattening is seen in the end systole. Again, in the LV eccentricity index, there is a ratio between the AP diameter and the septolateral diameter. So, if it is more than 1, then it is suggestive of the RV overload and suggesting of the pulmonary hypertension. Now, coming to the pressure management in the pressure measurement in the pulmonary artery hypertension. So, one of the most basic thing that in the echocardiography, the first and foremost thing is the TR-Z gradient. When we put our cursor on the tricuspid valve, and put the continuous wave, and that we see this type of parabola, and the pulmonary artery pressure we can see by the TR peak velocity. So what are the, this is the basic formula of the PR velocity, that is that RVSP is a 4V square plus RP, where V is a peak TR V maximum. So peak TR velocity is the here representing the V, the velocity. So PASP is equal to the RVSP if there is a no PS. So there is, if there is no pulmonary stenosis, it equals the PASP and the RVSP is the equals. And now coming to the right atrial pressure. So the right atrial pressure we are defining by the help of the IVC estimation. So by the IVC measurement, here you can see that we took the subcostal view, and in the subcostal view we see the IVC, and we see the IVC proximal to the hepatic vein. And now at the end expiratory method, we take after asking the patient to take a brief sniff, and then we see there is a collapsibility. The previous slide, please. Yeah. So if the IVC diameter is less than 21 millimeter and it's fully collapsible, that is more than 50%, then the estimated right atrial pressure would be around 3. Previously it was around 0 to 5, the range was there, but now there are the 3 values only, 3, 8 and 15. So if the IVC is dilated, if the IVC is normal size, less than 21 millimeter and fully collapsible, then it is 3. Now the intermediate condition is if the IVC is the normal size, but there is a decrease collapsibility, that is less than 50% on the inspiration, then it is around 8 millimeter of the mercury. Again, the second scenario is if the IVC is dilated but fully collapsible, again it's the 8 millimeter of mercury, but now the condition is worse, like there is a IVC plethora, that is IVC is fully dilated and less than 50% of inspiratory collapse, then it is said to be 15 millimeter of the mercury. So here we can identify the RA pressure, and then by this adding into the 4V square, we can get your pulmonary artery systolic pressure. In the patient where there is a mechanical ventilator patient on the using the positive pressure, the IVC collapse cannot be used to reliably estimate the RA pressure. Then we should have then the CVP line. And in the same group, if there is a IVC is less than 10 millimeter of mercury, then it is suggestive of the RAP it's less than 10 millimeter of mercury. Now coming to the PR segment, after the TR velocity, now coming to the pulmonary regurgitation signal. In short axis view, when we are going in the pulmonary parasternal short axis view, when we are going towards pulmonary valve, and we put our cursor and we see there is a pulmonary regurgitation, there is a mild PR or the significant PR, and we are going for the pulse wave. So where PR velocity refers to the pressure gradient between the pulmonary artery and the right ventricular during diastole. So you can see on your slide there is an end diastole PR velocity, that is one of the important thing, and the estimation of the pulmonary artery diastole pressure from the peak end diastolic velocity. So the PADP, that is the pulmonary artery diastole pressure, is equal to 4V square. Here V is the pulmonary artery and diastole velocity, and plus RVEDP. In the absence of the tricuspid stenosis, again RVEDP is equal to the right atrial pressure. So the PADP is equal to 4V square plus RAP. And estimation of the mean pulmonary artery pressure from the peak PR velocity. So mean pulmonary artery pressure is equal to 4V square per V, plus RAP. So method has been validated against the gold standard right heart catheterization. So it is one of the important tool to get the mean artery pressure. One of the important formula and the most common used formula for the mean pulmonary artery pressure is the 2/3 the pulmonary artery diastole pressure plus 1/3 by the pulmonary artery systolic pressure. The pulmonary artery diastole pressure, it is measured as already seen by the measured by the end diastole PR velocity, and systolic pressure by the TR peak velocity. Now coming to the RVOT acceleration time. So what is the acceleration time? It's a time interval between the onset of the flow to the peak systolic flow. As the PA pressure increases, there is a resistance to the blood flow from the RV into the PA increases, and resulting in the shortening of the RVOT acceleration time. So in RVOT acceleration time, in your left hand side, you can see there is a normal RVOT acceleration time. So, and on your right side of screen, you can see there is a decrease in the acceleration time, and simultaneously there is a peak, there is a notch in the acceleration time in the mid systole. So pulmonary hypertension, there is a rapid rise of the peak, shorter acceleration time, and the mesosystolic notching also seen. Whenever we see on the RVOT acceleration time assessment, there is a reduced acceleration time and there is a notching in the mid systole, then suspect about the pulmonary artery hypertension. So interpretation, the value of the RVOT acceleration time, if it is more than 130 millisecond, then it is said to be normal. And in anything that is less than 100 millisecond, it is suspecting of the pulmonary artery hypertension. And these are the two formulas for the mean pulmonary artery pressure when there is a RVOT is less than 120 millisecond and when there is a more than 120 milliseconds. Now coming to the estimation of the mean pulmonary artery pressure, another method is by the TR-VTI. So by the we put in the 4-chamber views and we put the color Doppler on the TR jet, and the mean pressure gradient is measured from the TR-VTI. We are tracing the TR signal, and the mean pressure is equal to mean PA pressure plus RAP. So it's one of the most common and most easy method. Just you have to trace out, take a mean pressure and plus adding the right atrial pressure. So these are all the methods and formulas I have already shown you in the previous slides, and these are the common formulas for the estimation of the mean pulmonary artery pressures. So by these all formulas you can use any one of these to get the mean pulmonary artery pressures. Some important findings like the right ventricular isovolumetric relaxation time, that is called as IVRT. Then we are putting the just TDI signal, the tissue Doppler, on the lateral annulus of the tricuspid valve, and we measured from the offset of the S dash view and to the onset of the E dash view. So here you can see on your slide there is a S dash view that is the systole waves. So IVRT, just the cutoff values are, I am showing this, you are this the cutoff values. The IVRT is more than 75 millisecond, it is a reliably predict the pulmonary artery hypertension. If it is less than 40 millisecond, it is a high negative predictive value. So you can betterly say that this patient does not have any pulmonary artery hypertension and there is no chance to have any pulmonary artery hypertension. So there is a high negative predictive value if the IVRT is less than 40 milliseconds. Now coming to the pulmonary vascular resistance calculation. So this is the one of the important thing that by a short axis view and by the apical 4-chamber view, these two views you can get your pulmonary vascular resistance. This is the formula of the pulmonary vascular resistance, that there is a 10 multiplied by peak TR velocity divided by the RVOT VTI plus 0.16. So if it is more than 2 Wood units, then it is suggestive of the pulmonary artery hypertension. And in some cases like in the ASD, and where we need to get whether to QPQS ratios and PVR, whether to patient get benefited by the operation or not, the surgery or not, due to the presence of the pulmonary artery hypertension, we need to get the PVR. So you can get non-invasively by the help of the echocardiography PVR, and this is as much as reliable by the right heart catheterization. So one of the important thing about the PVR is that it can differentiate between the pre-capillary and the post-capillary pulmonary artery hypertension. In the pre-capillary phase there is a high PVR, and in the post-capillary phase there is a normal PVR. So this is one of the important differentiating point also. Now coming to the RV functional assessment. In RV functional assessment, better to get always and always the RV function as RV fractional area changes by the FSE method. So you can see that there are the 3 slides on this slide. There are the 3 views, and the first one there is a fractional area change is around 60%. You can see there is a in diastole and in the systole. We just trace out the RV area, and by the end diastole area minus end systole area divided by the end diastole area multiplied by 100. This is just as simple, and we measure about the RV systolic function. So again the cutoff value is more than 35%. Anything less than 35%, it is suggestive of the RV functional, or decrease the RV function or the RV dysfunction. One of the important thing, that is the 3D RVEF. Though by the 3D method we show in your workshop that how can we easily assessment of the RVEF assessment, and the cutoff value is again is the more than 45%. That the T index and the TR measured by the PASP. So T index is the Doppler derived markers of both the systolic and the diastolic ventricular function. So the T index is the IVRT relaxation time and IV isovolumetric contraction time divided by the ejection time. So again, the cutoff value is the more than 0.4 by the pulse wave Doppler and more than 0.55 by the tissue Doppler. So these are the indirect signs, and one of the important thing for the RV functional assessment, that is a TAPSE, that is a tricuspid annular plane systolic excursion, or that is also called as TAM, that is a tricuspid annular motion. So there is a longitudinal motion of the tricuspid annulus, and better the longitudinal motion, better the RV function assessment. The reflection of the movement of the base to apex and shortening of the RV in the systole. It is derived by the 4-chamber view, and again the cutoff value is 16. We took 16, less than 16 is a higher mortality and the significant RV dysfunction. One important thing is S-dash wave. So S-dash wave in the TDI, if it is less than 10 centimeter per second, it is impaired RV function. And the strain imaging again, we show you in our workshop. It is very important.
Please conclude your talk.
Yeah. So strain is, if it is more than positive to the minus 19%, it is indicated the RV dysfunction. So one important slide, this is in the PA patient, the presence of the VSD and the PDA. So in the VSD and PDA, with the VSD with the high velocity, then there is no pulmonary hypertension. As much as the VSD size is larger, then there is a suggestive pulmonary hypertension similar to the PDA. My last slide is, this is the algorithm about the screening the patient with a suspected pulmonary hypertension. So just by all of these things, we can see in this algorithm, we are going one by one by the right heart catheterization, the right heart measurement, the right atrium, right ventricle, the mean PA pressures, and the TR velocities, IVRT, S- waves, TAPSE, all these things make the pulmonary hypertension confirmation and helps, and then further confirmation by the right heart catheterization. Thank you.
Thank you, Aman sir, for a nice talk on echocardiography as a screening tool in pulmonary hypertension. Any questions? We will take questions after the session. Now we will invite Dr. Meghaseni ma'am. She will speak on emerging role of imaging in pulmonary arterial hypertension.
So good morning, everybody. First of all, I would like to thank Dr. K K Sharma, sir, for the invite. Thank you so much, sir. We'll be talking about the imaging in pulmonary arterial hypertension. So now, as we all know about the definition, not be repeating again, but on this slide, I would like to emphasize that we should not interchangeably use PH and PAH. PH is basically a condition which is caused by multiple diseases. However, PAH specifically occurs when the vessel wall is being involved. There occurs the thickening of the vessel wall along with the vessel wall hypertrophy, leading to the increased pressure. The groups we have already discussed, the WHO classification, again, we have already discussed, so I'll just skip this slide, just emphasizing in this slide that group 2 and group 3 are the most commonest one. Now, when the patient comes to an OPD, the first imaging modalities which are being subjected are the chest X-ray and the echocardiography. Now, in chest X-ray, what we can see is the pulmonary artery dilatation, which is being said on the X-ray when there is a tangential lining is being drawn through the aortic knuckle and the left cardiac border. And if the pulmonary trunk is lying on to the lateral aspect of that particular line, we say it as a dilated pulmonary artery. We can see the peripheral pruning of the vessels along with the cardiomegaly and elevated left cardiac apex, which occurs when there is a significant dilatation of the right ventricle. So echo already we have gone through, will be talking about much on this. Then the next imaging modalities come out to be the CT chest and CT pulmonary angio. So now CT chest is important as we can evaluate the pathologies of the lung parenchyma, which are grouped in group 3. So we can evaluate those, as we can see in the last image, that this is a case of UIP where significant honeycombing is being there. And there was one question, so radiologically, one question which was saying which group we should keep in. Radiologically, it is stated when there is a significant amount of fibrosis or emphysema on HRCT and no other causes of pulmonary hypertension, you can group that in group 3. However, if there are minimal changes which actually do not classify the cause of the pulmonary hypertension, we will be taking them in group 1. The other pulmonology findings which we can see could be due to pulmonary arterial hypertension itself in the form of curly B lines. These are the interlobular, smooth interlobular septal thickening. We can see fine ground glass opacities, again classically being seen in PAH. We can see the areas of ground glass opacities predominantly in the central part of the lung, giving the bat wing appearance. We can find pleural effusion as well. So now in pulmonary angiography, ideally when a patient is subjected for pulmonary angiography, specifically for pulmonary hypertension, I would like to emphasize that not a single go of contrast should be done. Ideally, we should repeat. We should have a second repeat of the contrast as well. Now, that is because in chronic cases of pulmonary embolism, there is a secondary collateral circulation which is being established by the hypertrophy of the bronchial artery. So if we see a hypertrophied bronchial artery as well in the second go, it will suggest the chronicity of the embolism if it is present. Now, in this particular slide, we can see that when we will evaluate initially, we will have to define whether the pulmonary arterial hypertension or pulmonary hypertension is there or not in the form of dilated pulmonary artery to more than 3 centimeters and pulmonary artery to aorta ratio of more than 1. We can find the dilated right atria. We can find the septum, whether it is being central or bowing towards the left ventricle, and it is defined if the angle of the interventricular septum on the short axis view is more than 140 degrees, then we should think of increased overload in the right ventricle. In chronic cases, we can also see the free wall hypertrophy of the right ventricle, which is assessed at the level of right ventricular outflow tract. And if it is more than 6 millimeters, it suggests chronically increased pressure. Other than that, we can also see the reflux of the contrast in the, So we can also see reflux of the contrast in the hepatic veins and the IVC, along with the dilated IVC and hepatic veins in cases of tricuspid regurgitation, which occurs when there is a significant enlargement of the right ventricle. So after we have diagnosed on CT angio that yes, pulmonary hypertension element is there, we need to look out for the pulmonary and the cardiac causes, if at all we can see in the angiography. So on this particular slide, we can see different type of the congenital anomalies which can be found incidentally or may be known through the echo as well. So the first image is of PDA, where we can see a clear communication between the aorta and the dilated pulmonary artery. That was a case of PDA. Here we can see a clear septal defect between the atria. So that was a case of ASD. Now where the CT supersedes over echo is diagnosis of such kind of the anomaly. So that was a case of PAPVR or PAPVC, where we can see the pulmonary vein is not actually communicating with the left atria, it is communicating with the SVC. Again, the certain images and certain diseases where we can rule out the left-sided heart disease. So the first image is of dilated cardiomyopathy. We can clearly see a dilated heart with relatively thickened left ventricular wall. And another case, there is a globular increase in the left ventricular wall size. Left ventricular hypertrophy is there. So that was a case of hypertrophic cardiomyopathy. Another case where we can see a significant pericardial thickening along with the calcification, which can lead to diastolic dysfunction. or the valvular diseases. So here is a magnified image of the tricuspid valve of the aorta, which is calcified. So all these pathologies, if found on CT angio, can give us a clue that it is a left-sided heart disease leading to pulmonary hypertension. Now, talking about chronic pulmonary thromboembolism induced pulmonary hypertension, first of all, we should differentiate whether it is an acute embolism or a chronic embolism. Now, why it is important? Because the treatment modality is a little different, as well as in cases of acute embolism, there can be a transient increase in the pulmonary artery pressure, as well as a dilated right ventra, which can reduce or recover once the embolus is gone off. So in acute embolism, the diameter of the pulmonary vessel is going to increase and the thrombus is going to make an acute angle with the vessel wall. However, in chronic embolism, we can see the reduced diameter of the pulmonary vessel and the thrombus is going to make an obtuse angle with the vessel wall and the webs can be seen. The chronicity of the embolism can also be judged retrospectively by seeing the thickened ventricular wall. So right ventricular hypertrophy in cases of embolism will again suggest the chronicity of the disease. So now these are the images where we can see a right ventricular hypertrophy along with the web-like areas within the right lower lobe pulmonary artery. These are the magnified images showing the web and an acute angle, obtuse angle of the thrombus with the vessel wall. So as I spoke earlier, in chronic cases, we can see the bronchial artery hypertrophy. So here we can see a dilated bronchial artery as well in the case of chronic embolism. Talking about the lung parenchymal changes in cases of chronic embolism, we can see the mosaic perfusion. So these hypoattenuating areas are the areas of mosaic perfusion, and the vessel walls here are attenuated. However, the pulmonary artery and other segmental arteries are dilated. So basically these are the areas where the embolus is there in the tiny vessels, which is not being perceived eventually with the eye. So in such cases, ventilation perfusion scan comes into view. If there is a perfect match in the ventilation and the perfusion scan, it will suggest that it will diagnose that there is no chronic embolism. So basically it is the key to be done. So in cases of mismatch, we can see such kind of wedge-shaped perfusion defects. To extrapolate the same findings, now in CT we have dual energy CT lung perfusion imaging, where the iodine maps are being created in the post-contrast scan, and similarly we can also find the wedge-shaped perfusion defects. So here is a vessel with a central thrombus, and we are seeing a wedge-shaped perfusion defect. Now talking about the cardiac MRI can beautifully show all the morphological changes which were being seen on the CT in the form of the dilated pulmonary artery, dilated right ventra, atria. There could be the thickening of the free wall of the right ventricle. We can see the septum being deviated or straight. But here I would emphasize that we can little bit grade morphologically as well. So as in the lower images, the first image is the short axis view. We can clearly see a convex margin of the interventricular septum. So this is normal. When it gets straightened up, it signifies a mild increase in the right ventricular volume. However, if it is slightly deviated towards the left ventricle, but the left ventricular volume has not been compromised, it is moderate. And when there is a significant convexity with a reduction in the volume of the left ventricle, it would suggest a severe grade. We have many cine view images where we can assess for the shunts in cases of congenital heart diseases. So here are some of the images where we can see a site of ASD. And when seen in the cine mode, we can actually, define the direction of the flow. So here the jet is going towards the right side, or it was left to right shunt. We can also quantify them. We can calculate the QPQS in such cases, and in left to right shunt, when the QPQS is more than 1.5, the patient needs intervention. Now talking about the functional imaging, this is where it supersedes CT angiography. in MRI, we can evaluate the end diastolic and systolic volumes through which we can calculate, stroke volume, the stroke volume index, ejection fraction, tricuspid regurgitant volume, and the ratio of the right ventricle to the left ventricular dilatation, which all are important in grading as mild, moderate, and severe grades of the severity in MR. So finally, I would say that in cases of congenital heart diseases, we first need to know that whether the patient is in the compensated phase or a decompensated phase. So even if we are having the morphological findings, morphological changes of pulmonary hypertension, but the ejection fraction is being maintained, then it is a compensated state and the patient can go for the surgery. However, in the decompensated phase, we will see reducing ejection fraction and increasing right ventricular end diastolic volume, which suggests the contractile dysfunction of the right ventricle, and the medical management is being suggested in these patients. Also, we will see if that there is initially a left to right shunt, but then there occurs a shunt reversal. So these patients are basically not the proper candidates which would be of help, of benefit from the shunt surgeries. There are also other parameters where MR takes over, even echo, which include ventricular mass index. So when the right ventricular mass keeps on increasing in the follow-up studies, it will suggest a bad prognosis. When we can calculate ventricular mass index, which is more than 0.7, suggests significantly elevated right ventricular pressure. And we can also see for the pulmonary artery stiffness. So the pulmonary artery stiffness is being measured first in the systole and then in the diastole. So if the pulmonary area difference is less than 16%, it will suggest a bad prognosis. As well, if we see if the late gadolinium enhancement is being seen in the insertion sites of the interventricular septum, and if it exceeds up till the mid part of the septum, it has a worse prognosis. So basically, I have already elaborated the parameters which will define for the poor prognosis or the therapy failure. We'll just skip this. So final slide where we can say that the advantages of CT scan and CT angio are to define for the underlying lung parenchymal lesions, associated cardiac diseases. We can see through that, we can find for the congenital heart diseases, and extent of the pulmonary embolism can be given to the cardiothoracic surgeon, which is a guide for the treatment for them. So basically we gave a vascular map through which we will be helped for the treatment itself. In cardiac MRI, yes, we can do functional imaging, which are helpful in diagnosis of the treatment as well as the prognosis of the patient. Also, myocardial tissue characterization and pulmonary stiffness are certain things which are not being commonly practiced in other modalities, and if present can give us a clue that the patient can have a better survival or a poor survival. Thank you.
So excellent presentation, ma'am. So you are a radiologist or a chest physician? Radiologist.
I'm a radiologist.
Okay, fine. So we can have a short discussion on this imaging, and we can call, sir, you can come, Dr. Hemant, you can come. And any question from the audience? Yeah, please.
Is there any specific indication, or are you looking for anything?
See, practically speaking, if after listening to the lecture ahead, yes, all the functional parameters are being seen in echo as well, but the cardiac viability in the form of delayed enhancement, the fibrosis element cannot be defined on echo, and the pulmonary stiffness which I spoke about, these two poor prognostic features cannot be actually diagnosed on echo. But if you talk about the functional imaging, I think we should go for an echo.
I think I should put this question to the cardiologist. So should we routinely do cardiac MRI for the risk assessment of the patients before starting the treatment?
I think world over it is kind of becoming a kind of a standard of care now. all patients with PH who are undergoing group-wise therapy or going advanced therapies are all getting in their MRI repeatedly to assess function, because we all know that for cardiac function assessment, echo is suggestive, but right heart function, RV function, MRI is gold standard.
Yes.
For PH assessment, echo is suggestive. For that, the gold standard is cardiac catheterization. So now Western countries where there are advanced centers for PH, both cardiac catheterization repeated and MRI repeated is becoming standard of care. But in India, we don't have enough cardiac MRI which can be reported by so many cardiologists. If all patients with our IPH and Eisenmenger start getting their MRI done, we don't have the capacity and the low resources there. Currently, what we are relying on, most importantly, MRI is a must or mandatory when you have to decide between whether the patient undergoes a cardiac transplant versus pulmonary heart and lung transplant. So that's a very critical area where MRI plays an important role in deciding whether we can get away with a lung transplant or you just mandatorily need a heart-lung transplantation. That is something that absolutely MRI is mandatory. Rest of the places, wherever you can get it done, it's absolutely essential to get it done.
Sir, does it make a difference in the categorization of risk if we take the MRI out of the algorithm?
So only problem here is that where in the Western countries where they are using MRIs, like for example, when do they want to start beyond dual therapy? Whether they want to start sotatercept today or the Prosta analogs, when they want to start, that is where they are using MRI. So when the clinical judgment, when you are doing the risk stratification, the judgment is borderline, there they are using cardiac catheterization and MRI to reclassify the patients. So for example, a patient is falling into borderline low risk or a borderline intermediate risk, there they are using MRI. If the MRI is showing RV dysfunction, they are actually aggressively treating them. So even though this is not a kind of established with evidence, that is where currently they are using MRI as well as cardiac catheterization, repeated cardiac catheterization.
Thank you, sir. Thank you.
Sorry, sir?
FAPI-PET, FAPI, fibroblast activating protein inhibitor, because wouldn't that be a better prognostic marker to assess tissue modeling in the arteries rather than doing a cardiac MRI? Correct. So what is the role of FAPI-PET vis-a-vis a cardiac MRI?
Currently, we have data for the various MRI parameters showing long-term outcome. So PET, there are some interesting changes shown, but they are not outcome-based data are not there. It is emerging. I think things will emerge as a parameter.
Markers, how the FAPI-PET tells us prognosis, probably in PH also as a surrogate.
I think people are working on it. Currently, MRI-based clear-cut cutoffs are there where, so for example, TAPSE below is associated with poor outcome. Such cutoffs are there in various MRI parameters. Such cutoffs are not there with currently PET. So regarding imaging, I want to add a few things. So how many of you are here cardiologists who do echo? Very few. Okay, mostly pulmonology. So important thing in echo is that we, as echocardiographers, we all want echo to be the gold standard for PH, but it is certainly not. And the important things, two important things that we have to understand in diagnosis and prognosis of PH in echo is, number one, it is terrible. The echocardiographers also do not understand. And we always look at TR velocity and say that is the gold standard. We look for whether it is 64 or 72 or 45. We always look upon that. That's pretty useless, because it is dependent on loading conditions. You change the loading condition, that number changes. So heart rate changes, that number changes. So that is why gold standard has always been cardiac catheterization. So it's very useful to do. The other important thing that is emerging in today's time is, so for every patient of PH that you see in younger patients, a lot of them are likely to associated with congenital heart disease associated PH. Like for example, Eisenmenger syndrome in this country is more common than IPH in the younger population. And in older population, the typical HPF, that is heart failure with preserved ejection fraction, which has a pulmonary hypertension phenotype, that is far more common than IPH in older patients. The group 1 PH in older patients. These two things everybody practicing PH should understand. So for that, what are you supposed to do? For that, the most important mandatory thing that every echocardiographer should do in a young patient is do a contrast echo. Saline agitated contrast. That saline agitated contrast will show the missed ASDs, the missed PDAs, and the missed VSDs, and AP window. These are the ones that are commonly missed in an adolescent coming with 20-year-old coming with PH, who is otherwise labeled as IPH. So contrast echo is a must. And contrast echo also helps in adult patients whom the TR velocity we are not able to get properly. If you don't get a TR or PR, most of the estimations of PH is theoretical. Practically, it is not useful. So you do contrast and then tiny little TR, you can get a very good jet. So contrast echo is very essential in both the groups. Other important thing that all echocardiography should keep in mind is the LA volume index in adult patients. So for example, IPH is a right-sided disease. There is no reason for LA to be large. So if the LA is large, that means this is a left heart disease associated PH, and more likely this is going to be a HPEF related PH than anything else. It's a very simple thing that everybody who's doing PH echocardiography should understand. There is no reason for IPH to have a larger LA. So that's about echo. So I'm sorry, I'm taking a bit of time. So one important question that I want to ask is, like, should we do, a patient is labeled as IPH. Are we okay to rule out with CTPH, CTPA, or should we mandatorily do VQ scan in all of them? It's a very important question, so everybody should be clear on that. Should we do both, or are we okay
Sorry,
with?
sir, didn't get the.
So we have a IPH, like everything looks like idiopathic PH, and we are referring to a radiologist for CT angiogram. So CT angiogram doesn't show CTPH. Are you okay to leave there, or should we do a VQ scan?
I believe every patient should undergo VQ scan.
Why? That is where the question is, like, everybody has to understand this. What you are saying is right.
Because 50% of the patients with CTEF won't have the history or overt history of embolic episode.
But CT is very good. Like, the radiologist will claim that CT
No,
is
sir,
very
for
good.
the terminal branches, CT is not
So
good.
there is a group 4 type of CTPH which could be missed by CT.
Yes.
So that is why I think in a high index of suspicion, as a routine, if you have VQ scan available, all the patients should undergo both, especially the younger patients where CTPH probability is high, or any thromboembolic complications are there and CT is not showing. Then also you have to get it done.
Ma'am, as a pulmonologist, lots of audience is pulmonologist. When a patient came with dyspnea, exertional dyspnea, then lots of pulmonologists order about the contrast CT or HRCT. If we found diameter of main pulmonary artery and left and right pulmonary artery diameter above the certain criteria, then is there any need to go further for 2D echocardiography or MRI?
Only telling about the anatomy of the heart, we are only telling about the anatomy of the pulmonary vessels and the lung, which we are seeing over there. So if for the functioning, which is actually of prime importance in the treatment as well, we need to go for a further functional imaging in the form of echo or in the form of MR.
So thank you, Dr. Hemant and Dr. Mega.
Thank you, sir.
We can take this discussion further off the stage. Thank you.
To begin with our session 3, I would call upon Dr. Mahesh Goyal sir, Dr. Alok Mathur sir, and Dr. Atul Kasliwal sir to chair the session.
Hello. Good morning. First of all, I would like to congratulate Dr. K K Sharma for organizing this scientific session on a topic which is mostly neglected by at least physicians like us. And the gold standard way of diagnosing this pulmonary hypertension or arterial hypertension is definitely right heart failure. So I will like to just ask Dr. Mahesh Goyal to introduce the speakers.
For this right heart catheterization speaker is the Dr. Sanjay Khatri. He is basically a pediatric cardiologist in Fortis Hospital. Welcome, Dr. Sanjay. Please start your talk.
I will, sir. Good morning, everyone. Respected chairperson, and thank you, KK and SIPLA PH team. I am not a regular player of the team. I am playing as a substitute here. Neeraj Avasthi should be given this talk, but some unavoidable reason he is not coming. So I am taking his talk with adding few my cases. I hope I will justify my topic, intervention, structural intervention in pulmonary hypertension. Yes, myself, Dr. Sanjay Khatri. I have changed the forties. Now I am in Mahatma Gandhi Hospital, sir. So any intervention in PH can be catastrophic. Diagnostic optimization baseline, clinical and radiological profile, previous sessions, very good imaging. We should have clear things about clinical sense and echo and CT or MRI findings. Echocardiography assessment is very good, and 3-minute walk test with all indices should be taken. Maintain the strict thermoregulation, use warm saline, minimum lung handling and structural manipulation, execute continuous monitoring of ABG, hemoglobin, electrolyte and ACT, imperative plans to absolute minimal intervention time. That is the key for a PH patient because they are very sick with reserve, where reserve is very less. So we have to be very particular in our things, what we want to do, how we want to do. It's a critical in the PH patients. So right heart and pulmonary pressures, what we see in the right side, catheterization in the cath lab, RA pressure, RV pressure, PA wedge, left LA pressure, and LVEDP, cardiac output, and sometime we do the vasoreactive test also. Now, as my case is, topic is intervention in PH patient, but see the patient clinically first, see the echo, don't rush for the intervention. This case, 8-year-old boy, weight 46 kg, complaint of mouth breathing and snoring, known case of adenotonsillar hypertrophy. Refer to pediatric cardiologist in view of harsh murmur and cyanosis. He is obese, having adenotonsillar hypertrophy, saturation 80%, central cyanosis with loud P2. Now, this is the echo. You see, RV is dilated, TR is there, and TR gradient is 122. Yes, is severe PH. PFO shunting bidirectionally. So, dilated RARV with severe PH. So, what is the next step? We know the clinical scenario. It's a adenotonsillar hypertrophy. So, chronic airway obstruction, hypoxemia, pulmonary vasoconstriction, pulmonary hypertension, RV dysfunction. So, no need for any cath or anything. It's a clinical diagnosis based on the echo. It is the most common cause of upper way obstruction in children, and we have seen serial of patients like this. They come with the cyanosis, obese, mouth breathing. We do the echo. Sometimes they are cyanos because PFO shunting right to left. And then we do the echo and guide them because parents are reluctant. ENT surgeons advise them go for surgery, but they are reluctant. But when this cyanosis appear and child is dyspneic so much, and we convince them, they are ready for the surgery. And the various study in the literature shows it's a very common treatable cause of pulmonary hypertension. I saw the child with 70% saturation, PFO shunting right to left, TR 150, having benefited by this surgery. Child is absolutely normal after that. So our aim is intervention, but before intervention, see the patient clinically with every parameter. Now, PH interventions pathway. One is the Essing-Wenger physiology, another is the idiopathic subgroup. Some interventions are therapeutic, some are palliative. I try to discuss few of them with you because when the ASD, PDA and VSD, they become PH. Essing-Wenger group, they are borderline. When we need to close ASD, when we need to close ASD partially, when we close the VSD, when we close the PDA partially, whether we ligate the PDA partially, whether we do some palliative or we give the therapeutic benefit to the patient. So, according to HA guideline with PVRI, you all know, less than 4, very much safe zone. 4 to 5 is a borderline zone, and after 8 we generally don't describe for anything closer of ASD or PDA. Now, this is the case. Basal status, 56-year-old female, dyspnea on exertion for 7 days, fever, edema. Context, managed initially with the chest infection, no closure indicated until infection is resolved. Echo windows are poor, but having TR of 85. So after stabilizing the chest infection, infection taken for the cath study, normal CAG, balloon occlusion test for 15 minutes. This is the balloon occlusion. Now we decide whether we close ASD or not. So in the cath lab, when the saturation is 92% and we are sure on the echo it's a left to right shunt, and after taking the treatment of chest infection for 7 days, still 56 year of ASD, doubtable whether we close or not. So we do the balloon occlusion test in the cath lab. We occlude the ASD with the balloon, simultaneously taking the LVDP continuously. When LVDP not rise and we feel that balloon occlusion test, no parameter change, cardiac output not decrease, then take the decision to close that ASD. Sometime in this type of patient, we use the ASD perforator. We perforate in between so that keep as a pop-off wall, that fenestration will help. So it's a therapeutic intervention. Yeah, some degree of desaturation may occur because the fenestration shunting sometime right to left when crisis occur, but these type of patients are very much benefited, and we did 3-4 cases with fenestrated ASD device closer in the borderline case of PH. Underlying, treat the chest infection first, take the clearance from the pulmonologist. Now no chest issue is there. Do your cath study every parameter, whether balloon occlusion, PVRI, vasoreactive test in the cath lab, then take the decision to close this ASD. The same thing happened to the VSD. Large VSD, severe PH, QPQS baseline 2.1:1, PVRI 9. Can we call off this patient? PA pressures are also severe PH. Now, when we do the nitric oxide test, which is doing in the Scots, they are doing the nitric oxide test, or in our lab, we are doing the IV sildenafil testing, and we find PVRI drop to 2.4. So it's the time, get the benefit of VSD closer to the patient, because you are sure that it's a vasoreactive PVRI fall after the vasoreactive test. So take the decision, we close this VSD with PDA device, 22/20 PDA device, and patient is doing very well after 4 years. Initially few weeks, we keep the patient on antipulmonary hypertensive, the patient is doing well. Now your decision is most important in this type of PDA and VSD, you need to close. Third case, 28-year, weight 39 kg, complaint not gaining weight, upper limb saturation 97, lower limb saturation 97. PDA 14 mm, large PDA, shunting left to right, LV dilated. See, this is the PDA, laminar flow. Now, hemodynamic data in the cath lab. See the PA pressure. Mean is 73. Severe PH. On oxygen, it's come to the 62. When we calculate the PVRI in the cath lab, PVRI 6. Again, it's a borderline. When oxygen, it's become 3. So, QPQS increase in the cath lab. LV is dilated. Patient is having MDM at the apex. So, all data think that this PDA need to be closed. So, are PVRI sufficient? No. We do the balloon occlusion study in this. We keep the balloon, which simulates a large PDA device. We keep the balloon for 10 minutes. That time we calculate the PA pressure and aortic pressure and cardiac output and see the result. When we occlude the PDA with the balloon, complete occlusion of the PDA with balloon, this is the PA pressure pre-occlusion. See, the PA pressures are very high. Mean PA is 73. Post-occlusion, see the difference. Mean PA is 48. So if we don't close this PDA, the girl is going to be Axing-Menger, no chance of pregnancy. All the parameters suggest double, triple we tested is with the PVRI, with the balloon occlusion, that we should give the benefit of doubt to this patient. Because LV is dilated. We close this PDA. In the cath lab with the large device, 22/20. And this patient I did some 7 years back, comes in the follow-up, not any medications, doing very well. This is the large device. So, trial occlusion assess the risk of persistent pulmonary hypertension, because these cases are borderline, tricky, whether we need to close or not close. Yet decision of cardiologist is very important in the cath lab with all the parameter, with the oxygen study, with IV sildenafil, if nitric oxide is possible, or balloon occlusion test, you should assure, because if you convert a CHD into primary pulmonary hypertension, then survival is very less. We can't do this thing, but is borderline of cases, we do the intervention in these patients to make the pH compatible with the life. So, device closure not done after trial occlusion if patient has a symptom of chest pain, aortic pressure decrease more than PA pressure, and balloon occlusion did not decrease in the result in the decrease in the PA pressure. So, don't put the device, just come out, labeled it's a severe PH, we can't do anything, and put on the antipulmonary hypertensive. But balloon occlusion is a very good test. I did some 14-15 cases with the balloon occlusion, more than 40 years of age. Those PDA are borderline, but other than one, all are doing very well. Now, palliative decompression, these are the therapeutic in which the ASD closed completely, VSD closed completely, PDA closed completely. Can we do some therapeutic also? Yes, we create in a primary pulmonary hypertension, we puncture the septum with a Brockenberg needle, dilate it serially, or sometimes we put the stent also. In smaller children, or sometimes we take the univentricular heart for palliation, we do the atrial stenting also. So this thing help is decrease the pH. Yes, these are the palliative process. You can see the stent across the septum. But this is the case of idiopathic pH, increasing breathlessness from 2 to 3 class, 6-minute Boss test is 200 meter, 2 episode of syncope in last 3 months. Echo severe pH, RV dysfunction, no infusion. This is the ideal case of syncope with atrial flow regulator. This is not FDA approved till now, but if it's a suitable candidate, they are willing. It's a very much good things to decrease the episode of syncope. But yes, patient have some degree of cyanosis there, because this flow, we put the contrast, you can see some right sided blood from this diverter goes to the regulator, goes to the left side. Yes, PA pressure decreased significantly, but say pop-up wall is there. So yes, patient symptoms are relieved. So these are the not palliative procedure we can do in the case of pH. Now this is the 16-year-old child, 84 kg weight, prolonged cough, exertional dyspnea. When come to my clinic, not able to climb the 4 or 5 stairs. So bilateral air entry equal, no murmur, soft systolic murmur is there. This is the echo. You can see in the second diagram, you find few echogenic thrombus in the RV. Now TR is round about 60. So we CT angioplan and thrombocheck Palen sent. What thrombocheck Palen shows? Antiphosphate antibody positive, COVID IgG positive, homocysteine more than 100. We did the CT. CT saw thrombus full in the RV and the PA. So what next? Whether we should start heparin, anticoagulants, we try for catheter removal or surgical pulmonary embolectomy. So we send this patient to surgery because extensive thrombus are there, and see, surgeon remove this thrombus and see how many thrombus are there. Make a lung tree in that. So it's a very curative process for this patient, and patient is doing very well. Now see the echo, no thrombus is there in the RV or in the PA. See the RV function, no thrombus in RV, no TR, pressure normal. The child who is not able to climb just 4 stairs, now doing very well. This child is from Kota, 3 years back in the after COVID, in 21 or 22 we did this surgery, so doing very well. So this is also a surgical therapeutic things we do in the PH. Prolonged cough and progressive dyspnea, further investigation is must. COVID previously and COVID antibody still showing a few unexpected complications. Case 6, a 16-year-old severe PH, tiny PDA, severe TR, PVRI 42 and 32. Child is very dyspneic. So only tiny PDA is there. So what we do to relieve the symptoms to the patient, we put the PDA stent there. So if we can't change the pathology, but with the putting the stent, we provide a shunt to the patient, so symptoms are reduced significantly. So these are the few interventions in the PH patients which we are doing. Few advanced which we are not doing, Dr. Prashant is doing in the Mumbai, that is the port shunt, transcutaneous port shunt. It is shunt between a severe idiopathic PH, a shunt between aorta and LPA. So it will preserve the pure blood to the coronary and the brain circulation. But yeah, lower limb is decompensated because of deoxygenated blood. But yeah, this is a newer technique in the PH patient, and Dr. Prashant did at least 15 port shunt in the Mumbai Kokila main. Now some novel frontiers are there, like interventional radiologists are doing for renal hypertension, they do the denervation of the renal artery sometimes, few times, which have some benefit in the decrease in the hypertension. The same, it's not in the literature yet, not so many cases are there, but pulmonary artery denervation is the known entity which may decrease the pressure with the some extent. So decompression strategy, if we do the fenestrated device, it's a therapeutic, balloon atrial septostomy again therapeutic, and port shunt, it's a palliative for the PH patient. So conclusion, intervention in PH are very risky. You want to take the patient to the cath lab with the 70% or 80% saturation, where airway compromise, everything is there. When you put the catheter in the RV, sometimes you have arrhythmia, sometimes desaturation, sometimes hypotension. So these precious cases are very risky. Evaluation, optimization of therapy is the key. Intervention aimed at therapeutic goals are preferred. If we can put the device closely, VSD, PDA, ASD closely. If not, palliative is also a good choice in these cases. Thank you.
Thank you, Dr. Khatri. Now I will like to invite Dr. Prashant Dwivedi for his talk.
Good morning, everyone. First of all, I would like to thank Dr. K K Sharma for giving me this opportunity and organize this conference, which is truly on the topic which is truly neglected from the physician's perspective, from the pulmonologist perspective, and even from the cardiologist perspective also. Because most of the time, the cardiologist is more involved in the only about the heart-related problems like a left heart disease or the right heart disease, but nobody is thinking about the pulmonary hypertension per se. So my topic will be the pulmonary hypertension associated with left heart disease. So the most common pulmonary hypertension a cardiologist see in their routine practice is the pulmonary hypertension associated with the left heart disease. The majority of pulmonary hypertension encountered in routine practice by a cardiologist, and it signals a rising filling pressure, pulmonary vascular involvement, and the mounting RV stress. So disease burden is significant because most of the time the pulmonary hypertension associated with the left heart disease is usually not being taken care, and most of the time it's an overlap between the pulmonary disease as well as the left heart disease. So sometimes the cardiologists think that it is more of a COPD related problem, and the pulmonologists think that it might be related with the left heart disease because the patient is having an ejection fraction of less ejection fraction, and most of the time it's the overlap between both of these. That in those situations we need to define which pathology is predominantly is giving the symptoms to the patient, and then only we have to treat accordingly. So whatever the cardiac diagnosis, pulmonary hypertension makes the outcome worse. It leads to progressive right ventricular dysfunction, impaired exercise capacity, recurrent hospitalization, and the increased mortality. So it is not just the elevated filling pressure, it leads to a progressive vascular disease. So there are two different entities. One is the isolated post capillary pulmonary hypertension, and one is the combined pre and post capillary pulmonary hypertension. Just to brief, what is isolated post capillary pulmonary hypertension? So when there is an elevated LV filling pressure, it leads to transmission of backward filling pressure to the pulmonary vein and the capillaries. And this specifically at elevated pulmonary artery pressure, there is no intrinsic pulmonary vascular disease. So the pulmonary vascular disease, there is no intrinsic pulmonary vascular disease, but there is an elevated filling pressure because of the left side passive congestion. So then when there is a persistent venous congestion, it leads to the structural and functional changes in the pulmonary circulation, which includes a medial hypertrophy, intimal fibrosis, endothelial dysfunction, and the rise in pulmonary vascular resistance. So if you look at the isolated post-capillary pulmonary hypertension, it's an early disease which is potentially reversible, but the combined pre and post-capillary pulmonary hypertension suggestive of advanced disease, and it's substantially associated with the worst prognosis. So pulmonary hypertension in the left heart disease should not be simply regarded as a hemodynamic consequence, because if the pulmonary hypertension is associated with a left heart disease, it is a marker of progressive pulmonary vascular disease. So the clinical cascade, if you just summarize, the passive congestion leads to pulmonary vascular remodeling, leads to fixed increase in the pulmonary vascular resistance, and it progressively leads to RV dysfunction, and it leads to poor prognosis and advanced disease associated with the limited reversibility and high risk prognosis. While the early stage leads to, if in early stage, if we relieve the congestion, the pressure may normalize. So these are the simple hemodynamics. Pressure, normal pressure of mean PA pressure is 8 to 20, pulmonary artery wedge pressure is 6 to 12, pulmonary vascular resistance is less than 2 Wood unit, and right atrial pressure is 2 to 6, and the cardiac index is 2.5 to 4. So hemodynamic definition. So diagnosis require invasive hemodynamic assessment by the right heart catheterization. So as Dr. Ramakrishnan rightly pointed out, the echocardiography just raised the suspicion of pulmonary hypertension. Just by showing the echocardiography, showing the high TR velocity, high PA pulmonary artery systolic pressure, it doesn't mean the patient is having a significant pulmonary hypertension, because echocardiography just raised the suspicion, but it can reliably but it cannot reliably separate whether it's a pre-capillary pulmonary hypertension or the pre and post-capillary pulmonary hypertension. So the gold standard is the invasive hemodynamics by the right heart catheterization. So there are two entity. One is the mean PA pressure, if more than 20, and the pulmonary artery wedge pressure more than 15. Then only we can diagnose that this is a left heart disease associated pulmonary hypertension. So the pulmonary artery wedge pressure is very important, because only if this is elevated, then only we can say that yes, this is because of the left side heart failure associated pulmonary hypertension. So the pulmonary artery wedge pressure, as we discussed, that it surrogates the left atrial pressure, and in most cases also the left ventricular end diastolic pressure, and it measures. This measurement separates the post-capillary pulmonary hypertension from the pre-capillary pulmonary hypertension, and we also need to understand this pulmonary artery wedge pressure is a dynamic situation, because it depends on the volume status, respiratory variation, atrial fibrillation, diuretic therapy, mitral regurgitation, and the measurement techniques also. So then what about the pulmonary vascular resistance? So this pulmonary vascular resistance signifies that there is a vascular remodeling has already started. So the pulmonary artery pressure alone cannot tell whether the passive pressure transmission from the true vascular resistance is there. So there is a different entity. So once the pulmonary vascular resistance has increased, then only there is a intrapulmonary capillary pulmonary hypertension started. So there are two phenotypes, two prognoses. So one is isolated post-capillary pulmonary hypertension, and one is the combined pre and post-capillary pulmonary hypertension. So isolated post-capillary pulmonary hypertension, where the pulmonary vascular resistance has not elevated. While in the combined, the pulmonary vascular resistance is elevated. The isolated pulmonary hypertension, the vascular remodeling is minimal, while in combined, the vascular remodeling is significant. The RV dysfunction is common in combined pre and post-capillary pulmonary hypertension. The prognosis is also worse. So the phenotype continuum is LV dysfunction leads to elevated LV dysfunction, elevated LV endostolic pressure, increased left atrial pressure, pulmonary venous hypertension, leads to pulmonary vascular remodeling, increased pulmonary vascular resistance, leads to RV dysfunction, and finally leads to the pulmonary hypertension in an advanced stage. So as I told, it's not simply a consequence of heart failure, it marks the progressive involvement of the pulmonary vasculature and ultimately leads to the RV dysfunction. So, as we pointed out before also, the left atrium is basically a gatekeeper of the pulmonary circulation. If the left atrium is enlarged, it means there is some sort of left-sided heart disease is there. It might be heart failure with reduced ejection fraction, or heart failure with preserved ejection fraction, or there might be mitral or aortic valve disease. So LA remodeling is now recognized as a key determinant of pulmonary hypertension severity. Vascular remodeling. So what exactly happens? When there is histopathologically, we see the medial hypertrophy, intimal fibrosis, advanced advential thickening, endothelial dysfunction, small vessel obliteration, and the plexiform like lesion. And from here, there is a changes. It transitions from the isolated post-capillary pulmonary hypertension to combined post-capillary pulmonary hypertension. And once the combined post-capillary pulmonary hypertension develop, it leads to increased RV after load, reduced pulmonary artery compliance, exercise intolerance is decreased, and progressive RV dysfunction and the persistent pulmonary hypertension despite valve or LV correction. So the structural changes define the transition from the isolated post-capillary pulmonary hypertension to combined post-capillary pulmonary hypertension. So who progresses from isolated post-capillary pulmonary hypertension to combined post-capillary pulmonary, pre and post-capillary pulmonary hypertension? So the clinical factors associated with the progressions are long-standing heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, significant mitral valve involvement, older age, diabetes, chronic AF, obesity, metabolic syndromes, and a chronic kidney disease. There are certain other factors also like hypertrophic cardiomyopathy, cardiac amyloidosis, mixed cardiac and pulmonary disease, aortic stenosis, mitral stenosis, and there are certain, so the disease specific phenotype. So there are different disease in the left side also, but there are different disease specific phenotypes behave differently. In certain situations, the pulmonary hypertension develop very rapidly, while in the certain situation, the pulmonary hypertension takes some time to develop. So they progress differently, so the treatment also demands different therapy. So the pulmonary hypertension with a heart failure reduced ejection fraction, it leads to a reduced exercise intolerance, the RV dysfunction, frequent hospitalization, increased mortality, and a subset of patient develop a combined pre and post-capillary pulmonary hypertension by chronic remodeling. So the most of the time these patients are those who have a older age, female predominance, obesity, diabetes, hypertension, AFib, and the LA enlargement. These are the patients who most of the time develop the heart failure with reduced ejection fraction. While heart failure with reduced ejection fraction, there will be LV remodeling, decreased systolic function leads to functional MR, increased LV pressure, pulmonary venous congestion, and further leads to remodeling and increased pulmonary vascular resistance. And these patients clinically present with a more advanced heart failure, reduced exercise capacity, increased hospitalization, higher mortality, and a greater risk of RV dysfunction. There are certain valvular heart disease also, like a mitral stenosis, mitral regurgitation, aortic stenosis, and these all leads to increased LV pressure and finally leads to increased pulmonary pressure. Then there are certain hypertrophic cardiomyopathy and cardiac amyloidosis, which leads to, and the pulmonary hypertension associated with these cardiomyopathy is signals of worse prognosis. Then, as I discussed, that most of the time it's not a single entity. And clinically, in real world scenario, what we encounter is there is an overlap between the left heart side as well as the pulmonary parenchymal involvement also, because sometimes the patient is having a COPD, obesity, hypoventilation, or a chronic thromboembolic disease, or interstitial lung disease, or the myocardial disease, along with the other left side heart disease problem, like a valvular heart disease or a heart failure with reduced ejection fraction, or the heart failure with preserved ejection fraction. So in these situations, what exactly is defined is, what we need to do is we need to take a proper clinical history, pulmonary function testing, HRCT, high echocardiography, right heart catheterization, and CTPA. So we need to define accordingly which modality, which phenotype is predominant, whether it's a left side heart disease is predominant or whether it's a lung disease is predominant, and then only we need to define what line of treatment we need to decide. So the crux is that we need to identify these patients early. The symptoms are usually progressive axial dyspnea, fatigue, reduced exercise tolerance, orthopnea, PND, peripheral edema, and the abdominal fullness. And we need to make sure that we need to identify this important point, that the syncope is uncommon in the patient with a left side heart failure associated with pulmonary hypertension. Though the syncope can happen because of the aortic stenosis or other disease, but the pulmonary hypertension per se associated with the left side heart disease is not a common phenomena. So echocardiography is the gatekeeper, but it is not the judge. Echo raises the suspicion of the pulmonary hypertension associated with the left heart disease, but it does not establish the hemodynamic diagnosis. So the right heart catheterization is the gold standard, and when we are doing a right heart catheterization, we need to measure the right atrial pressure, pulmonary artery pressure, mean PA pressure, pulmonary artery wedge pressure, cardiac output, and the pulmonary vascular resistance. And sometimes these patients having a volume status can change, or the patient is having another spectrum. So in these patients, there might be unmasking. We need to unmask the occult pulmonary hypertension associated with the left heart disease. So what we can do is we can give some fluid challenge, like a 500 of fluid over a period of 5 to 10 minutes, and then we have to repeat the pressure measurement of pulmonary artery based pressure, and if it rises more than 18, then it suggests the occult left sided heart disease. And or sometimes we can do an exercise right heart catheterization, and that can lead to increased venous return, increased cardiac output, and it leads to increase in the pulmonary artery wedge pressure. So sometimes there might be a situation we might be encounter that whether there is a pulmonary hypertension is present or not, then we need to give these fluid challenge or the exercise. So the step-wise diagnostic algorithm is, if there is a patient with unexplained dyspnea, we need to assess clinically whether there is a heart failure, whether there is a heart failure with a preserved ejection fraction, reduced ejection fraction, or there is a valvular disease. There could be AF, obesity, diabetes. Then we need to do the echo to assess whether what is the LA size, LV function, pulmonary artery systolic pressure, and the RV function. And then if the pulmonary hypertension is suspected, the gold standard is the right heart catheterization, not the echocardiography. And if the right heart catheterization is showing the pulmonary artery wedge pressure of more than 15, there is a high chances that there is a pulmonary hypertension associated with the left heart disease. And if the pulmonary vascular resistance is less than 2, this is high likely that this is isolated post-capillary pulmonary hypertension. But if the pulmonary vascular resistance is more than 2, the combined pre and post-capillary pulmonary hypertension has already sets in. And if the pulmonary artery wedge pressure is less than 15, there is a high chances it is more of a pre-capillary pulmonary hypertension. So we need to define what phenotype we are dealing with, whether it's a heart failure, whether it's a valvular disease, or whether it's a cardiomyopathy, and then we need to treat the underlying left heart disease. So just to summarize the risk stratification, because if it's isolated pre-capillary pulmonary hypertension, this is a low risk patient, while the advanced combined pre and post capillary pulmonary hypertension are usually a high risk patient. In the advanced stage, there is RV failure, markedly elevated pulmonary resistance, and advanced which requires the advanced evaluation. So the management principles: treat the heart and not the number, relieve the symptoms, reduce LV filling pressure, prevention of pulmonary vascular remodeling, preservation of RV function, improve quality of life, and reduce hospitalization and the mortality. So for the heart failure with reduced ejection fraction, we need to do the guideline directed medical therapy, which includes ARNI, S inhibitor, ARV, evidence-based beta blocker, mineralocorticoid receptor antagonist, SGLT2 inhibitor, and loop diuretics. While heart failure with preserved ejection fraction, we need to control the blood pressure, diuretics, SGLT2 inhibitor, treatment of atrial fibrillation, weight reduction, and we have to manage the diabetes and the sleep apnea. While the valvular intervention, we need to see which valve is involved, whether it's a mitral stenosis, mitral regurgitation, or the aortic stenosis. So we might need to go the mitral BMB, we might need to do the transcatheter aortic valve replacement or the surgical aortic valve replacement. We might need to do the transcatheter mitral valve replacement, or sometimes sometimes the patient is having a mitral annular calcification with a severe mitral regurgitation or the stenosis. In those situations, we might need to go a surgical or the transcatheter mitral valve replacement. And this is a patient with a 75-year female with a severe MR, pulmonary hypertension, recurrent heart failure, hospitalization. And you can see there is a significant tricuspid regurgitation also. It means there is a PA pressure was elevated. Patient underwent a right heart catheterization, and it shows a significant PA pressure. And finally, patient went into the mitral clip, and this was the result that pre-clip there was a significant MR, and the post-clip the MR has gone from the torrential to the trivial. So sometimes we miss the paravalvular leak also, because sometimes the patient is having a prior mitral valve which was surgically implanted before, and these patients sometimes develop paravalvular leak. So we also need to, that's why it's not only the 2D echocardiography, that's why the 3D echocardiography is also having a significant role to define which part of the left heart is involved and what is the reason for the left heart disease. So this is a patient with a significant paravalvular leak, and it underwent a paravalvular leak closure with a 2 AVP devices, and the patient went well. So the recommendation is optimize DDMT, aggressive decongestion, manage hypertension, treat atrial fibrillation, correct significant valvular disease, and refer advanced heart failure appropriately. So my conclusion is the pulmonary hypertension associated with the left heart disease is the most common form of pulmonary hypertension in the cardiology practice. It should trigger evaluation of both the underlying left heart disease and the pulmonary vascular phenotype. The right heart catheterization remains the gold standard for the diagnosis and classification. Elevated pulmonary vascular resistance and RV dysfunction identify the highest risk patient with the poorest prognosis. Evidence supports optimizing the underlying cardiac disease and discourages routine PAH specific therapy. We need to understand that the routine PAH therapy is not going to work in the patient with an isolated pulmonary hypertension associated with the left heart disease. The future is the better phenotyping, early diagnosis, and the disease-specific therapeutic strategy. Thank you.
Thank you, Dr. Prashant. One single question from my side. But we all know that right heart catheterization is the gold standard way. But for all practical purposes, I am asking Dr. Atul also, how many right heart catheterization we are doing only for pulmonary hypertension?
Very few, sir. Very few. So that's why because even most of the cardiologists doesn't do the right heart catheterization. So this is the clinical scenario. Why?
Yeah. For all practical purposes, although we know the gold standard way, but do we not start anti-pulmonary hypertensive therapy in a single patient of VSD, ASD, or PDA to declare it SC-Menger until unless we do the cardiac catheterization? So not a single patient.
So there are two different spectrum. One is the patient, a young patient like a pulmonary hypertension associated with a congenital heart disease. In those patients, we always do a right heart catheterization. Before, there's a different scenario, but yeah. So in a patient with adult pulmonary hypertension associated with a left heart disease. So only when most of the time in Indian scenario, what we do is when there is a overlap between whether we are confused whether it's a left heart disease is predominantly involving, or is there a COPD or interstitial lung disease which is predominantly involving. Only in those situations we usually do the right heart catheterization. While in the Western world it is very routine that most of the problem here in India is there is a financial constraint also. Patient doesn't want to go for a right heart invasive therapy. So they said, sir, on echo it's already showing, so why to do? So there are many limitations also in the Indian scenario. But yes, ideally every patient who is having a pulmonary hypertension should be diagnosed with a right heart catheterization as a gold standard.
And what I do remember, we have done right heart catheterization for the transplant patients.
Yeah.
if we say the need and doing the right heart catheterization, it's very minimal. Reason he is very rightly pointed out that either patient refuses the invasive or it is the cost. These are two major constraints. That's why majority of persons who require logically are not done.
Echocardiography for all practical purposes.
Yes, yes, yes. Even in PS3 also.
I think I strongly disagree, and this is a problem of doctor's inertia, and it is actually it's like people are willing to do angiogram any number of time when there is not indicated, but unfortunate problem is that many of the current cardiology curriculums don't teach right heart catheterization. That is where the problem starts.
Totally agree.
People are not confident in doing a right heart catheterization. Swan-Ganz catheter, which is the backbone of right heart catheterization, is not available in India because nobody is buying it. Nobody is using it. So that is the standards we have fallen to. I think this is nothing to do with anything, nothing to do with patient problem, nothing to do with the indication problem. It is absolutely to all the cardiology institutions are to blame. They don't teach the cardiologists how to do right heart catheterization. That is being percolated in practice.
Absolutely. 95% of the cath lab across India doesn't have even a Swan-Ganz catheter. I'm totally agree with sir that there is inertia, and because of that inertia, nobody is going to teach, and the new fellow also doesn't get to get that experience, because sometimes when we ask the fellows to let's do the right heart catheterization, they find more difficult to do the right heart catheterization than the coronary angiography.
Yes, same thing. I find that doing the ASD, VSD, PDA is easier thing than doing a diagnostic cath for operability. Okay, whether this VSD is operable or not, whether severe pH is certain, we can't close this VSD, or yes, it's a chance we can close this VSD. It is the most difficult and decision-making cath. You need to take care of all the things. Every time anesthesia support, oxygen saturation, correct time when we send the gases, they should come back in us in 5 minutes. Sometimes they stuck there, we waited for the gases, correct interpretation, correct calculation, everything is needed to make a diagnosis whether this we take or we not take. This is a very big challenge.
So time constraint is also one of the factor to have an inertia in cardiologist.
Thank you both the speakers. It was a very practical discussion, and thanks. We would like to close this session. Thank you.
Thank you. Thank you.
Thank you all the speakers and the chairpersons. It was an amazing session. Now we move on to our next session, which is a panel discussion, Group 3 PH, case-based panel discussion. For this, I would like to call upon Dr. Avya Bansal sir, who will moderate the session. And the panelists for the session are Dr. Adar Dhuria sir, Dr. Amit Jain sir, Dr. Ankit Bansal sir, Dr. S.K. Madhukar sir, Dr. Pramod Dadit sir, Dr. Vikas Pilania sir, and the expert for this session will be Dr. Pramod Joshi sir. Thank you. Dr. Vinod Joshi sir is as an expert in this panel. Yes.
1 minute. Okay. Hi, good morning, everybody. At the onset, I'd like to thank K K Sharma sir for having me here and talk about an important topic, pulmonary hypertension, and how do we as pulmonologists look at group 3 pulmonary hypertension. Over the next 20-25 minutes, we'll be discussing routine cases which come to our OPD, very often diagnosed late, put on erratic therapies. But what should be the practical guideline-based approach when a patient of suspected group 3 PH comes to our OPD is what we're going to discuss. We'll see cases of patients who come to us who've been mismanaged, incorrectly diagnosed, very often towards the end, and how we need to retrace our steps and ensure that optimal therapy is given to these patients is what we need to do. Okay, so first and most importantly, what do we mean by group 3 pulmonary hypertension? So Dr. Adhar, can you please tell us and educate our audience what do we mean by group 3 PH?
So group 3 PH is when the pulmonary hypertension is associated with the lung disease under hypoxia. That is, it is not a primary pulmonary hypertension. So it can be associated with a COPD, emphysema. What I see primarily is the interstitial lung diseases, CTD, ILDs. Then there can be non-parenchymal diseases, hypoxia without lung diseases, developmental lung diseases. So we believe the primary pathology lies in the lung and not in the pulmonary vasculature.
So essentially, any pulmonary pathology with or without hypoxia can potentially predispose a patient to develop pulmonary hypertension. Now, Dr. Adar rightly said that he sees a lot of ILD with pulmonary hypertension, but when we go by the sheer volume of COPD in our country, and when we look at that 1% who may have a severe PH phenotype, technically we should be seeing a lot more COPD patients with pulmonary hypertension. But do we actually investigate the COPD patients with echoes as often as we do with their lung function tests? I don't think so. So here we've got a 50-year-old female. She's a teacher by profession, resides in Thane. I'm from Bombay, so Thane is a part of Bombay. Her smoking index is 200. That means she was smoking about 10 cigarettes for 20 years, being a teacher, asymptomatic for 50 years of life. She went on a pilgrimage to Kedarnath to quit smoking and she got breathless when she went to Kedarnath. There's no diurnal postural variation, no aggravating factors, no weight loss, chest pain, wheeze, rhinitis, any of the respiratory symptoms. No pets, birds, comorbidities, lives in a clean room, no family history of respiratory cardiac disorders, no significant past history. Cardiac workup was negative. The cardiologist said there's nothing because very often breathlessness, the first step the patient goes to is a cardiologist. Lungs come in later. Heart is more important apparently. Head-to-toe examination of the patient showed vitals were stable, SATs of 97 on room air, no tachycardia, no tachypnea, no clubbing, BMI was 30, RS was clear. Now the patient went to a pulmonologist. Dr. Amit, what would you do in this situation?
I think from the history, two catching points that I could make out was smoking history and BMI 30, and only recently breathlessness when she was at high altitude. So I think this will be maybe early COPD. So we will do PFT of the patient, and apart from that we will also advise for the sleep study. Apart from the basic investigation, we will like to do like CBC, chest x-ray, x-ray PNS, IG levels, and also 2D echo to assess the heart conditions.
Correct. So the cardiologist had done the echo. There was a pH of about 30. The cardiologist said it's nothing, stop smoking. It's because of your obesity, your overweight. Then the patient went to a pulmonologist. Dr. Jain rightly said x-rays were done. They were clear. Labs were okay. Lung function showed FEV1 of 89, FEC of 96. Fairly good. Mid-expiratory flow rates were about 60 with a 90% post-bronchodilator, indicating some amount of small airway obstruction and good reversibility. And then the patient went back to the pulmonologist with all the reports, and the pulmonologist put this patient on formoterol budesonide, 200 bar 6, 2 puffs twice a day. Now, in spite of knowing that this is a 50-year-old smoker with a small airway obstruction, the pulmonologist felt that the patient required an ICS-LABA combination rather than chasing up and actually phenotyping whether it was a COPD phenotype or an asthma phenotype. So this is what we commonly see in our practice, that even smokers at 50 years of age with a smoking index of 200 are put on ICS-LABA therapy. So these are real-world cases which come to our OPD, and very often we are perplexed what to do. Then the patient came back after 1 month. The diagnosis was an obstructive airway disease, OSA or overlap. Likely said that the BMI was 30. So lung volumes were normal, DLCO was 70%, walk test was 96, no DSAT, all reports were fine, mild pH, pro-BNP was okay, OSA workup was advised, CTPA was advised. Now, important question to Dr. Ankit Bansal is that would you do a CTPA in this patient? Mild pH, obese?
While this is a very tricky question, but considering all those prospects, a smoker, a borderline BMI,
Yes.
and we are living in a post-COVID era.
Correct.
So there is always a possibility of a hypercoagulable state.
Yes.
So in that, if I have to rule out and the symptoms are not relieved by the routine medications, definitely I'll go with a CTP.
Also, one important history which we need to remember was that the patient got breathless on high altitude. Why should the patient get breathless on high altitude? Your echo is fairly okay. Your lung volumes are about 89-96%. DLCO is at 70. Pro-BNP levels are okay. So probably you don't want to miss something.
It is the thrombi in the peripheral territory.
Correct.
Definitely we need to rule out that also.
And also the diagnostic algorithm tells us that when in doubt, we must consider getting a contrast
Yes.
imaging done rather
Yes.
than a plain imaging in this patient. So the patient underwent a CTPA. The CTPA didn't show anything except a pulmonary artery to artery ratio of more than 1. The expiratory images showed some amount of air trapping, but otherwise the pulmonary parenchyma was fairly okay. So this is what the patient did. The CTPA was done. The PA to A ratio was more than 1. Air trapping was there. Moderate OSA, the RDI was 19 and the lowest DSAT was 85% on the polysomnography. And ABG was done because in OSA and in patients of COPD, you should get a basic blood gas levels to understand their PO2 and PCO2. You need to rule out obesity, hyperventilation also in these patients. So the PA2 was 90 and the patient was anxious and was asking that why pulmonary hypertension is there. So the pulmonologist went all out and even did the autoimmune workup because ChatGPT and AI really scared the patient that possible group 1, 2, 3, 4, 5, all causes of pulmonary hypertension needed to be ruled out. So the pulmonologist did everything, did the autoimmune workup, Triple H, ultrasound, everything came back negative. So Dr. Madhukar, how would you manage this patient now? You've got all this data, patient has been worked up extensively, OSA, CTPA shows air trapping, smoker, 50-year-old female. How would you manage this patient now?
When you gave the history, there were 3 important differential diagnoses in
Yes.
my mind. One was idiopathic PAH lung phenotype. The second was obstructive sleep apnea with hyperventilation or obesity hyperventilation. And third was COPD. COPD ruled out. Idiopathic PAH lung phenotype ruled out because DLCO is pretty normal. So one thing that is coming up very nicely here is the obstructive sleep apnea with possible hyperventilation. So I would plan the treatment as I will first start the patient on, I will do the PAP titration and then start the PAP therapy in this patient.
Yeah, very well said, because obesity and obstructive sleep apnea and OHS is also known to cause some amount of pulmonary hypertension. The patient underwent a blood gas analysis. OHS was ruled out, like Dr. Madhukar rightly said. So then the pulmonologist put the patient on PAP therapy, advised weight reduction because BMI was 30. Weight reduction becomes imperative. Patient didn't want any weight loss drugs, was asked to be reassessed in 4 weeks, and the pulmonologist changed the patient from an ICS LABA to a LABA-LAMA combination for the simple reason the inflammatory markers were all negative. The IG, eosinophil count, and FeNO were negative. There was a history of smoking. Air trapping, small airway disease is seen also when noxious exposure to chemicals, typically smoke as well, and could be a probable precursor for COPD. And when you look at this patient, typically breathless, smoker, no inflammatory markers being positive, I would not disagree with putting this patient on a LABA-LAMA. The patient was better at 4 weeks on follow-up, and then the pulmonologist asked the patient to come back at the end of 3 months. This is what typically is done. You start the therapy of a patient, ask them to come back in 4 weeks and assess the patient. Patient was doing well and the patient came back in 3 months. Now, after 3 months, the patient says that breathlessness has worsened. It's gone from 0 to MMRC grade 2. Sudden onset has been there and the patient has consciously worked on weight loss. She's lost about 10 kgs in the last 3 months. Her BMI has come down to 23. So she asked the pulmonologist, why am I still breathless? You've done all possible investigations from me. What is wrong with me? Dr. Dadich sir, what would you do next in this patient?
The initial problem is now solved because he has improved initially.
So we suspected OSA is the culprit for pulmonary hypertension. We've treated the OSA.
Yes, that part was recovered. But why there is a worsening? So we need to reevaluate that thing. We should go for the spirometry. We should go for the echocardiography. We should go for the DLCO. we should re-evaluate the patient on the previous investigating tools. And according to the reports, we should decide that what is the hidden cause which probably has appeared later, or rather it was not diagnosed initially. So we will go for the routine test again.
So the patient was worked up again, a repeat spirometry was done. Here you can see the FE1 has gone down from 86 to 63. The ratios come down to 0.7. The DLCO has dropped from 70 to 39%. The PA pressures have gone up to 60. RARV was dilated. ProBNP levels have gone up. The CPET was done, which showed a VE, VCO2 and PET CT, which was normal, but the VE, VCO2 ratio was slightly elevated. Repeat scan showed again small airway disease and no embolism. Cardiac workup was negative again. ABG showed a dip from 90 to 80. 6-minute walk test from 600 meters came down to 300 meters with a resting heart rate of 104. And repeat blood work was done to rule out everything else was all negative. So here we can see that on the repeat spirometry, you've got a significant reduction in the FEV1. You've got a significant reduction in the DLCO. The walk test of the patient has deteriorated drastically. And here you've told the patient that you probably have sleep apnea, which is the culprit and causing everything in your life. And suddenly the patient says, I've corrected my sleep apnea and all my reports are haywire and I'm feeling worse than what I came to you 3 months back. Now, is this then OSA COPD, which OSA you've corrected? Is it a severe pulmonary hypertension phenotype is the question. That is what we need to look. So what do we mean by a severe pulmonary hypertension phenotype in COPD? Is that the pulmonary vascular phenotype is typically seen in about 1 to 4% patients of severe capillary pH, mild airway obstruction, that's the FEV1 is above 60%, mild parenchymal impairment with small airway disease, severe reduction in DLCO of less than 40%, and profound cardiopulmonary limitation. These patients tend to develop progressive right ventricular failure and share similar features with pulmonary hypertension. In addition, PH can also be complicated by airway obstruction and overlap of sleep apnea and other causes of group 3 PH. So this is something we need to look. Now, when you look at retrospectively, does this... This is a real patient who's done everything and come. Yes, sir. Yes, sir. The patient...
Though diffusion can reduce.
Yes, sir.
But FEV1 reduction in short span of time. How will you explain that?
So the explanation for that was probably the quality of the test, and the patient kept smoking. She didn't give up smoking, sir. The patient was still smoking about 10 cigarettes in the last 3 months.
So smoking index of 200 at the beginning,
yes,
and then in next 1 year or 3 months.
3 months, sir. 3 months.
In 3 months, such a reduction.
There was a viral episode.
Probably your first thing, that quality of test first time.
Yes.
But first time it was normal.
Yes, sir.
So second time quality was questionable.
Second time quality was correct. The first time quality was questionable. So this is...
So first time it was normal.
First time the FE1 was reported
So
normal, sir.
if that was questionable, then
the second time... So this is what we all see in our OPD practice. So, these are real patients who've come with all these reports.
Yeah, Dr. Abia.
Yeah.
One important point also here is if you have done the CPAT, it doesn't show any circulatory limitation.
Yes, I've not done the CPAT. This is just real patient data come. It doesn't show anything.
So there is no circulatory limitation on CPAT.
The CPAT only showed a mildly elevated VE/VCO2.
Yeah.
That's it.
So
Nothing
there is
else.
no
like peripheral edema, hepatic congestion, pleural effusion or ascites. And the second, whether there is a STO of syncope or not. If it is present, how come frequent is it? Is rarely or is frequent syncopes? And there is an increase in the clinical signs and symptoms of the patients. WHO functional categories of patient. We have to see that there are biomarkers like BNP and pro-BNP levels, 6-minute walk distance, CPAT, and there are multiple criteria. According to that, the risk stratification is done, and according to the risk stratification, the treatment is decided whether patient required only oral tablets or patients having aggressive parenteral prostacyclines, or we should have evaluate the patient for early lung transplant. So risk stratification is a very important in this.
So correct. So we need to stratify the patient. Assuming this is a group 3 pulmonary hypertension patient who's come to your OPD, you have to stratify and risk and assess whether it's a low risk, intermediate risk, or a high risk. So you've got a reveal 2.0. It's a fairly simple questionnaire and a scoring system where you classify the cause of pulmonary hypertension. You look at the demographics of the patient, the NYHA class of breathlessness, the vital signs, 6-minute walk test, pro-BNP levels, echocardiography, DLCO, the mean pulmonary artery pressures, and an RHC. So here, the important question which Ramakrishnan sir was also saying that we as pulmonologists do not advise RHCs. Probably we are limited and inhibited in our approach to probably consider advising an RHC for multiple reasons. Cost becomes a very important factor. Patient is not willing sometimes, and probably access to cardiologists who are interested in doing an RHC and rather than doing a stenting becomes a tough job. So at our center, we've got a simple thing that if you want all our angioplasties, you have to do all our RHCs as well. So that's the way you get a cardiologist on board to get an RHC done when you're suspecting a group 1, 2, 3, 4, whatever type of pulmonary hypertension you get. Now, having spoken about that, what do you mean by, and how do you, pathophysiology of pulmonary hypertension in group 3, how does it happen and what exactly happens in these patients? So you've got a pulmonary parenchymal damage, there's vascular remodeling which takes place over a period, vasoconstriction which takes place, and finally you've got endothelial dysfunction and some amount of left heart disease as well, because the risk factors for COPD are probably the same as for the left heart disease. And over a period of time, all of these factors accumulate and give rise to pulmonary hypertension in group 3 patients. So hypoxia, inflammation, and endothelial damage become the 3 driving factors when you talk of inflammation, remodeling, and hypoxic pathophysiology of pulmonary hypertension. Now, how do we treat group 3 pulmonary hypertension? This is not something which is going to be spoken by us because we've got Virendra Singh sir talking next on this topic. And why shouldn't we have a multidisciplinary approach when we look at pulmonary hypertension patients? We've spoken about MDD in COPD. We've spoken about MDD in ILD. We have a cardiologist when we look at COPD throughout cardiac diseases. In ILD, you've got a rheumatologist, you've got a radiologist. So why not in pulmonary hypertension? I mean, I'd like to ask our panelists, how often do you have a team who looks at a patient of pulmonary hypertension apart from a cardiologist? Madhukar, your point, and I'd like everyone to know how would you and a cardiologist be the only people managing the pulmonary hypertension, or you would have a big team look at it at least once?
I totally do agree that we should have a MDD like we have in other pulmonary disease. Without MDD, it's very difficult to decide treatment in pulmonary hypertension. Like in your case, somehow I cannot get into the core of your case. I mean, the problem is, if you are talking about the risk stratification on giving the drug, your patient does not have vascular limitation of exercise. Your patient has CT mosaic with FEV1 by FVC drastically coming down just within a month or something like that. So, and also, so it totally makes me that the patient has ventilatory defect, which is leading to the breathlessness, not the pulmonary vascular defect.
Correct.
So this is how the MDD should be there. There should be a cardiologist. He should be putting forward his opinion. There should be a radiologist or cardiologist, a pulmonologist, and we require the entire team to reach to a particular diagnostic classification and then to stratify and treat the patient.
Yeah, it makes sense. You also have a rehabilitation, nutrition, physiotherapist in these patients because it's very important rehabilitation which needs to be done. And when you manage these patients, you have to treat the underlying cause in group 3 patients. You need to ensure compliance with therapy is there. You need to have a low threshold for obstructive sleep apnea. It needs to be ruled out when you have pulmonary hypertension in group 3. Rehabilitation becomes very important in patients of pulmonary hypertension. Oxygen therapy probably would be required, heart-lung transplant, vaccination, etc. Now, how do you follow up these patients, Dr. Jain?
Mostly, if there is elevated pressures on the echo, we will follow up, serially monitor the echo, and especially look at the right heart. I think that is the way, and also monitor the lung functions with PFT, DLCO, and echo and anti-proBNP levels.
Correct. So once you've established you've got a group 3 pulmonary hypertension patient, functional limitation becomes very, very important. So simple parameters such as breathlessness, your NYHA classification of breathlessness, your 2D echo, 6-minute walk test, diffusion, and FEV1 become important, and routine parameters which need to be screened on a 3-monthly level. And also, like Sir said, in cases of rapid worsening, a cardiac MRI to understand the functionality of the heart becomes very, very important. And the next important question is, now you've got a botched up case, you don't know which way you're going, whether the first report was correct, the second report was correct. Now, in this patient where you've not firmly established whether it's a ventilation issue, a perfusion issue, or there is a mixed issue, would you do a right heart cath in this patient? So if you've got this patient who's come to you with all these reports, The patient was breathless, then got better with bronchodilators, inhaled corticosteroids, corrected the sleep apnea, and then suddenly got worse after 3 months. And probably the COPD was always there, and the first spirometry never really picked it up. And the patient only showed symptoms at high altitude, and then there was a gradual downward spiral which the patient took. Would you do an RHC in this patient to understand that is there something else which we are missing, and probably the previous reports were incorrect, the previous images have missed something, previous spirometry showed some defect? Would you do an RHC, and what would the RHC tell us in this kind of a patient?
So I believe whenever we think of RHC, we need to answer two questions.
Yes.
The first is this RHC giving us some additional information that we didn't had in before, or whether this RHC is going to change your therapy? In your case, it is going to help.
Two answers.
Yeah, two answers. And
Because
both
he'll
these
tell you
answers
why
are
the
needed.
PA pressures are high,
Yeah.
and also potentially change your therapy in this patient.
So yes. So in this case, you need an RHC because it will answer both of your questions.
Correct.
So we should do an RHC.
So this is what the patient came to us finally with all the bunch of reports. We had a radiologist look at the images once again. The CD was not there, so all the images only could be seen. The first spirometry was poorly performed. The second spirometry was correct. So probably we assumed that the COPD was always there, but the lady didn't really have any massive functionality or was not a marathon runner or a swimmer or a jogger. So it was quite comfortable leading her life. And only when she went on high altitude, the symptoms probably slightly flared up. And the bronchodilators helped her, the CPAP helped her, but there was something else which was worsening. Smoking obviously didn't help, but that doesn't explain a sudden worsening which happened in the place. RHC becomes important in group 3 patients is because it helps us understand the reason for clinical deterioration, to understand suitability for surgical treatment, to suspect severe PE on TTE, to diagnose suspected concomitant idiopathic PH or a chronic CTEF, and further hemodynamic information will help us understand which way the patient is going. Now, when we did the RHC of the patient, I mean, the patient was willing because she wanted an answer. She's a teacher, she's an educated person. She questioned the first report of the spirometry, was compliant. The only thing she didn't do was stop smoking, but now she was so scared. And when we did her RHC, it was found that the RSVP was draining into the SVC into the right atrium. So essentially, this was a PAPVC which was missed on the first CTPA done. And this explained some amount of worsening at high altitude. So the patient was born with a PAPVC which worsened at high altitude, and then her symptoms gradually worsened over the last 3 months in spite of optimization. So finally, when a PAPVC diagnosis in this patient was made, the patient was offered a surgical correction, the patient underwent a surgery, recovered from that, and is doing very well on a LABA-LAMA combination, has quit smoking. So here it becomes very important for us to look at the images, look at the scan, look at the echo report, question the reports which the patient comes to us. And when you feel that the diagnosis is not fitting and it's not correct, please do not hesitate to repeat questions, repeat the tests. So probably what we should have done looking retrospectively is repeated a CTPA rather than asking an RHC, but the patient had already done a plain scan and a CTPA. So the patient was reluctant for radiology and radiation exposure. So the only option we had left at this situation was getting an RHC done, which told us that there was a PAPVC component as well, which was worsening the underlying symptoms of the patient. Though it was mild, the patient was born with it, but yes, it was a definite contributory factor. Okay.
I would like to say one thing. So at one point of time, there was an increase in, RARV was dilated.
Yes.
So at that point of time, we have gone through again echocardiogram and everything by the cardiologist evaluation. So at that point of time, there must be a contrast echocardiography, along with has to be a saline echocardiography.
A bubble contrast echocardiography should have been done. It should have been done.
If it would have been done at that point of time, there might be a more suspicious of some other pathophysiology.
So ideally, the CTPA should have picked up the PAPVC in the first place.
Yeah. So there was a problem from both the echocardiographer or the cardiologist as well as the radiologist. Because sometimes we blindly trust on each other, then there might be a problem.
So the patient wouldn't have decompensated had the first CTPA been reported correctly, and you could have easily understood. So that is the importance.
And somebody should have put a stethoscope there. So with the PAPVC, with that kind of RARV validation, would have had a bomber. So this is where we don't rely on our basic science and then
we
go
don't.
to basic clinical
We
science.
just look at reports. We accept substandard reports, and then we've got our hands back to the wall, and we really miss things. This is what shouldn't have happened, if we ask honestly.
Same way, I think ECG cannot be normal in this case. Like ECG should have had RARV BBP. ECG should have simply had an RBBB, and this is not putting things together.
This
simple.
is, yeah, it shouldn't have happened in the first place. She got a clearance, a mild pH up front, high altitude worsening. Probably they said high altitude sickness. She was given a diuretic when she came down, immediately a low dose of steroid. So this was all the history which the patient had.
The problem with that, okay, we can joke about CTPA should have picked it up and everything. Sometimes what happens is whatever your suspicion, they tailor their dosing accordingly.
Yes.
So the arterial phase, venous phase, where they are putting their focus on, everything changes totally when you think of like that. So basically, for example, in this case, ideally they should have picked it up. Had you had a suspicion of Cori PAPVC, they would have obtained a delayed phase. So now they will be focusing on the arterial phase where the immediate filling of the pulmonary artery is the maximum focus, where they would be acquiring the maximum images that place. So had your question being Cori PAPVC, they would have put the acquisition timer later. So as a routine, we all think that okay, CTPA means everything should be out. So for example, at our institute also, patient was investigated for pH and later on turned out to have coarctation of aorta. So CTPA missed coarctation of aorta because when we later went ahead and saw that they have not acquired the images that is required for a coarctation of aorta.
Correct.
So this is I think that all of us has to be aware that CTPA is not a one-stop shop. Ideally, it should be a one-stop shop, but it cannot be a one-stop shop for everything.
And also, when you are suspecting pulmonary hypertension, you are calling this patient.
Sending a patient for pulmonary hypertensive to radiologist, always write what things you want to see. I always say them, I want to see the arch for any communication, a large collateral which I can miss in the echo, pulmonary veins, and take the cut up to the liver. I want to see the IVC also for drainage for any aberrancy. Until unless you don't give your eye to the radiologist, they will not see, as the sir told. So that's a basic. If you do a CT for pH, you are suspecting a pH. So tell them what are the things you want to see, because sometimes a large collateral can be missed on the echo.
Absolutely.
And the same thing, the pulmonary vein, PAPVC. Same thing, the sometimes aberrancy malformation, the portal vein, and they cut the cut up above the diaphragm, and pathology is behind.
And to make use of a DECT wherever you've got the opportunity, because it'll give you much more information than with the CTPA combined. So dual energy CT, if you've got the option of planning a CTPA in a patient, I would personally advise a DECT to the patient. Get a dual energy CTPA done in this patient. It'll give you much more information. And that is the importance of ensuring a correct report, a correct diagnostic center, and a good quality report, because a lot of money, time, and incorrect diagnosis is wasted. So what radiation too, and that's the reason the patient was unwilling for further imaging radiologically point of view, because she didn't want any more radiation to be exposed. So
just one more comment. If suppose hypothetically situation RARV is normal, PAPVC is also not there.
You have to do the RHCs. I mean,
no, right heart catheterization also being done, and there is mild filling in the mild pulmonary artery wage pressure is slightly elevated. What will we do?
So we would label this as the group 3 pH patient in any case. Her group 1 autoimmune workup was everything was negative, which was already done. You've got an impaired spirometry to a certain extent and a smoker. So we manage with respect to the group 3 pH. You've already done a CTP, there's no embolism. You've ruled out group 1. Your echo will also rule out.
RHC, if pulmonary artery waist pressure is raised, being a pulmonologist, I will seek the help of the cardiologist.
Yes.
Now you tell me what we have to do.
So that's why I'm saying the question is, sometimes we just focus about the dyspnea, but sometimes the dyspnea might be an angina equivalent.
Correct.
Considering the 50-year female is smoker,
yes.
and now the age is not a bar, so if we are writing that cardiologist is clear, he must have think about from all the aspects. Sometimes if the left main is involved or the proximal LAD is involved, and sometimes the patient doesn't have symptoms, and these develop symptoms on high altitude or when they got a full exertion. So sometimes we need to go through the left heart catheterization and angiography also to rule out.
So in this patient, the CAG and RHC both were done is because we didn't know what we were dealing with. The CAG came out clean, 40% blockage, medical management is advised. But you're right, when you have risk factors and you've got risk factors associated in this case, like you've got a postmenopausal smoking women of 50, you would obviously do a CAG and an RHC, but point well taken, we need to inform that you must look at not just the RHC, the cardiologist needs to do the CAG as well in the same sitting and understand and have a better prognostication of the patient. So thank you very much, everybody. Thank you.
Thank you so much to all our panelists, expert and moderator. So moving forward to the fifth session, I would like to invite Dr. N.K. Jain, Dr. R.P. Meena and Dr. Atul Kasliwal sir to please chair the session.
The next session is on pH in lung disease, when to treat and when not to treat. And our speaker is no other than Dr. Viren Singh. He is a known pulmonologist, and I don't think he needs any introduction. pH in lung disease is a very tricky question. There are so many drugs for pH, but group second, third, and fifth, there are no drugs. So this is a very relevant topic, whether to treat or not treat, to treat, how to treat.
Thank you, Nirmal. At the outset, I congratulate Dr. K K Sharma for excellent talk on a neglected topic. Friends, after my retirement, I am working in Rajasthan Hospital and Asthma Bhavan. And in next couple of minutes, I will discuss pH in group 3 disease, that is a lung disease, and after many successful stories and blunders in reports in last panel discussion, I'll share blunders in my clinical practice. I think that will emphasize a little more. This is the patient Ramlal ji, 35 pack years of smoking, dyspnea grade 3, peripheral edema, loud P2 right ventricular heave, 6-minute walk distance 180 meter with 85 lowest saturation, FEV1 is 45% of the predicted, right ventricular systolic pressure is 50 mm, SpO2 resting 92%, HRCT emphysema, and diagnosis was severe COPD with pH group 3. What should be the treatment? We planned LABA-LAMA, pulmonary rehabilitation, sildenafil. It's almost 15 years back. So do you agree with it? Yes or no? One no? Any yes? Okay, any confusion? Those who are in confusion?
Dr. Virendra, if I remember, there was a study published by you on sildenafil, and that you showed that it is a positive response. Though in recent literature, all PD inhibitors are not recommended for group 3 pH.
So ये होती है जिगरी दोस्त की बात. So yes, he is right. The sildenafil in severe COPD, 2011, it was randomized control trial. We published it in Indian Journal of Chest Disease Allied Science, and it showed that with 12 weeks follow-up, there was significant improvement after 12 weeks. There was significant improvement in primary outcome of 6-minute walk distance. And looking to our experience, we started. But Ramlalji improved. His 6-minute walk distance improved by 120 meter. But after 4 months, there was worsening of dyspnea and hypoxia despite of maintaining FEV1 45%. So subsequent guidelines also showed they didn't recommend sildenafil. So friends, it is the research. Sometimes our own papers teach us modesty, and that is how science progresses. And if we just summarize, there is pulmonary artery, lungs, and left heart. So group 1 is heart, pulmonary artery, and then there are pulmonary thromboembolism. Group 2 is left heart, and group 3 is lungs. Group 5 miscellaneous causes are there. Should we use these drugs, anti-pH drugs, in group 3 pH? Yes or no? Those who say yes, raise your hand. Those who say no, raise your hand. Okay, okay. So you are making my topic quite clear. There is a big no. Why? Because basic action of these anti-pH drugs is pulmonary artery dilatation. And if we see, if there are 3 portions of this circulation, pulmonary artery, lung and left heart, if problem is at B, then if we make dilatation of A, will it work? It can't work. It is analogous that if you are swelling on the left hand and you put a local applicant on the right hand, does it work? अरे भाई पेट में दर्द मेरा हुआ दवाई निर्मल को दी तो काम करेगी क्या? नहीं करेगी ना. तो in the same way it won't work. So why it is so? Why it causes deterioration? It causes deterioration because there are poorly ventilated areas of lung, and hypoxia in those areas causes vasoconstriction. By anti-pH drugs, we are vasodilating those areas which is going to cause wasted perfusion. It will cause mismatch, and therefore it should not be given. That our second blunder in this patient was that though during daytime patient was having normal saturation, but in night time he had problems, and we missed that. That was our second blunder. And in night hypoxia, if you wish to identify patients in clinical practice, this mnemonic sleep will serve the purpose. Sleep which is not refreshing in COPD patient, lethargy and daytime sleepiness, early morning headache, episodes of nocturnal awakening, and poor concentration and fatigue. If you find these 5 things, probably we will not have, we should suspect nocturnal desaturation in such cases of severe COPD, and nocturnal oximetry will help in such cases. When to treat was the topic. We should always treat. But what should be the treatment? Treatment should be the basic treatment of the disease itself, not anti-pH treatment. So we should optimally treat COPD, ILDs, OSA, bronchiectasis, post-TB, lung diseases. And what is the commonest adverse effect in such cases if we use drugs like sildenafil is disappointment. So it's better not to treat. And after 2 years, in this patient, what happened? That he deteriorated again. And this time he had syncopal episode. Dyspnea, grade 3, it progressed to grade 4. 6-minute walk distance reduced from 180 to 100, and saturation 85%. FEN remained almost stable, 45 to 44%. DLCO reduced from 55 to 24%. Echo 50 to 84, SpO2 91%, HRCT scan was repeated and it was almost the same. The diagnosis of severe COPD, pH. What is the problem? Where is the problem? One point here we can see is that in such cases, how should we progress? History, examination, echo, PFT, DLCO, CT, chest, 6-minute walk test, BNP, and right heart catheterization. These should be our test. But one very interesting thing, to suspect pH in such patient, pH in such patients are disproportionate. Disproportionate of symptoms, disproportionate of tests. And 6 Ds to remember to suspect pH in pH is dyspnea out of proportion. In that case, FUN was almost the same, 45, 44, but dyspnea increased from 43, increase 3 to 4th grade. Declining exercise capacity, desaturation after rest or exercise, DLCO. From 55, it reduced to 24, and dilated right ventricle, decompensation in form of edema, syncope, or raised BNP. So, friends, in some cases of PS3, pulmonary vasculopathy is also there, and that represents a small number of patients but distinct phenotype. And most of the patients usually are hypoxia-driven PH, but less than 10% of the group 3 have superimposed pulmonary arterial hypertension. And so right heart catheterization is only the answer in such patient. And here you can see that in this patient we got right heart catheterization, and you can see that pulmonary vascular resistance is significantly high. And pulmonary wage pressure is normal. Wage pressure normal means left heart is okay. And pulmonary vascular resistance high means precapillary pulmonary hypertension is present. So this is a small category. It is not a routine thing. It is exceptionally very small number. But in these patients, if we manage this patient continued COPD therapy, pulmonary rehabilitation, oxygen requirement was addressed appropriately, and anti-PH therapy, tadalafil, was given. And outcome after 4 months was the 6-minute walk distance, MMRC grade improved, pro-BNP reduced, no significant fall in oxygen saturation. Why did the patient respond? Because there was pulmonary arterial hypertension associated with pH. Now question arises probably in your mind, why in our study there was significant improvement in 6-minute walk distance with sildenafil? The reason was simple. Sildenafil also acts on skeletal muscle. It improves efficiency of skeletal muscle. So probably in our study it improved skeletal muscle, leading to improvement in 6-minute walk distance. Friends, carry home message is that when pH in 3 group, as you universally and everyone agreed, we should not treat with anti-pH drugs, except in limited number of the patient. And we need to ask one question which I usually ask: is pH proportionate to COPD severity? If reply is yes, never treat with anti-pH drug. If reply is no, then go to next slide. Anti-pH therapy is given in group 3 pH when there is yes to all these 5. Disproportionate to underlying lung disease had been optimally treated, hypoxia corrected as much as possible, significant symptoms with right ventricular dysfunction, and RSCs confirms pre-capillary pH. So, thank you very much.
Thank you, Dr. Viren Singh. Probably this case transferred from group 3 to group 1. So it responded.
Group 3 plus group 1.
Yeah. But now recently there has been a trial on treprostinil which has shown that group 3 pH with ILD, not with COPD. Though group 3 pH, 80% of the cases are with COPD pH. But some of the cases which are secondary to ILD can respond to treprostinil, which is available in all the forms, available in subcutaneous form, IV form, as well as oral form. Though it is not available in the country. But recent studies show that it...
And that was RCT?
Some drug,
RCT
published. And there was a perfect trial for sildenafil in COPD. And that had shown that there is a virus mismatch. So message clear that there is no drug current directly available in our country, but future is not so. We may have some drug for the group 3 also.
Yes, please.
Sir, why we cannot think about the PVOD in this case?
Why can't?
PVOD, pulmonary venous occlusive disease.
Pulmonary venous occlusive disease.
Why we cannot think in this case?
Why didn't I think of that? Because I didn't know.
Because you did the directly right heart catheterization. Why we should not go for the HRCT to evaluate the
HRCT twice done and only emphysema was present.
So before going catheterization, CECT should be done to rule out this PVOD. That is the primary thing.
That is the primary thing, I think so.
Probably 15 years back we missed it.
Okay, sir. Thank you.
I'll just put a point of the inhaled pulmonary vasodilator in COPD. All the trials of inhaled pulmonary vasodilator in COPD has failed, unlike ILD. Even that. The reason is, if you give the pulmonary vasodilator inhaled, what happens? We say that the VQ mismatch will improve or will not get worsened if you give the inhaled vasodilator. Despite this hypothesis or despite this fact, all the inhaled therapies in COPD with pH has virtually failed. We are still waiting for the results to come, but in ILD, yes, I totally do agree with you.
I think I want to add 2 points here. Generally, we all consider like bosentan, ambrisentan to be superior to sildenafil, tadalafil. But definitely, whenever in doubt, whenever you are treating a disproportionate pH, it is better, as sir has pointed out, stick to sildenafil, tadalafil than bosentan and ambrisentan. All the ERAs, unfortunately, the trials have not been published. If you go to the earlier literature, all these trials were done, and the trials are prematurely terminated for even excess death in COPD and ILD. So I think if at all you want to try in a disproportionate patient with COPD or ILD, try sildenafil and tadalafil. That's point number 1. As sir pointed out, the trials are actually happening most with inhaled treprostinil. The problem with inhaled treprostinil is it has a separate kinetics and it has a separate different inhaler which is very difficult to handle. So that is where the host challenge is happening. I think once it comes in a simple inhaler form, which is another group is trying. If that comes, I think there will be a big breakthrough. Otherwise, currently available, the trial that you are talking about, it's a very cumbersome delivery system, which I think even US may not be following it like.
But others they are showing the worst effect.
Yeah, everything is going to be inhaled. Treprostinil is going to be the big future in group 3 pH.
The bottom line is disproportionate. Just remember disproportionate finding. If you come across in your clinical patient, suspect pH in pH. Thank you.
Thank you, Dr. Viren Singh.
So the next topic is medical management of pH, how to choose the best treatment. Well, this will be delivered by Dr. S. Ramakrishnan.
Good afternoon, everyone. Thank you, Dr. K K Sharma, for getting me here. I think PH has been my passion, and I've been working on PH for quite some time. And currently, we are very fortunate to run a Center for Advanced Research in PH with a lot of interesting projects, and maybe a few more data will come from India. The large data may come from India for Indian conditions like IPH and Eisenmenger syndrome. And we are also trying to develop Indian treprostinil, which is going to be at a fraction of a cost of what is available in the West. So I think this presentation is going to be interactive, where I think I'll be showing some questions, and you can scan the QR code and then answer the questions also. So yeah. So this is going to be on medical management of PH and how to choose the best treatment. So I think we all discussed about all this. I think we have limited resources and expertise, and late presentation is pretty common in our patients. I think oftentimes we don't diagnose. So in my life, I have catheterized quite a lot of patients. Very few, maybe around 1% would have had somewhere on the mild PH range. Most of them are, when they are diagnosed, severe PH, and often with heart failure, right heart failure and syncope. That is when we diagnose PH. And maybe many of them have associated comorbidities. And the most important thing is cost constraint. It's most painful. I think I sit in my PH clinic. Every month, at least 2 patients come who says, I am doing very well on these drugs, but can I stop one of them? So this is the problem that we face. So that is the reality. We are not talking about expensive medication. We are talking about simple bosentan and sildenafil. So I think lack of specialist training and guidelines, as I told, like most of even the cardiologists in the current era cannot put, they can put anything in the right coronary artery, but they cannot put properly into the right pulmonary artery. That is how the training has become. That's unfortunate. And then lack of standardized protocols, care protocols, which I think we should be evolving. I think first effort has been made, and we have published our Indian guidelines, which is kind of come down version of the usual international guidelines that have been published recently in pulmonary circulation. So let us start with this case, which is a typical patient that we all encounter. A 27-year-old female with class 3 dyspnea of 3-month duration, but clinically heart failure, JP is elevated, hepatomegaly is there, TR velocity of 58, and CT angiogram which was done showed dilated pulmonary artery, no other cause was found, and routine workup were negative. So this is the information that is there, and which one of the following drug is not ideal in the following patient life. So these are the options at this stage. So torsemide, digoxin, sildenafil, and diltiazem. So you can just scan the QR code and then start answering. Let me check whether I'm connected. Yeah, I'm connected. Sorry. Yeah, you can start answering. Is it not coming, or is there a problem? Like only 1, 2, 3. Yeah, now it's coming. No, it's not answer. It's live. It is live. No, it's live. It's like whatever they are answering, it will change. So we got roughly around 25 answers. So the answer here is that you're no business in starting diltiazem at this stage. So patient can be started on sildenafil. If you are in doubt, you can start and refer to a cardiac PH center. But oftentimes this is a common problem that we face, that patients are started on diltiazem and referred to us. Because older era, diltiazem used to be a kind of a routine that everybody used to start. Most of the cardiologists start diltiazem whenever diagnosis of PH is made. Why they should not be started? We'll come to that point next. But what about digoxin? When can digoxin be used in PH? So digoxin is a drug which was an orphan drug, which I think nobody wanted. The cardiologists were after the costly drugs and they all thought they are more effective. But again, digoxin is making a comeback in heart failure, reduced ejection fraction also right now. And both in rheumatic heart disease and reduced ejection fraction, there is a good data with digoxin now. And patients with heart failure, clinical heart failure with RV dysfunction may be started on digoxin. It's not a crime to start on digoxin. But at this stage, starting on diltiazem is a crime because diltiazem is useful only in patients who show vasoreactivity testing positivity in cardiac catheterization. So what that does mean? Like, what is it? We give, say, right now the recommended agents are like inhaled nitric oxide, or we used to use adenosine, but then now the current guidelines have taken it off. So the currently available, I think only NO is available right now for us. Otherwise, you have to use epoprostenol or treprostinil or leoprost or something like that. So if you use that, there are defined criteria to make that is vasoreactivity. So let me tell you, these are two different diseases. Commonly, IPH, the idiopathic PH, group 1 PH is a proliferative disease. Generally, it is a kind of a vascular proliferation of sometimes monoclonal origin, where there is a vascular proliferation that happens in the artery. But some of these patients, they just have the balance between vasoconstriction and vasodilatation as the primary problem. They tend to respond very beautifully to calcium channel blockers. And that patients are picked up by this vasoreactivity testing. This is only 5% of adults and 10% of children have vasoreactivity testing. But the moment you diagnose them, they have absolutely different prognosis. They live longer. They do very well on calcium channel blocker. That is one of the reasons every IPH patient in the world should be catheterized. Not only to rule out other things, but to establish vasoreactivity. Because these 5 or 10% patients are absolutely different problem and different prognosis, and they do often very well. So just to reiterate the point, the longest following vasoreactive patient was catheterized by Professor Rajan Tandon, who is no more. It was the patient was catheterized in the 90s. So no other IPH patient is following up for such a long time. So they are absolutely different gene, different problem, different things. So we have to make an effort to identify, because if the calcium channel blockers have a negative inotropic effects, they should not be started in a patient without vasoreactivity proven in patients with RV dysfunction at all. So which of the following is the preferred patient, like preferred agent in this patient who is functionally class 3? So which one of the following is the best combination or monotherapy that you would start? Same, you can scan the QR code and then vote. Tough fight. Let's go for the tie break. So it's equal. But I would say the answer is ambrisentan and tadalafil. Can anybody tell me why sildenafil and bosentan is not given a class 1 recommendation by most of the agencies, most of the ACC or ESC recommendation? What is so superior about ambrisentan and tadalafil as compared to sildenafil and bosentan? So two important reasons. One, I think the ambrisentan and tadalafil, the ambition trial was done with those agents, and there is a clear-cut proof with that agent that these two agent combination works. Number one. Number two, there is a significant drug-to-drug interaction between bosentan and sildenafil, which is clinically meaningful. Very few clinically meaningful interaction happens with the current drugs that we use, but significant interaction happens with ambrisentan, sildenafil and bosentan. So if patient can afford, patient can use. In all patients with idiopathic PH, a dual combination therapy with ambrisentan and tadalafil is class 1 recommendation. You can use mesitentan and tadalafil also. That is also class 1 recommendation, but mesitentan monotherapy is no longer recommended. So we all know that traditionally there are 3 pathways that are there. Currently, out of which we have availabilities like for ambrisentan, bosentan and mesitentan are available in India. These are not available. Selexipag is available of the endothelin pathway, the prostacyclin pathway. The endothelin pathway, these 3 are available. And nitric oxide pathway, we have riociguat, sildenafil and tadalafil. These are the agents that are available with us. The ambition trial that showed combination therapy is superior to ambrisentan alone or tadalafil in preventing clinically meaningful endpoints. So what has been shown is initial combination therapy with ambrisentan and tadalafil is a class 1 recommendation. Macitentan and tadalafil is also a class 1 recommendation. Others are a class 2A recommendation. So it's better to follow a class 1 recommendation, which is doable. So Selexipag is not recommended as a triple combination because the trial failed. So in current practice, it's very simple. You diagnose an IPH, start them on ambrisentan and tadalafil combination. That's it. That's the first and possibly the last that we have as a routine. But which are the patients you will not start a double combination therapy in today's time? So who will not do a dual start? So patients who have comorbidities, patients who have say LVH, patients who have diabetes, hypertension, other comorbidities, you better start with one agent and see the response and how it goes. In non-group 1 pH, whenever you are starting, as we discussed, disproportionate pH, all those things you don't start. Same Eisenmenger syndrome. Currently, the recommendation is to start with bosentan there, single monotherapy with bosentan, and then stepwise escalation if required. That is what is recommended there. And then the PVOD and PCH, where the pulmonary vasodilators were considered contraindicated before, but now people are saying that they can be used under caution, under careful monitoring what happens to the patients. But at times there can be pulmonary edema precipitated if you use very high dose without monitoring. So it's better admit them and objectively assess whether they're improving or not in a patient with PVOD and PVH. And CCP responsive IPH, you are not supposed to start dual combination therapy. And then in pregnancy, obviously ERAs are contraindicated, you are not supposed to start. Excepting all these situations, whenever you start a pH therapy, it's better that you start with a dual combination therapy, preferably with ambrisentan tadalafil or macitentan and tadalafil. That is what is the current recommendation. So we discussed about all this. Group 1 pH, this is current recommendation. Group 2, you have no business in starting pH specific therapy. And group 3 we discussed enough. And group 4 also, there is only one treatment, that is surgery, surgery, surgery. Only when the surgery is not possible in CTPH or surgery has failed and there is residual pH, you have business in treating them. So now we go to the next step. We discuss about that. No business of starting anything, just a low dose diuretic as much as possible, as slow as possible. And then you start digoxin if there is right heart failure, no other drug. Just a combination, dual combination. If they are doing well, very nice. If they are not doing well, what will you do? The improvement is less than satisfactory, what will you do? So excellent. Now this time they all understood the game. So everybody got it right. Mostly they have got it right. But increasing the dose of bosentan beyond the traditional one is not ideal and doesn't work. And same way increasing the dose of sildenafil doesn't work. There are many studies that have shown that it increases the complication rate and the efficacy increases marginally. So there is no need to increase the dose of sildenafil or bosentan or tadalafil or ambrisentan beyond the limit. I will tell you the maximum doses later. What about adding riociguat? There is no role of adding riociguat, but there is a role of replacing riociguat with tadalafil to riociguat. There is a switch that can be done, but you cannot add riociguat. You can add selexipag or sotatercept. So both the answers should be right here. If the patient can afford, you can add sotatercept or you can do selexipag. So this is the next stepwise. So see, keep it life simple. Start ambrisentan tadalafil or macitentan tadalafil. Next step, if the patient is not doing well, either you can add selexipag. You look at all the other things also. You just rule out anemia, this, that, everything, optimize everything. Then you later add selexipag or add sotatercept if the patient can afford, which roughly comes to around, say, somewhere around 20 to 30 lakhs a year. So if the patient can afford, so that is one. Or otherwise you add selexipag, or otherwise what you can consider is switching of the sildenafil and tadalafil into riociguat. So I will come to each of them later. So Griffon study is the one that showed that addition of selexipag over the monotherapy or combination therapy showed significant improvement. So that is the basis of adding selexipag. And then switch to riociguat. you have a physiological basis for that. That is that these agents, the sildenafil and tadalafil, require intracellular NO concentrations that get depleted over time. Whereas riociguat doesn't depend on that. That is the physiological basis behind that. And these are the studies that showed, there are 2 studies which are roughly around 300, 400 patients that showed that switching may benefit the patients. And this is the most important slide that everybody for practice use. Ambrisentan, the maximum dose is, target dose is 10 mg, bosentan is 125 mg, macitentan is 10 mg. And sildenafil is 20 mg TAD and tadalafil is maximum 40 mg OD. This is what you have to know. Beyond this, there is no role of adding anything. A few slides on sotatercept, which is I think a game changer, because most of the time there is a big delay and then there is a ceiling effect. Like with these agents, the 60% patients do well and 40% don't do well. And the real problem is that most of them are vasodilatory molecules which don't actually work on the real pathway, which is of the proliferation dysregulation. So that is the kind of thing that has been going on for ages, and this is a clear cross engineering that has happened. Like people have started from BMPR2 mutation, which is commonly associated with IPH. They've gone back, what is the molecule behind it, and they identified the activin signaling, and then they identified the activator for that. So this is the kind of a rebalance that happens between the proliferative and the anti-proliferative mechanism. That is what is sotatercept, and now there is good evidence in both early disease, established disease, and advanced disease that this drug can really change. And Stellar really showed around 84% relative risk reduction in event. And everybody thinks that sotatercept is a new paradigm change. And the patient, that limited number of patients that we have been using, it's really doing wonderful. But the real problem is the cost. Like so, now the people in the US are suggesting that sotatercept should come higher up the ladder, like higher up in terms of where do you use it. So I think you can. How do you follow up the patient? I told like very simply, like the patient is doing well, not doing well. But how do you do that? So it is very simply done with what is known as 4 strata risk stratification. This is not a rocket science, it's very simple. So points are only for WHO functional class, 6-minute walk distance, BNP or NT-proBNP, that's it. So that's all you have to assess, and this is the low risk, intermediate, high risk and high risk. So based on that, you have to reclassify patients into this range, and then based on this, you have to either intermediate, high, supposed to start prostanoids, but which are not available in the country. Then intermediate low, you are supposed to add selexipag or switch from PD5 to riociguat. So let us revise again. It's so simple. I think no other disease in the world will be so simple. Start with ambrisentan, tadalafil, or macitentan, tadalafil. If the patient is doing well, do this 4 strata classification, which include just 6-minute walk distance, WHO functional class, and NT-proBNP. That's all. Nothing else. Do this 4 strata classification. If the patient is doing well, leave them alone. Just keep them patting on, go on, and just talk to them. That's very important, because it's young female mostly, just suddenly something comes out and they think their life is only 5 years, 6 years, which is worse than many cancers actually. So that I think keep them positively reinforced if they're doing well. If they're not doing well, add selexipag, assess whether they are suitable for sotatercept. I think all across India for the last 1 year, I think only 75 patients are able to afford it. So that is where we are with respect to sotatercept. I think you have to add selexipag in most of the patient, or consider switching sildenafil, tadalafil into riociguat. So that is a sequential approach that you should follow. If they are not doing well, don't treat without right heart cath. Send the patients to right heart catheterization. There are very many centers in this country where there are specialized PH clinics are running. At least advanced patients you should send. And these are the very many possible. If these things have failed till now, what are the things that are left? You have to go for VA ECMO, right atrial septostomy, atrial flow regulator, pod shunt, and lung transplantation. So this is going to be my last 2 slides. This is another disheartening thing that I have to tell. I get a lot of referral for lung transplantation and heart lung transplantation in Eisenmenger syndrome without not even doing a 6-minute walk distance or a pulmonary or the exercise capacity assessment. So just the disease doesn't need a lung transplant or a heart lung transplantation. Many of them can lead a reasonably good life. That the label alone does not mean they need a transplantation. So you have to do and then assess at least REVEAL score. And if there is a significant risk, high risk REVEAL score of greater than 7, you are supposed to get lung transplantation. Your REVEAL score, that means you have to do a right heart catheterization. I find a lot of patients referred with not even with a 6-minute walk distance, without an NT-proBNP, and without a right heart catheterization for lung transplantation or a heart lung transplantation. So I think we should avoid that and then properly practiced. I think my last slide is going to be this. This is what is the real problem India faces. So the number of molecules of sildenafil, tadalafil, ambrisentan, bosentan sold in this country is at least 10 to 100 times the number of estimated IPH and Eisenmenger in this country. On one extreme, we get regularly patients who are benefiting from the therapy, asking us to stop therapy. On the other extreme, physicians are outrightly prescribing sildenafil. Just like cardiologists do this routinely. I know, like PR velocity of 40, greater than 40, they write sildenafil, add sildenafil. Think about it later, what happens. So that reflects starting sildenafil should stop. We should understand it's so simple. Right heart catheterization is mandatory, but I think understand that this is one disease where possibly we should avoid this Indian double whammy, and where I think a right decent physician is needed for overall evaluation and management. Let us be a good decent physician first. Now don't be the intervention cardiologist, the stentologist and the valvologist. Like. So thank you for patient listening.
Thank you very much, Dr. Ramakrishnama. You have asked the question to the audience. Now audience can ask the question.
So as I told you, like first therapy is always surgery. So surgery is also like we'll have a discussion on that. So we'll have a discussion a lot of this. Surgery also is like a graded thing. Like it's not like, for example, like every center has different expertise in surgery. Pulmonary endarterectomy is not an easy surgery. So every center has different expertise. I think unless you get a reasonable opinion from a high-end, high-volume center, don't label them as inoperable, or at times even consider for redo surgery. So redo surgery has been done and there is a residual pH. Then there is an option of starting them, or while they are waiting for surgery, you can start them on riociguat. So riociguat is kind of a first-line agent because somehow surprisingly effect is more on the drugs. Trial is also first done with the CTPH situation. So possibly the first drug is that. If the patient is not improving, then you can add a ERA. So that is how we go as a routine practice. But there also now what is excitingly coming up is the balloon dilatation. Like in patients who have residual lesions or failed or who are not suitable for endarterectomy, where there are peripheral thing, there can be multiple staged balloon dilatation is possible today's time. So all this has to be considered. So let us consider like group 4 pH with anybody with CTPH should be referred to specialized centers who can care for it.
Even after endarterectomy, should they be put on riociguat?
When there is residual pH. Some of them are absolutely cured. Some of them PA pressures nearly normalized. Then our routine is to do a continued treatment for at least 6 months to 1 year and do a right heart catheterization and document PA pressures are normal and then stop it.
Which ERA would you suggest? Ambrisentan, macitentan?
I think anything, macitentan or ambrisentan is fine. Any of them is fine.
Thank you.
Sir, nice presentation. What is your choice of drug for primary pH or Eisenmenger pH? First initial therapies, any change is there?
So I think as I told you, like maybe I rushed through, maybe the IPH is very clear. Always dual therapy to start with, and then you add selexipag or switch over to riociguat. That is the standard. But Eisenmenger is totally different. Like for example, Eisenmenger, the average longevity of Eisenmenger today is around 45 to 50 years. Most commonly we see an Eisenmenger at around 25 years of age, 20 years of age. So they have around 25 years to go. You don't lose much by doing stepwise. You don't have to rush through, okay, because this is a killing disease. The longevity is 3 years, 4 years, where you want to aggressively treat with 2 pathways, 2 agents to control everything. Here what we are dealing with is like a longer natural history. Having said that, same Eisenmenger in clinical heart failure with syncope, with right heart failure, or there is a TR, or there is a right heart failure, everything is happening. I would start with a dual therapy first, upfront. But in a routine standard Eisenmenger who has a reasonable walk distance, everything is borderline, then I would start with bosentan, which is the most well-established therapy or most well-studied in Eisenmenger. Start with bosentan and then stepwise escalation into tadalafil if required.
So my patient is DORV VSD pH at 10 years of age, saturating 80%. So first time they come to me and diagnose. So that time I should start bosentans.
So that's a different, maybe 80% I will start. But a lot of our patients come, say, when there is a borderline operability. Maybe this is a pediatric allergy discussion.
Yeah.
So there is now a separate group that has been coined now, which is left to right inoperable. So left to right inoperable means patient has not Eisenmengerized classically, but he is inoperable. So in that case, we don't know whether by starting them early, whether we are going to improve outcomes or not. So we really don't have any data. So in starting it in a kind of a early Eisenmenger who cannot be operated. So if there are clinical symptoms, if there is increased 6-minute exercise capacity in any form, or if there is elevated NT-proBNP, I would start them on bosentan. If any of them are not there, if the saturation is say 90, 92, but you've done a cath, your TERK is inoperable, and the 6-minute walk distance is 400. So I don't treat them. I tell them just if you develop symptom, you come back. Then we'll start.
Thank you, sir. Having low risk or intermediate risk, is there any subset of the patient with intermediate risk in PAH where you would like to start triple therapy from the onset?
So patients with the right heart failure and RV dysfunction.
Would you consider it at intermediate risk or high risk?
So it is high risk. Like it's like there are two ways to class. I don't want to confuse you that I stopped here. But if you classically look at it, at the first initial evaluation, you are supposed to do a three strata classification. So by that it will be low, intermediate, or high. Whatever be it, you are going to start with 2. Anybody in high risk, you are supposed to start prostanolone directly. But we don't have prostanolone, we will start selexipag.
So any intermediate group patient, where would you start triple therapy from the start?
So generally no. Generally we'll start with dual therapy and see the response, because the problem here is some of them respond very, very nicely. Patient may be very sick, but the moment you start, they will become totally all right.
So there are certain studies where it says that if the patient has intermediate risk and the patient has pulmonary vascular resistance more than 12 or right atrial pressure more than 20, then those are the patient, despite being in the intermediate risk, should be started on that.
So you put them in the reveal score, same numbers, it will become high risk. Like.
Thank you.
So that will the same thing. Like for example, this is another very important conceptual understanding that everybody should have who wants to treat PH should have. Is we all, like us, initially when we started practice also, we also look at the moment a patient comes, do an echocardiogram and look at the TR velocity. That's our first aim. Okay, we started treatment, TR was 85, it has become 55. Patient is happy, you are happy. Stupidity. Absolutely wrong. Patient's prognosis doesn't depend on that number. Nobody has shown that 85 TR velocity is worse prognosis compared to 64 TR velocity. No data is there. Same way in cardiac catheterization is also there is no data. So what is the conceptual understanding every student here should have is the prognosis in PH depends on not the absolute PH number, but on how the heart is reacting to that. So why RA pressure is important? At 80, somebody's RA can be failing. At somebody, right heart will be failing. That is why RA pressure is increasing and there is low cardiac output. But somebody can tolerate 100 pressure and RA can be normal. RA can be 2, 4. The cardiac output is well maintained. So that is the crux that we are not able to understand. So the prognosis in PAH depends on RV function and how the cardiac output is maintained and the filling pressures are how they are there. So that is why RA pressure is very important. That is why cardiac catheterization is absolutely important. That information you cannot get from echo.
All these been taken care in reveal 2 and 3 strata risk calculated score. So first you do it. If it is a high risk category, then you can start the triple therapy.
So, it's a great honor for us, you being here. And I'll take this, take this opportunity to have just one question. Being a pulmonologist, it's like unrelated to your topic. In the patients of ILD, while doing right heart catheterization, vazing becomes difficult. And sometimes the patient has low vazing. And then the pulmonary artery vase pressure comes, low, which should be high. It comes, or which should be normal, it comes low, despite having left heart disease. And then it said that we have left ventricular in-diastolic pressure as the judging criteria. My question is, why don't you use, if these are the difficulties, why don't you use left ventricular in-diastolic pressure as a surrogate marker for the pulmonary vascular resistance?
So I think this is routinely practiced. Like the problem is that when we get a good wedge pressure, we always use it. When we don't get a good wedge pressure, we always use end-diastolic pressure.
So why don't the guideline accept the directly measured left?
Because many countries they don't catheterize the left heart at all. In a routine right heart catheterization that happens routinely, they just take an ABG from the artery. They don't do an arterial puncture. They do the right heart and come out. The artery is not punctured. It's a OPD procedure. They go from the jugular. So if you go to Germany or US, all the patients are IPH get every 6 months or 1 year they get right heart catheterization done. They come in the morning, routine tests are done. They get a jugular access, one go, cath done, 2 hours discharged. So that is what is being standardized. So they get an ABG done for arterial saturation.
Pulmonary wedge pressure is always better than a left ventricular end diastolic pressure in the sense, suppose when you are talking about pulmonary wedge pressure, you know, if there is no mitral stenosis, suppose you have got a mitral stenosis, then pulmonary wedge pressure will be a better option than a left ventricular end diastolic.
So it's a very important point, practical point is that you can assume pulmonary capillary wedge pressure as LVEDP as pulmonary capillary wedge pressure, provided there is no obstruction in between. Any mitral inflow obstruction, pulmonary venous obstruction, anything, that pressure will be high, this pressure will be low.
Thank you, Dr. Ramakrishnan, for a wonderful lecture and wonderful discussion. Since we are running late, we would like to close the session here.
Thank you all the speakers and the chairpersons. Now we move on to our next session, which is a panel discussion. Case-based panel discussion, idiopathic PH, from early recognition to management. To moderate this session, I will call upon Dr. K K Sharma sir, and the panelists for the session are Dr. Aditya Agrawal sir, Dr. Amit Sharma sir, Dr. Madhur Joshi sir, Dr. Mehul Agrawal sir, Dr. S.K. Madhukar sir, and Dr. Sanjay Khatri sir.
Hello. So good afternoon to all. I thank CIPLA Eternal Hospital for making this program possible. And PH is, as you said, it's very uncommon, but delayed diagnosis is very common, if you ask me. Then patients frequently pass through multiple consultations before the possibility of PH is considered. So through one evolving case, we'll discuss how to recognize PH early, how to establish the diagnosis systematically, stratify risk, and select an appropriate treatment strategy. So we have an expert panel comprising of Dr. Sanjay Khatri, who is pediatric cardiologist from Mahatma Gandhi Hospital, Dr. Amit Sharma, rheumatologist from Fortis Hospital, S.K. Madhur, leading pulmonologist at Patna, Dr. Madhur Joshi, pulmonologist at RHL, Mehul Agarwal, pulmonologist Mahatma Gandhi, and Aditya Agrawal, leading pulmonologist at Sri Ganganagar. So who is she? She is Mrs. Y. And who is Mrs. Y? So she is a 32-year-old school teacher who presented to us with progressive exertional dyspnea for 14 months, fatigue, palpitations, reduced exercise tolerance, and occasional dry cough, no fever or wheeze. So, panelist, looking at this history, any one initial definition which comes to your mind? ILD and anemia, okay. Any other differential?
So it could be pulmonary, could be cardiac, could be vascular, could be functional.
So a young patient with progressive dyspnea might be ILD, might be anemia, might be anything else. Anyone else wants to add something? So patient was diagnosed in asthma and she was treated as asthma for 1 year with inhaled bronchodilators. She got no improvement. So what is the most probable likely initial diagnosis? Poorly controlled asthma, anxiety, ILD or pulmonary hypertension? A, B, C, D. A, anything else? Any? Okay. So Dr. Amit, in a history, which features should make us urgently consider pulmonary hypertension when you see symptoms in history? Can you enumerate?
So the first thing is the exertional dyspnea, which comes to our mind, and then the easy fatigability or this reduced exercise tolerance. These are the two most common symptoms which we think that patient might be suffering from any pulmonary hypertension.
Any red flag sign or any alarming sign?
So it is not noted, but that definitely the exertional syncope is the red flag sign for pulmonary arterial hypertension.
So on further asking, patient had got 2 episodes of exertional syncope. So what we get important clues in history for diagnosis PHS, there is progressive unexplained exertional dyspnea, disproportionate exercise limitation despite absence of over respiratory symptoms, fatigue, palpitations, and young patient without any obvious cardiac and pulmonary disease. Red flag being is external pre-syncope or lightheadedness. It is concerning because it may reflect inability of the right ventricle to increase cardiac output during exercise. Which further tests or which further histories should be asked in a patient with initial presentation which suggests PH? Any history you want to ask? So we need to ask history about CTD, any thromboembolic disease. So in our patient Mrs. Y, there was no CTD related symptoms, no thromboembolic history, no liver disease, no congenital heart disease, no drug or appetite suppressant exposure, no family history of PH or sudden death, no history of any previous cardiac or lung disease, and there was no snoring or daytime somnolence. Physical examination, BP was normal for her age and it was around 110/70. Pulse 96 per minute regular. Respiratory rate was 18, SpO2 96% of room air, and JVP not elevated. There was prominent right parasternal heave and loud P2, clear lung fields and no peripheral edema. Routine blood investigation including CBC, RFT, LFT and thyroid function were normal. So now we got a patient who is a 32-year-old female with symptoms and signs suggestive of PH. What do you say? Can we call now this idiopathic PH? A, yes or no?
Still no.
Still no. Why?
With your history, with a pulmonologist point of view, I'll have 3 differential diagnoses in my mind. The first is, pulmonary hypertension because of any reason. The second is sarcoidosis. Your patient has cough, extreme fatigue, breathlessness, syncope, palpitation. All these can occur in pulmonary sarcoidosis with cardiac involvement, pulmonary and cardiac sarcoidosis. Third is Sjogren's ILD, where the patient will have extreme fatigue and the patient will present in the same way. So these 3 differential diagnoses are coming to my mind. Even if the patient doesn't have the CTD features, we need to have a serological evaluation of these patients. The second, we still do not have lung function test. We do not still have the HRCT or the imaging. So before these basic tests, I will directly jump to the idiopathic.
Rightly said. So history is suggestive but not diagnostic, and idiopathic PH is a diagnostic of exclusion. So again, I come to the Mrs. Y, and what will you order first in this patient? ECG, a chest radiograph, spirometry with DLCO, 6-minute WASP test, echocardiography, NT-proBNP, CT pulmonary angiogram, or RHC. So I'll make it a bit simpler. A is 1 to 5, means ECG till echo, then add NT-proBNP, add CT pulmonary angiogram, or do all. Initial test when a patient comes to you suggestive of pH? Anyone? Where are you? But I think till anti-proBNP, it can be done everywhere right now.
So 1 to 6, 1 to 6.
1 to 6, perfectly. So these are the suggested initial test: ECG, chest radiograph, PFT with DLCO, 6-minute walk test, anti-pneumonia echo. Because apart from diagnosis, it will also help in initial risk stratification. So this is ECG for a patient. Dr. Sanjay, can you explain the ECG findings?
Yeah, first as a ECG, we should see the rhythm and the rate. So rhythm is okay, rate is okay. Now what is the alarming? In V1, I see the tall P wave and axis is extreme right axis deviation. So then the alarming thing is tall R wave in V1 and deep S wave in V5, V6, which indicate RV low. Then T wave repolarization changes are there, which says RV strain pattern. And few leads, we are seeing the P also tall. So we P pulmonale. So P pulmonale, tall V in V1, V2, and tall S in V5, V6, and ST changes are there, inversion. All suggest RV strain pattern. So
Okay.
PA pressures are high.
So can you suspect pulmonary hypertension from this ECG?
Yes, we can.
Yes. Okay. So in ECG, we can see right axis deviation, rightly said by him, right ventricular hypertrophy, right BBB, right ventricular strain pattern. A normal ECG does not exclude pH, particularly in early disease. However, right heart strain support the need for urgent evaluation. Yeah. Supra? Cardiologist can better explain this. Okay. Mike. So, Dr. Sanjay, which ECG feature in a symptomatic patient would make you expedite referral? It is a feature. What you see in the ECG, you think patient should have a referral?
RV strain pattern, V1 in RV, Q word followed by R, and then T wave changes. So something is wrong with the RV, and axis also indicate. So it's urgent preference for PA.
Yes. Apart from these arrhythmias also, I think. Yeah. I'm not asking about this ECG, any patient.
Yeah.
Yeah. So a chest X-ray was done. Anyone who can want to comment on this X-ray? What one thing you see in this X-ray? Dr. Megaox, pulmonary artery enlargement, perfectly. So in a patient with large pulmonary arteries in clear lungs, think of pH. Apart from enlarged pulmonary arteries, you can see peripheral vascular pruning and right atrial, right ventricular enlargement. A PFT was done for the patient next, and volumes were normal, but you can see a DLCO which was 55% moderately reduced. So Dr. Madhukar, spirometry looks normal, but DLCO reduced. So how would you interpret this? And what are the important differentials at this point?
So for me, if the FVC is preserved and DLCO is falling down, the first thing that would come to my mind is pulmonary vascular involvement that we need to rule out. So this is the first thing. The another thing is in the patients with ILD, the first parameters that go down is DLCO rather than FVC. So it could be early ILD without pulmonary vascular involvement, or it could be pulmonary vascular disease.
Rightly said. So normal. It was normal. The CBC was normal, so hemoglobin was normal. So 6-minute walk test relieved a distance of 330 meter without any significant desaturation. So rightly said by Dr. Madhukar, we can see disproportionately reduced DLCO in PAH, pulmonary veno-occlusive disease, SSC, PH, early ILD, emphysema, anemia, and CPFE. Pro-BNP was done for him, which is 620. So what does it signify? It is important because it reflects myocardial wall stress and used for baseline severity assessment, risk stratification, follow-up, treatment response, and prognostication. But you need to keep in mind that it is also elevated in left heart failure, renal dysfunction, acute P, arrhythmias and advanced age. So now echo was done for her. Dr. Sanjay, so what does this echocardiographic image do? I'll label it. This is, and compare with normal also. So you can explain it on a better.
So echo shows RA-RV dilated, septum deviating towards the left side. So these are the parameter in the still frame. We can say something wrong in the RA and RV side. So pressures are increased, and there are very indices we can calculate by this, by RA area, then RV fraction, then TAPSE, which Hemant discussed very nicely all the echo finding in pH. So by this we can tell what is the degree of pH, how severe is the pH is by taking the TR gradient, PR gradient, PA end diastolic pressure, PA mean pressure, which give us some idea how we are dealing with. And the ventricular eccentric index, which we calculate by, it should come generally 1, but it's more than 1. It signifies that septum is pushing towards LV. So it's some serious issue is there in the patient.
Okay, so these are numerical findings. TR velocity was 3.5, dilated RV, mild right atrial enlargement, TAPSE was 17 mm, septal flattening was there, RVSP was approximately 58, and normal LV systolic dysfunction. So, Dr. Sanjay, which echocardiographic findings suggest pH and which parameter carries the greatest prognostic value? So, from which finding you can say it is pH and which is prognostically important basically?
Previous discussion also Ramakrishna sir mentioned numbers are not important. Our clinical sense to interpret the echo. In my appearance, in my setting, the RA dilatation and the appearance of pericardial effusion is the worst prognostic sign in the pH. If I see the degree of pericardial effusion, I label it's a severe pH. Yeah, it's TR of 60 with the normal RV function is considered to be not severe, but if TR is less but RV dysfunction is started, it's considered a severe pH. So we consider all the parameter in total, see the IVC, cholesterability, RA dimension, RV fraction change, then strain pattern, we all calculate all these things. But if you see in any echo, a rim of pericardial effusion appear, it's always poor prognostic sign in a pH patient.
Okay, so to summarize, TR velocity is central to assigning echocardiographic probability and prognosis more closely related to RV function. So, another question I think you all be able to answer this. Does echocardiography diagnose pH? Yes or no? No. So, it estimates the probability of pH, it assesses right ventricular structure and function, it identifies potential left heart or congenital disease. Dr. Madhur, then what is the role for 2D echo in evolution of pH?
So I think as far as the case is concerned, so we are still having a high diagnosis, high chances of diagnosing it as pulmonary arterial hypertension, but it is not the diagnostic test. So it's a good screening test. Maybe it differentiate between the left heart and the right heart and the other congenital heart diseases. And if at all, we may assess the functions of the right heart primarily, whether it is in failure or not. But it cannot be the diagnostic test so far, even the transthoracic echocardiography.
Rightly said. So, now this is our patient, Mrs. Y, 30-year-old school teacher, signs, symptoms, history of pH, ECG, chest X-ray, NT-proBNP, PFT, 2D echo, all suggestive of pH. So, what to do next? This is for audience. Start treatment immediately. Repeat echo after 6 months. Order CT pulmonary angio, give diuretics and observe. And refer to a center where a comprehensive evaluation can be done and RHC can be done. E. So Dr. Mehul, why? Why it is important before starting a treatment, a comprehensive evaluation RHC is important in these patients?
So, sir, as Dr. Madhur sir has already told that echo is an excellent screening tool, but it does not establish the diagnosis. Moreover, before we start specific anti-pH therapy, other etiologies should be ruled out like left heart diseases, lung diseases, or chronic thromboembolism. So right heart catheterization remains the gold standard for diagnosis because it not only establishes the diagnosis, it can differentiate between pre and post capillary pulmonary hypertension. It can accurately measure the pulmonary vascular resistance, and in some subset of patient, acute vasoreactive testing can also be done. So we can find out those subset of patient who can be responsive to high dose calcium channel blockers. So before we start patient on a specific anti-PS therapy, RSC should be done.
Surely. So comprehensive evaluation is important to differentiate between the groups and to exclude other groups. And RSC confirms hemodynamic phenotype and provides baseline prognostic measurements before starting the treatment. So this is a diagnostic pathway. You suspect a patient of with PH, do echocardiogram and confirm at an expert PH center. So now we come to again our patient. So what to do next? Or we already discussed this. What to do next? Anyone?
Right heart catheterization.
Before right heart catheterization, anything? Yes, you need to exclude other causes. So this is very important. I'll take some time on this slide basically. So Dr. Aditya, so why it is important to classify these patients than simply confirming the pH?
Yes, it is very important to classify these patients because PH itself is not a disease. It is basically a syndrome. So the prognosis, the management varies with various groups, and the drugs which are specific for PH are only reserved for group 1. In other, we have to treat the cause. So it is very important to classify various groups and then do accordingly.
Rightly said. So because these groups have different pathophysiology, prognosis and treatment. So before starting treatment, it's very important to classify the pH in which group it belongs. Dr. Amit, so is CTD associated pH clinically and prognostically different from idiotic pH despite both belonging to group 1? So what is the difference between these two?
Yes, definitely the CTD pH is clinically and prognostically different from idiopathic pH, though it is in group 1, but it overlaps with other groups also, like interstitial lung disease, or if you have a cardiac fibrosis, or you have a secondary Apla syndrome causing thromboembolic phenomena. And definitely there is a severe autoimmunity and vascular inflammation that is involved in CTD pH, unlike idiopathic pH, where the lesion is in only the lung. Other than that, we need the CTD pH respond good to the anti-PH therapy along with immunosuppressive therapy. But definitely the prognosis is poor in CTD pH compared to idiopathic pH. And because of this poor right ventricular adaptability.
So what do you think? A patient with systemic sclerosis related pH with the idiopathic pH, which would respond better to the treatment comparably?
Idiopathic pH.
Idiopathic, definitely. So these patients with CTD related pH are complex and they usually respond to treatment not as well as other idiopathic pH groups. Dr. Madhukar, coming to group 3 pH, so what do you think? Which investigations are essential to exclude this group?
I think you have done the lung function test. At this point of time, we need HRCT. That is must here because your patient has low DLCO, which is quite unusual with idiopathic PAH. So what at this point of time I'm thinking of having CTD panel test to rule out the CTD.
I just want you to delineate the test basically to rule out group 3 pH as a general. Yeah.
Group 3 is lung function test.
Yes.
6-minute walk distance test and the HRCT.
Rightly said. So you need a complete PFT with DSCO, ABG, resting oxygen saturation, HRCT chest, overnight oximetry or polysomnography when you suspect OSA, or in some cases exercise testing or CPET when symptoms remain disproportionate. Again, as already been discussed, the extent of lung disease must be assessed against the severity of pH. Say if a patient is having a very severe pH and you can see a limited infiltrates on the CT, then you need to consider an alternate diagnosis. Again, I am coming to this chart, Dr. Mehul. So why should every patient with newly diagnosed PH undergoes evaluation of CTEPH? Even if he's not having history for P or any other obstructive diseases. veno-obstructive disease.
So because nearly in 1/3 of the patients of CTEPH, they don't have a prior documented history of acute pulmonary embolism. And all the newly diagnosed patient of PH should be evaluated for CTEPH because as Ramakrishnan sir has already told that this is a potentially curative entity. We have a definitive surgical option like in the form of pulmonary endarterectomy, and even if the patient is not a surgical candidate, we have other alternative good options like balloon pulmonary angio or the medical therapy in the form of Riosigate. So all the patients who are newly diagnosed PH should be ideally subjected to a VQ scan, because a normal VQ scan essentially rules out CTEPH, but if it is abnormal, the patient should be evaluated further, because missing CTEPH means missing a potentially curative disease entity.
Rightly said. So it is very important to recognize CTEPH because it may occur without a recognized previous PV, and it is important not to miss it because it is potentially curable. Already been discussed, which is the best screening test for CTEPH? VQ scan, yes. So VQ scan is the preferred screening investigation. In our patient Mrs. Y, it was normal. So a normal perfusion scan makes CTEPH unlikely, but a normal CT, as already told by Dr. Ramakrishnan sir, a normal CT pulmonary angiogram insufficient to occlude CTEPH because you can't see chronic distal lesions, webs, or perfusion defects which may be missed. So next is to exclude other associated pH. The test, these are a battery of tests which we can do to exclude other causes. And in our case, ANA was negative, ENA was negative, HI was negative, liver function already told you it was normal, abdominal ultrasound was normal, and there was no congenital shunt on contrast echo. So next, you should do a genetic evaluation. Dr. Madhur, which are the patients who should go on genetic counseling and testing in apparent idiopathic pH?
So I think this particular patient is an ideal candidate to evaluate for genetic evaluation because we are now labeling her as a group 1 pH. So she is a young lady without any other comorbidities. We have ruled out cardiac entities. We have ruled out all the pulmonary entities. We have ruled out other autoimmune entities as well. So I think she's a young patient with a family history who is landing up in a pro forma with the idiopathic cause for a pulmonary arterial hypertension is an ideal candidate.
Any other pH group where you should need to do a genetic test?
So young female who are with a history or maybe young with the idiopathic labeling of pulmonary arterial hypertension should undergo.
So this is list of the cases where it should be done: idiopathic pH, heritable pH, familial cases, young patient, patient with features as your PVOD, and patient with congenital and syndromic features. These are the genes which needs to be tested. So again, Mrs. Y, a pH case, other probable causes excluded. Now what to do next? RSC. So rightly said by Dr. Madhukar, RSC was run by Dr. Sanjay. And these were the results. Can you explain, Dr. Sanjay?
Yeah, 3 parameter we see quickly in this. So mean PA pressure is 42, suggestive of pH. Then PVRI 8 would, again it's a pH. And another critical point is pulmonary artery wedge pressure 9, which is less than 15. It indicates it's a pre-capillary. So with these minding, our diagnosis will be narrowed down that we are not dealing with any left-sided lesion or post-capillary shunt because PA wedge is 9 only. So that's the information right heart study gives us.
Okay, so this table has already been discussed and it is very important when you are looking at RSC. So in your patient, PAP was greater than 20 and PAWP was less than 15, PVR greater than 2. Right? It is pre-capillary pulmonary hypertension diagnosis is consistent with idiopathic pH. Dr. Aditya, what to do next? What do you think in which pH subtypes you do vasoreactive testing?
Yeah, we should go for a vasoreactive testing, specifically in this idiopathic pH, because after testing, if they respond very well to high dose calcium channel blocker, then there might be a favorable prognosis compared to the other categories.
So it is recommended primary for idiopathic pH, heritable pH, and any patient with drug or toxin associated pH. Preferred agent being inhaled nitric oxide, inhaled ilioprost, and inhaled, IV epoprostenol, if centers are experienced for doing this. Positive response to vasoreactivity testing means fall in PAP by at least less 10 mmHg. Final PAP should be less than 40 and cardiac output should remain unchanged or increase. So in our patient, our vasoreactivity testing was done with inhaled NO and mean pulmonary artery pressure falls from 42 to 39 and cardiac output remains preserved. So if this is a positive vasoreactive test, no. So it is very important because only 2 responders should receive high dose cancerogenic blockers. Next is to do our risk stratification. So Dr. Amit, why is risk stratification important in pH?
So there is a new concept of treatment now which is coming into our practice is treat to target. So risk stratification is important when you are treating a patient of pulmonary arterial hypertension in follow-up. So and you should always target a patient in a low risk group. So because if patient is doing well, she has adjusted her lifestyle in such a way that she is not feeling breathless. But if you go with the stratification, might be she is coming into intermediate group. So you should escalate or you should modify the treatment to bring her into a low risk strategy. So treat to target is you modify your treatment and treat your target.
Rightly said. So at diagnosis, a 3-strata model is used which incorporate full hemodynamics, low, intermediate, high, but at follow-up, 4 model, low, intermediate, high and high. Most important parameter which are used is functional class WHO, 6-minute walk distance and NT-proBNP. So it is important for initial treatment intensity, timing of parenteral prostacyclin, frequency of reassessment, need for escalation and timing for transplant referral. Most important thing, with this we can find whether the treatment goal has been achieved. So treatment goal in this patient is to achieve and maintain low risk profile. So these are 3 important things. WHO functional class, 6-minute walk distance and NT-proBNP should be done at initial point and at the time of follow-up. At follow-up, hemodynamics and echocardiography is also important. I'm not going in detail. This is 3-strata model, which should be done at initial pH diagnosis, and this is 4-strata risk model, which is you should be done at during follow-up, which includes WHO functional class, 6-minute walk distance, and proBNP. So this is a summary. So goal of therapy is to achieve and maintain low risk status. In our patient, she was WHO functional class 3, 2 episodes of pre-syncope, 6-minute walk distance was 330 meters, NT-proBNP was 620, cardiac index was 2.3, moderate RV dysfunction, no overt heart failure. So what is her basically risk stratification status? So if we calculate its intermediate risk, so there are multiple parameters with which we do risk stratification, not on a single variable. Now, next important question. You have diagnosed pH, you have done a risk stratification, now you have to start the treatment. So which is initial therapy which is appropriate for this patient? Sildenafil alone, macitentan alone, ERA plus PDE4 inhibitor, CCB, and immediate IV epoprostenol. Dr. Madhukar, what should be your initial treatment? See, anyone differs? Rightly said. So this is very important. Any patient who is vasoreactive without any significant symptoms, initial therapy should be oral CCBs. In non-vasoreactive patients who are stable, initial therapy should be a combination, and in non-vasoreactive patient with significant chest pain, syncope, high WHO functional class or other high risk finding, you should add IV or subcutaneous prostacyclin in addition to dual therapy. So this patient was started on macitentan 10 mg once daily, tadalafil 20 mg once daily, increased to 40 mg when the patient tolerated, education regarding pregnancy avoidance, and exercise and rehabilitation after stabilization. So, Dr. Madhur, what do you think? Which are the key counseling points should be discussed at the time of initiating therapy?
So it's very important to tell the patient that all the therapy that would be prescribed as we have chosen will not be curative. It's only going to preserve her functional class and symptoms, and probably the worsening of the disease. And then we have to advise her with certain non-pharmacological treatments as well, like vaccination and exercise, whatever is suitable as per her age and other comorbidities. So the first thing is that she should understand, this patient particularly should understand, it's not a curative goal that we are achieving. It will be just to preserve her symptoms and to prevent her from progressing the disease to right heart failure.
So these counseling points are very important when you start the therapy, and this should be advised before she leaves your clinic. Dr. Mehul, when should the patient be assessed after starting therapy?
So the patient should be assessed after 3 to 6 months, and it should not be a routine OPD follow-up. It should be a comprehensive assessment, as has already been discussed. The aim of assessment includes the WHO functional class, 6-minute walk test, anti-pro-BNP, or 2D echo can be repeated. And our goal is to maintain low risk profile, and the goal is treat to target and not to treat and just wait and watch.
So rightly said. So as you can see, every 3 to 6 months, you have to reassess, and patient may improve or deteriorate. The goal is to maintain a low risk profile. Dr. Aditya, my final question to you. So what would you call adequate response to therapy at follow-up?
Yeah. So firstly, most important is WHO functional class. She should maintain, because she was of class 3 in our case. So she should be either on the stable side or it should improve on the class 1 and 2. Second thing, very important, is 6-minute walk distance, because she was, I think, having 320 meters initially. So at least 30 to 40 meter improvement from the baseline will say that the disease is shifted from intermediate to low class, or even if the same will work. And similarly, the anti-pro-BNP. In our case, I think it was 600.
660.
So it should either be reduced less than 300 is the ideal. And fourthly, we can go for an echo. We can see for the right ventricle functions. And then we can see whether there is a risk of hospitalization was there, whether she was hospitalized in the follow-up. And then I can also see whether there is a infection, whether there was there. These are the main things which I will look for it.
So rightly said. The aim is to maintain a low risk profile, and as I already told you, a 4 strata model should be followed on follow-up. So in our patient, at 4 months follow-up, she was WHO functional class 2nd, 3rd, no further pre-syncope, 6-minute walk distance was 390 meters from 330, anti-pro-BNP reduced to 310, and there was persistent RV enlargement. So what do you call? Is this a treatment success?
Though it is a composite score, but your patient is in functional class 2 and 3, still 2 and 3, it has not gone to 1. But there is good improvement in 6-minute walk distance test, and there is good improvement in anti-pro-BNP. So I'd still stick with the same treatment plan and will further follow up the patient.
So she has improved though, but she has not achieved the treatment goal. So improvement is not enough. Target when we are treating a patient with idiopathic PH to maintain a low risk profile. So reassess 3 to 6 months, evaluate response, and if it is inadequate, you can escalate the therapy, has already been discussed, Selexipag, Sotracept, and you can switch to Riosurrogate. Final rapid question, just to summarize from the panel one by one. Yes or no? Can echo diagnose PH? No. Best test to exclude CTEPH? Who should undergo vasoreactive testing? Yes. Treatment goal? We are again been repeating to maintain a low risk status. First line therapy for most intermediate risk patient without major comorbidities. Combination, and when should transplant referral begin? High risk before there is irreversible RV and an organ failure develops. So to all panelists, Final question, what is the single most common reason for delayed diagnosis in IPH in your clinical practice? Anyone? Any point?
Not
One.
suspecting pulmonary hypertension in our
Suspecting pulmonary. First. Second?
I think delayed referral is a very important thing because we clinicians are looking upon each and other cases. So I think delayed referral to a specialized PS center is one important.
Yes.
Symptoms are quite vague. On the initial presenting symptom is just the breathlessness. So the patients are being evaluated for other common causes of breathlessness before suspecting PH.
Okay. Anyone wants to add anything else?
Availability of your cardiologist friend for a right heart
For
catheter.
this has been discussed quite a lot. So, final messages. Think of PH in unexplained progressive exertional dyspnea. Any patient who presents with syncope or pre-syncope is a red flag. Echocardiography estimates probability. You need to do a RHC to confirm the diagnosis. Idiopathic PH is a diagnosis of exclusion. Risk stratification is very important because it helps in initiation of treatment and follow up the treatment and how to do the treatment. Initial dual oral therapy is appropriate for most of the patient, and high risk disease require parental prostacyclin consideration. Reassess early and escalate until low risk is achieved. I thank you all for your patient listening. Thank you.
So just excellent, exceptional presentation where I think you have brought out all the essential things about this. So I just have a few comments that I want to pass on, so which I think possibly I missed in the lecture also. So ask your radiologist to include the cuts of abdomen whenever you are evaluating for an IPH patient. That should become a kind of a standard for IPH prescription for CT, because Abernathy malformation is emerging as a very common entity where I think in our unit, I think we have seen around 75 patients till now of Abernathy. Otherwise, they are labeled as IPH like. So you just close that portal, the extra communication, their pH at least starts to regress or this remains stable. So I think tell all your radiologists to include whenever your prescription is for IPH, CTPA, always include an abdominal cut. That's point number one. Point number two is in younger children and adolescents, do not be happy with your only saturation. Always do an ABG also. So we have at least 5 patients with mitochondrial myopathy with PH. So their PCO2 was high. The first patient we diagnosed was very interesting, where he was admitted for being sick. He was treated as IPH, and we admitted him, and then we evaluated everything. Even right heart has been done. So some of you have never done an ABG, and immediately we put him on oxygen. He was worsening. Then we got his PCO2 done. PCO2 was 84. Then everything again restarted, and finally I diagnosed to have a mitochondrial myopathy. He was unfortunately a topper in the schools, and he was 12th topper or something like that. So mitochondrial myopathy is very common, and always do an ABG in younger children and this thing. The third important point is in patients who are otherwise doing well, who are not doing well. So always get an iron profile done, and we have yet to publish that series. We have done an RCT of giving IV iron like in heart failure therapy, IV iron compared to usual care, and the IV iron seems to be improving the outcomes. It's a 60 patient RCT. So I think in our patients, iron deficiency is very common. In patients who are established IPH, who are otherwise not doing well, always get their iron profile done, and at least oral iron, or if required, if the iron profile is pretty bad, ferritin is low, treat them with IV iron.
So I thank all the panelists. Thank you very much. Thank you. Thank you all for your patient listening. Thank you.
Thank you so much, Dr. Sharma, and all our panelists. So moving forward for the next session, session 7, I would like to request Dr. Ram Babu Gupta sir, Dr. Ashish Singh sir, and Dr. Sanjay Khatri sir to please chair the session.
Good afternoon, everyone. So, first of all, I welcome you all in session before lunch, and I would like to thank Dr. K K Sharma and Eton Hospital for organizing this CME on very important topic, which is very much underdiagnosed. So, thank you very much. So, first speaker, I would like to invite Dr. Vivek Singh. Will speak on pulmonary hypertension associated with pulmonary artery obstruction, diagnosis and risk stratification in acute pulmonary embolism. Now, Dr. Vivek Singh is Director of Respiratory and Sleep Medicine and Transplant Pulmonology at Medanda Hospital. Dr. Vivek Singh, please.
Thank you, sir. Good afternoon, everybody. First of all, thank you, Dr. Sharma and Eternal Hospital for inviting me out here. So we have all heard about pulmonary hypertension for the past few hours. I'll be concentrating on a very specific subgroup of pulmonary hypertension, which is group 4 or pulmonary hypertension associated with pulmonary artery obstruction. Over the course of my talk, we'll just cover about the continuum from acute pulmonary embolism to chronic thromboembolic pulmonary hypertension. We'll talk a brief about risk stratification, the fundamentals of CTEPH, what is the recommended diagnostic algorithm, what are the differential diagnostic criteria, and finally, what are the key takeaway messages from what we know about CTEPH. So when you look at acute PE and how does it lead to a chronic thromboembolic pulmonary hypertension. So as we know, this is classified as group 4 in pulmonary hypertension, and this is caused by obstruction to the pulmonary artery by a thrombus or any other cause. Now, when we talk of acute pulmonary embolism, so acute PE is the sudden thrombotic occlusion of the pulmonary arterial bed, usually from a lower limb DVT, though I must emphasize it's not exclusive, but most common is from a lower limb DVT. The spectrum of outcome follows from a complete clot resolution to early death to long-term pulmonary complications like pulmonary hypertension. Early management of acute PE is guided by risk stratification of the index event, taking into account parameters like hemodynamics, RV function, and the biomarkers. And later on, a question arises for survivors that who are at risk to develop CTEPH. So when we do the risk stratification for acute PE, the high risk category, so the determinants which are used to risk stratify these patients, one of the most important risk factors, the hemodynamics. Sustained hypotension or shock is the single strongest predictor of death. RV dysfunction on an echocardiography or CT is also a marker. Cardiac biomarkers like TROPS or the BNP or the NT-proBNP, which reflect the RV strain, and the clinical severity scores like the PESI score. Now, this is one of the scores which we use, and if you look at it, as the score increases, the 30-day mortality is shown to be higher. Now, once we have an acute PE, what all spectrum can we have? We can have a complete full resolution of the thrombus, which a majority of patients we can achieve. There can be a post-pulmonary embolism syndrome where the patients may have persistent dyspnea or exercise intolerance. Then there could be patients with chronic thromboembolic disease. That is, they have a clot burden, but they do not have features of pulmonary hypertension. That is, the mean pulmonary artery pressure still is less than 20. And finally, there are the CTEPH patients who have chronic thromboembolic pulmonary hypertension with a mean pulmonary artery pressure of more than 20 and a pulmonary vascular resistance of more than 2. Now, it is estimated that CTEPH develops in around 1 to 5% of PE survivors, and progression beyond 2 years of diagnosis is very, very rare. And up to 38% of patients with CTEPH may not have any documented history of pulmonary embolism. So a diagnosis of exclusion, it's a diagnosis of exclusion, but on vigilance and not on history alone. When we talk of CTEPH, so chronic thromboembolic pulmonary hypertension is caused by pulmonary artery obstruction from unresolved thromboembolic disease, which is a late complication of acute PE. It is classified as group 4. And then we have one is a chronic thromboembolic pulmonary hypertension, and other is because of any other cause of pulmonary artery obstruction. Why it matters, as it has been emphasized in the previous talks, CTEPH is really important because this one particular subgroup of pulmonary hypertension has a very different therapeutic strategy than other pulmonary hypertension groups. And this is one particular group where a surgical cure can be achieved and the patient can be completely normal. And of course, then we have newer non-surgical options also being available for residual disease after a surgical treatment is attempted. So how common is the CTEPH? As I said, most of the studies have shown around 1 to 5% of acute PE survivors develop pulmonary hypertension. And its incidence at around 2 years is around 2 to 5%. 38% of CTEPH patients do not have any documented history of acute pulmonary embolism, and it is very rare for CTEPH to develop after 2 years of the cardinal event of pulmonary embolism. Various theories have been propagated for the development of pulmonary embolism. The most common is the hypercoagulable state hypothesis, but there is evidence against and evidence for this theory. However, still it is the most commonly believed theory, but there is no unifying explanation that why certain patients develop the pulmonary embolism. And why doesn't every pulmonary embolism resolve? We have got therapies, we have got thrombolysis, then why doesn't it resolve in some of the patients? Again, various theories are there. It's believed that the system is overwhelmed by fibrinolysis. The CTEPH may occur when endogenous clot dissolving mechanisms are overcome by age, extent, or location of the embolus. The fibrin, which was derived from the CTEPH patients, was shown to be resistant to the plasmon-mediated lysis. Primary pulmonary arteriopathy or in situ thrombosis can lead to CTEPH. And the current consensus is that the thromboembolic basis is exactly not clear, but how this clot converts into a fibrotic vascular obstruction is still not completely understood. Now, predictors after an acute PE, so cardiac dysfunction, so RV, there can be an RV dysfunction. So RV dysfunction at the time of acute pulmonary embolism may be an independent predictor for development of subsequent CTEPH, and it reflects the degree of acute hemodynamic compromise from the index even. Looking on to predictors after what are the other factors for after an acute pulmonary embolism for the CTEPH to develop? Embolic burden, patients with unprovoked PE who have a large thrombus burden, who have recurrent embolic episodes, or if there is a diagnostic delay of more than 2 weeks in diagnosis of an acute embolism, they have a higher chances of developing CTEPH. Host factors, female sex, advanced age, non-O blood group, thrombophilia, other comorbid conditions like the shunts, indwelling IV lines, history of cancer, splenectomy, chronic osteomyelitis, all of them have been proposed to be factors which increase the chances of developing CTEPH, but none of these factors have been individually consistent or have been strong enough to justify the routine CTEPH screening after an acute embolic episode. So currently, as I said, there is no screening strategy after acute PE, but the threshold to suspect CTEPH should stay low. We should follow these patients clinically and pursue a targeted diagnostic testing in patients who report new or persistent symptoms despite 3 months of anticoagulant therapy. So proposed algorithm, in the previous case, we have already seen the algorithm and discuss the algorithm for diagnosis of pulmonary hypertension. So algorithm using a ECG and a BNP without echocardiography has been used to exclude CTEPH in symptomatic patients, but still this needs validation. So the bottom line is that these patients should be followed very, very closely, and if they develop new symptoms or worsening of symptoms despite being on treatment for at least 3 months, CTEPH should be suspected in these patients. Now, we have to differentiate between an entity called as chronic thromboembolic disease versus chronic thromboembolic pulmonary hypertension. So this is a disease where the post-embolic exercise intolerance is there with imaging evidence of chronic thromboembolic disease, but the resting mean pulmonary artery pressure is less than 20 on a right heart catheterization. That is, they have a clot load, but they do not have resting pulmonary hypertension. And a larger population have CTED rather than CTEF. The symptom mechanism from exercise tolerance is from increased dead space ventilation or the limitation of the right ventricle to increase the cardiac output in response to the exercise. Diagnostic needs, the confirmation is usually by a right heart catheterization, and CT does not reliably distinguish the thromboembolic disease from hypertension. And we should have a lower threshold to do a right heart catheterization in these patients. So what are the signs and symptoms of pulmonary hypertension? So as we said, progressive dyspnea, exercise intolerance, delayed presentation. Some of these patients may present with signs of frank right ventricular dysfunction, edema, exertional chest pain, syncope, which may be exertional or near syncope, and non-specific onset means CTEF is frequently mistaken for deconditioning asthma and anxiety, as has been talked in detail in the previous discussion about these patients are obviously missed and for various other diagnoses. So what are the clues pointing specifically towards thromboembolism? If there's a distant history of thromboembolism like pleuritic chest pain, leg discomfort, prolonged atypical pneumonia, months to years before the dyspnea onset. If there is a thromboembolic history which is often absent, this is, as I said, is absent in around 38% of patients. And we should be looking at eliciting subtle clues like long hospitalization, previous surgeries, which has been followed by exertional dyspnea or reduced exercise capacity. These patients might need to be investigated for pulmonary hypertension or particularly CTEF. Presence of murmurs, a loud P2 obviously will give you a clue, but I think we should have a very low threshold in such patients. Chest radiograph. Now, in the previous discussion, we were looking at the chest X-ray. I would say the chest X-ray is really not helpful in diagnosing pulmonary hypertension. A normal chest X-ray does not exclude a diagnosis of pulmonary hypertension. So classical appearance is enlarged central pulmonary arteries with peripheral oligomia, as has been talked in the previous talk. But a normal chest X-ray is not excluding pulmonary hypertension. So CTEF fine. So the diagnostic approach is, of course, an echocardiography, which is a screening test. If it raises suspicion of pulmonary hypertension, then VQ scan is the investigation of choice, not CT pulmonary angiography first up. We should be doing a VQ scan, which, if highly suspicious for pulmonary, which shows VQ mismatch defects, then we should go for a CTPA. Now, what we have to understand, CTPA is more to judge cases who can be operable versus inoperable, right? So diagnosis of CTEF is more from a VQ scan. If the VQ scan is a high probability of pulmonary hypertension, we go on for a CTPA to characterize the distribution of the clots and to rule out other causes which may cause pulmonary hypertension, embolic pulmonary, which may mimic embolic pulmonary hypertension. Right heart catheterization, of course, to differentiate between chronic thromboembolic disease versus hypertension, and then the diagnosis of the choice is digital subtraction pulmonary angiography, which will give you an exact mapping of how the clot burden is looking like. So when to suspect CTF? During a pH workup, if there is a segmental or a larger mismatch defects on a VQ scan, please suspect CTF. Obstructing thrombus is visualized on a CT chest. There's a documented history of pulmonary thromboembolism, or if there are pulmonary flow bruit, which is being heard on auscultation. And after a pH is confirmed, dyspnea or exercise tolerance with confirmed pH, any risk factors for CTEF or a modest resting pulmonary hypertension on right heart catheterization points towards a CTEF. VQ scan, as I've already told you, it is the preferred initial test, and typical finding is segmental or larger mismatched VQ defects. it is very good to rule out with a 96 to 97% sensitivity and a 90 to 95% specificity. And the limit, but it has certain limitations. It underestimates the central obstruction. So canalized standards can't let the tracer reach the periphery. I'll just skip through it. CT pulmonary angiography, we all know. And this is the gold standard, the digital subtraction pulmonary angiography, not very routinely performed at most of the centers, but centers which are highly specialized in treating pulmonary hypertension patients would perform it. This is the gold standards, confirms the diagnosis, and this determines the surgical eligibility of the patients. This is best performed in a CTEF center. And of course, there are certain safety concerns about it, but in an expert center, these can be very well performed. We have to rule out other causes of pulmonary artery obstruction, which, a VQ scan and the subtraction angiography will be able to do it. Other causes can be definitely sarcoma, certain uterine leiomyomas, or vascular causes like arthritis, or congenital pulmonary artery stenosis, and infections like hydatidosis. So what is the diagnostic criteria for CTEF? The best criteria that we learned: first, there's a confirmed pulmonary hypertension on a right heart catheterization. There is thromboembolic occlusion, which is demonstrated on imaging. And then we confirm the diagnosis of CTEF. The management, as I said, varies. Most of these patients are amenable to a definite surgical cure in the form of pulmonary endarterectomy, but this should be performed in a specialized center where there is a team which specializes, risk stratifies, and decides about the operability of the cases. So just to summarize, CTEF is a potentially curable form of pulmonary hypertension classified as group 4. It occurs in around 1 to 5% of pulmonary embolism survivors, but 38% of patients may not have a documented PE history. There are no validated screening tools, so clinical vigilance is very, very important. Diagnostic algorithm includes a VQ scan, a CTPA, and a digital subtraction pulmonary angiography. Diagnosis requires both hemodynamically confirmed pulmonary hypertension and imaging demonstrating thromboembolic occlusion. Early referral to a specialized CT center for surgical evaluation is very, very important because surgery can be curative in these patients. Thank you very much for a very patient hearing.
Thank you, Dr. Vivek, for nice presentation. You want to say?
Sir, always surgical, or anybody tried, intervention radiologist people try thrombosuctions if clots are probably in the only one PA which causing pulmonary hypertension, or always surgical?
So, CTEF, majority of load lying only in the central main arteries and causing such a pulmonary. So these patients would be more acute. I'm talking of 2 years post. So the clot load would be much more peripheral. So I think once the clot has gone into peripheral, where I think surgical endarterectomy is the preferred treatment of choice. Other treatments can be followed up for some residual disease if they can do it, or patient is a real poor risk surgical candidate.
As you are running late, we can take 1 or 2 questions from audience.
Probability of PH. And then there is a mass or tumor visible in the right atrium or ventricle. And we are thinking that this pulmonary hypertension is secondary to the pulmonary artery obstruction. Would you like to perform or take the risk of doing RHC in those cases?
I think, as I said, that when you're making a diagnosis of CTEF, I think right heart catheter, because the presence of a mere clot load on a CT does not mean that this is CTEF. As far as a tumor lying in the right ventricle or somewhere, the risk of doing a right heart catheterization, I think there cannot be a consensus statement on it. It has to be individualized, discuss with your cardiology colleagues that, okay, what's the probability and what are the risks of doing such a procedure for them.
Thank you. I really enjoyed your presentation, sir. Thank you so much.
Thank you very much.
That's a wonderful lecture, sir. Just a quick question from my side. This CTEPD and CTEF, Should I see it as a spectrum? CTEPD without pH. Should I see it as a spectrum?
No, I don't think it should be that all disease patients will progress onto pulmonary hypertension. No, not at all.
Because in CTEPD, we also go for this PTE and the BP as well. We do not go for the pH-based
I'm sorry,
therapies. In this CTEPD, we always go for the PTE and the BPA therapies. We do not go for the pH-directed therapies. So my question, in CTEPD, we misses this thing on echocardiography because there is no pH. Okay, but it is picked up in VQ scan because there is a bit of perfusion problems. Okay, so my question to you is very simple. First of all, should I see it as a spectrum? And second thing, if this perfusion issues is not creating pH, how my BPA and PTE going to cure the CTEF? Because in BPA and PTE, basically I am relieving the mechanical obstruction. Okay, so if it is not creating any problem, okay, if there is no remodeling in CTEPT, how it is going to affect the outcome? And if it is remodeling is the main issue for pH, how my BPA going to affect my CTF mortality or prognosis?
So if I get your question very correctly, so it's a spectrum. So there is an acute pulmonary embolism, there is a chronic thromboembolic pulmonary disease, and there is pulmonary hypertension.
Should I see it as a spectrum?
Some patients will have complete resolution. Some people will have embolic disease without pulmonary hypertension, and some people will develop chronic thromboembolic pulmonary hypertension. Okay. So these are three entities which we can, or three. Some will have an absolute resolution after an acute pulmonary embolism event. Some people will develop a disease without pulmonary hypertension, and some people will develop pulmonary hypertension. As far as diagnosis of this is concerned, it's not on an echo. It's very well documented. It's a right heart catheterization.
I agree.
Which, if the mean pulmonary artery pressure is less than 20, with radiography still showing clot load in the peripheries, it's a CTEF. It's not a CTEF, it's a disease, right? Now coming to question that these patients are breathless because on exercise, the right ventricular is unable to improve the output as required for the with the exercise. Okay, that's why they're getting breathless. Did I get your question correctly?
Partly, yes, sir. So my question is very simple. So in CTEF, there are two problems. One is mechanical obstruction and one is remodeling.
Yes.
So if the gold standard is obviously PTE, the end aortectomy, obviously. Yes. So if that is relieving only the mechanical obstruction, how my patient is going to get better if remodeling is still there?
So when we do an endarterectomy, so between the disease and the hypertension, that's why you're saying that there is a clot load in disease also, there is a clot load in hypertension also, then how an endarterectomy is improving the patients, right? This is what you're, so I think this is, on a disease, this is a smaller clot load towards the periphery where the RV is not, heart is not under a strain at rest. Whereas in pulmonary, when the people who have developed pulmonary hypertension, the clot load is causing a load on the heart, on the right heart, and the right heart is getting dysfunctional, and that's why there is a pulmonary hypertension at rest.
Can I see it as this thing? I have picked this CTEPD early during the course of my patient before it developed CTEF.
No, I think when you look at the data, after an acute event, more than two, once the acute event is 2 years far away, these patients will not, hardly these patients progress on to developing a pulmonary hypertension. There have
been data also where CTEPD patients have developed CTEF later on. Sure. Thank you, sir.
That what subgroup of patients after endarterectomy or balloon angioplasty require reocygot in long term? When mechanical obstruction is clear, I think pH remains there. Then whether these patients require reocygot for long period or not, what percentage of patients are required?
So it would depend upon the effectiveness, how effectively the surgeons were able to clear the clot load. When you're doing an endarterectomy, you can actually, they can gauge the result on the table itself when the PA pressure starts coming down. And then you have to follow these patients up. So if an endarterectomy has been done really well with majority of clot load being removed, I think they may just go off treatment completely. And surgery remains the treatment of choice for these patients. It's not starting these patients upfront and just keeping them on Riociguat.
Thank you.
Thank you. Thank you very much.
So the discussion that I'm getting your point, so I don't know the name, that you said that is that. So you were asking that if we relieve the obstruction, even if there is a pulmonary arterial hypertension, how the patient will improve? That was your original question. Definitely, that time that if we have remove the obstruction, the patient has gone in irreversible changes in the pulmonary artery. That time, the treatment is the same that which we are getting all the treatments. Obstruction removal before the irreversible changes will improve. Otherwise, if they present late in the course of the disease, the fate or the treatment is the same like all other treatments.
In this, I would like to point out one thing. See, when you look at symptom improvement, there are a lot of components to it. So there's a component of afterload, and I extrapolate the transplant to it. The surgery of choice for pulmonary hypertension is not heart-lung transplant, only a double lung transplant. When you do a double lung transplant, what you are just changing is the afterload of the RV. And over the period of time, it has been well documented on transplants that the RV starts regressing in size, the RV starts picking up the function. Something similar, you're removing the mechanical obstruction, you're reducing the afterload for this RV. And over a period of time, there would be a remodeling and improvement in the RV function, which translates into a symptom improvement in these patients.
So there's a difference between the remove the obstruction and transplant. There's a totally different thing. Because on the subsegmental level of obstruction, we can't remove with the surgery and with the balloon angioplasty. It is the transplant that can remove that.
Correct.
So that is the we are changing in the situation that.
So correct. So if you look into this perspective, so there is a chronic thromboembolic pulmonary disease where there is still a small clot load in the peripheries, right? So these patients may still have some exertional dyspnea when the RV is not able to compensate for the increased workload on exercise, but at rest and on normal activities, they still may be normal.
So,
So very interesting. It's a new entity. A lot of things are being learned about the CTEPD primarily. One thing that has been recognized that CTPH is the only disease, but now we are recognizing that CTEPD patients also have the same amount of symptoms, same amount of exercise limitation as CTPH patients. So that is point number one. Point number two, a very few proportion of patients who are not documented to have greater than 20 pH ultimately develop greater than 20 pH later on also. So that is also happening, like CTPD into CTPH is also happening, but that is not in an extreme amount. Not everybody develops that. But a lot of the CTPD patients also have significant symptoms and exercise limitation. Other important thing is in terms of clot load, it is not that they have distal or proximal. At times, some of the radiographic studies, they are all small studies because they are going to be 50, 100 patient studies. So they compare, the radiological load seems to be similar, but the functional imaging showing a lot of difference between CTPH patients and CTPD patients. So we are not understanding why some of them develop PH and some of them don't develop PH with the same amount of clot load. So these are all interesting times. Maybe in few years we will have answers to all these questions.
So without wasting much time, because I am in between the lunch and you. So just starting my slides without wasting time. This slide is, I think we have seen multiple times from the morning, but it's still very important to understand because this is the basics that how you differentiate your pulmonary hypertension patients. I know that you know everything now because still from morning, from last 2 hours, I have learned a lot from everyone, from all of you. But still, I just show you that pulmonary hypertension, their mean pulmonary arterial pressure is more than 20. The mean means that the diastolic pressure plus 1/3 of the systolic diastolic pressure difference is the mean pulmonary arterial pressure. And you can diagnose with the pre-capillary, post-capillary, or combined pH with the right heart catheterization. Because being a cardiologist, I'm always do the right heart catheterization in all pulmonary hypertension patients. So this is the key slide that we should remember this, that if you have to diagnose the left heart versus the right heart pressure elevation, the pulmonary capillary wedge pressure is the best way to define these hemodynamics. So this is the early and late symptoms. There is no point to discuss this slide because everyone has been discussed that late symptoms like exertional chest pain could sometimes can be in the pulmonary arterial hypertension because of the dynamic compression of the left main coronary artery in these patients. Hoarse noise can be there because of the left laryngeal nerve compression, and the VH cough and other as the compression of the bronchi. These are late symptoms of pulmonary arterial hypertension. And these are these all these sign of pulmonary hypertension, RV backward failure, RV sign of forward failure, and sign of pointing toward the underlying cause of pulmonary hypertension. So this is the left lower one is, I think it's very important to discuss that. Digital clubbing, if you see the digital clubbing, it means that it could be cyanotic heart disease or fibrotic lung disease, bronchiectasis, venous obstruction, liver disease. So differential clubbing could be an PDA with SN manger, means that, and if you see the auscultative finding in your patient, maybe the pulmonary hypertension due to the lung or lung disease or heart disease. If you see the history of DVT, CTAP, telangiectasia may be related to the connective tissue disease, multiple system sclerosis, and sclerodactyly, renal phenomena, digital ulceration. All these you can, with these small signs, you can understand that which pathology is behind the pulmonary hypertension. So this is the echo additional finding. I think Hemant and Dr. Khatri has explained very well everything about the echo, how to diagnose and how to diagnose the RV failure, how to diagnose the RV strain on the echo. I'm not going to discuss in detail of these topics. And this is that most of the time the pulmonary hypertension 70% is from the left heart disease, and the 9.7% it is from the liver, and 0.6% cases it is CTAP, and isolated around 3 to 4%. And this is the slide showing the mean pulmonary arterial pressure. So that CTAP and the isolated pulmonary arterial hypertension having the higher mean pulmonary arterial pressure compared to the PH with the OSA and COPD and idiopathic pulmonary fibrosis. Just to slide just show that if you find a very high mean pressure, means that it may be idiopathic or CTAP. And this is to show that survival of the PH, as we have discussed, that congenital heart disease had very good survival compared to the connective tissue disease and the retroviral induced pulmonary arterial hypertension that has a worse prognosis. And these are the indications of the right heart catheterization. The right heart catheterization is mandatory in those where say patient where we have doubt, or before starting any additional therapy, pre-intervention like atrial septostomy, port shunt, pre-transplant workout, we should have the right heart catheterization. These is also the various echo finding, not going in detail. And this is the likelihood of, if you diagnosing your pulmonary arterial hypertension, what is the likelihood of the left heart is in the possible, is that is possible for the pulmonary hypertension, that if the age is more than 70, if there are more than 2 factors like obesity, hypertension, dyslipidemia, glucose intolerance, and diabetes, left heart disease, and the previous cardiac intervention, if atrial fibrillation and ECG changes are there, it means that the pulmonary hypertension is mostly because of the left heart disease. And these are the echo findings, that if the LA is enlarged, if you see the LVH, LA dilation, the pulmonary hypertension most of the time could be due to the left heart disease. And these are the hemodynamic measures. So I think this we should keep in mind if we are doing the right heart catheterization, that mean pulmonary arterial right heart pressure is 2 to 6 millimeter of mercury, systolic, diastolic. These are the we should know that PVR is 0.3 to 2 Woods unit is the normal level. Index level is 3.3 to 3.5. Total vascular resistance is less than 3 Woods units. Cardiac index. So this is the basic normal parameter we should know. We'll discuss about the pregnancy with pulmonary arterial hypertension. So as we all know that if if a 28-year woman with a 24-week of pregnancy present with the progression, dyspnea, syncope, oxygen saturation 91%, and we have diagnosed there is pulmonary arterial hypertension. So how these patients should be managed and which drugs should be given, because the mortality of these patients is around 50 to 30% if the pregnancy with pulmonary hypertension, because of the increased blood volume in the pregnancy, because the pregnancy is the high circulation status where there increased cardiac output, and these increased cardiac output that they in the pulmonary hypertension the patient could not afford and can lead to an RV failure risk, and that could be a very high mortality risk in these patients. So these patients should be discussed in detail. Preferred drug should be sildenafil, prostacyclin infusion, may use inhaled alloprost. We should avoid ER, Resogate, and Selexipag, and the delivery should be done at the experienced center. CTD, pulmonary hypertension with CTD, we have discussed in detail. The DLCO is the measurement that we should know about, that this is 35% Na positive, antipropion P elevated, alveolar enlargement, and this is the recommendation that pulmonary hypertension with CTD we should diagnose the right head catheterization and this DLCO, and these are the most common causes: systemic sclerosis, connective tissue disease, SLE, Jorgen syndrome, and the basic of mechanism is the endothelial injury, autoimmune inflammation, microvascular fibrosis, and progressive pulmonary vascular remodeling is the basic cause of the connective tissue disease with the pulmonary arterial hypertension. These are the risk factors, and the poor, as we have discussed, that the survival of these patients are very poor, with similar to the idiopathic pulmonary hypertension, and these are the pulmonary hypertension associated with the congenital heart disease cases like Eisenmenger. The survival is good with the left to right shunts and post repair pulmonary arterial hypertension. So these shunts can lead to increased pulmonary flow initially, that can lead to the pulmonary hypertension later when there would be a shunt reversible Eisenmenger syndrome. The treatment is that bosentan, PDE5, prostacyclin, and that all, because as we all know, as being a cardiologist, if a patient with the congenital heart disease comes to it, always we detect the left to right center and Eisenmenger syndrome, and at that time we should not close the defect, as we all know. In the CKD patients, all CKD patient stage 5, if a patient with the hemodialysis, dyspnea, if the pulmonary artery pressure is 75 or high, then maybe the pulmonary hypertension associated with the CKD. And the mechanism, which most of the time is volume overload because of the AV fistula. These patients also have the LV dysfunction. These patients can have the endothelial dysfunction. These CKD patients can also present with the pulmonary hypertension. So the management of these patients are volume optimization, adequacy of the dialysis. We should treat the LV dysfunction, means that we should do for the angiography, and in the any obstruction we can treat that. AV fistula flow should be measured and should be checked, and selected patients we can go with the pulmonary vasodilators. These HIV associated with the pulmonary arterial hypertension, the incidence is 0.3 to 0.5%. The mechanism is same that chronic immune activation, HIV protein, endothelial dysfunction, smooth muscle cell proliferation. The treatment is the continued ART, combination with the pulmonary arterial hypertension therapy, monitor drug interaction like ritonavir and bosentan and sildenafil, because the ART doesn't reverse the established cause of pulmonary arterial hypertension, and that could be the portopulmonary hypertension. That the portal hypertension could lead to hyperdynamic circulation, the endothelial dysfunction, the same can lead to pulmonary arterial hypertension. The treatment is the same, the mesentertine, the prostacyclin and multidisciplinary managements. Other specific group could be the drug induced, as we all know that like methamphetamine, cocaine, dasatinib, and appetite suppressant can lead to the pulmonary hypertension. So immediate withdrawal of offending drug is the treatment of choice and standard therapy of PS therapy if it persists. So we have discussed this. ILD we have discussed in detail. Obesity and sleep apnea. So if a patient with the high BMI, obstructive sleep apnea and pulmonary hypertension, the management of these patients would be weight reduction, CPAP, treat hypoxia, exercise, and controlled metabolic syndrome is the basic treatment of these patients in with obesity with sleep apnea. And these are the modern drug therapy, we have discussed it. These are the escalation therapy, how we escalate. And these are the emerging therapy, that's novel anti-inflammatory targets, gene therapy, precision medicine, all AI predictions. And these are the surgical management. So creation of interatrial communication where we can create the right and left atrium balloon ballonoplasty so that there can be the communication, and the pulmonary artery denervation, and lastly the lung and heart transplantation. So the take home message for my side is that early diagnosis improved outcome, right heart catheterization is remain essential, risk guided therapy is recommended, and early combination for most of the patients. And Indian consensus guideline has been published. It provides a practical recommendation. So that's all from my side. Thank you.
Situation in the PH pattern, sitting the lunchtime, any questions you can ask?
Yes. I didn't get CKD. So drug of choice, but I think tadalafil is the better than, but drug of choice is totally different. I prefer tadalafil.
To my knowledge, tadalafil is basically to be avoided when the creatine clearance is less than 30. And in liver disease also, in CLD also, and CKD also, sildenafil is a preferable option. I may be wrong, but I think that.
Still, I'm not sure. But
okay. And what about the this ERA choice, ambrisentan or macitentan for that portopulmonary hypertension patients?
In the ERA.
Yeah.
So basically, macitentan, I think it's better.
Thank you.
No other some trials on
Thank you all the speakers and the chairpersons. We'll now break for lunch and we'll gather again at 2:40 sharp for starting the next session. Thank you. After 15 minutes. नहीं एक और रखो। Good afternoon once again. We now begin with our post-lunch session, which is a panel discussion on CTD related PH, case-based panel discussion from early recognition to management. For this session, I will call upon Dr. S.K. Madhukar sir to moderate the session. The panelists for these sessions are Dr. Avinash Jain sir, Dr. Bhupendra Vaishnav sir, Dr. Javed sir, Dr. Pankaj Gulati sir, Dr. Amit Jain sir, Dr. Rohan Tambi sir, and for this session, the expert, I would call upon Dr. Sanjeev Sharma sir as an expert.
I think we should start, right? It's my absolute pleasure, privilege, and honor to be here with all of you. And at the outset, I thank Dr. K K Sharma sir for having me here in this state-of-the-art course in pulmonary hypertension. And let's give a big hand to this man who really organized a whole day symposium on pulmonary hypertension, which we'll never learn during our post-graduation days. So over the next half an hour, I have a brilliant set of panelists with me, and we'll be dwelling in to see how we can recognize the CTD-PAH early and how are we going to manage those patients. Over the morning sessions, we all learned that pH is not a disease entity. It's just a hemodynamic state. And what is the disease is defined by the pH classification. The pH classification is clinical, and this clinical classification is important because each class doesn't only have a unique pathophysiology and hemodynamic character, but it also has a very defined set of clinical presentation and therapeutic management. So what should be the framework whenever we see a case of suspected pulmonary hypertension? The first task of all the pulmonologists in hand is to raise the early suspicion of pulmonary hypertension. Once you have raised the suspicion, then you have to identify the underlying disease. You have to identify the comorbidities, and then a proper clinical classification should be ensured. We all have known this. Group 1, 3, 4 precapillary. Group 2 patients can present with either isolated post-capillary or combined post and precapillary hypertension. You know, since the morning, we are learning this, the hemodynamic criteria, identify the disease, and then identify which group the patient belongs to. The design is so simple, and that is why it is so complicated. Why? If you see the prevalence of PAH among CTDs, the two commonest causes of CTD associated with PAH are systemic sclerosis and mixed connective tissue disorder. And we have the registry data for CTD PAH, which says that the average age of CTD diagnosis is above 60 years. Or not surprisingly, most of these patients, 60 to 80% of the patients who are above 60 years of age, will have some cardiac or pulmonary disease. So they have a large number of patients have cardiopulmonary comorbidities. So an important task is, how are you going to say a patient who is having pre-capillary hemodynamic but has associated cardiac and lung disease, to say that this patient is of PAH? It's a difficult task. Cardiac disease, lung disease, pre-capillary hemodynamics, and I'm telling that the patient is having PAH. Not only this, the CTD group is further complicated by the fact that these patients can be classified into any group. They can have pulmonary vascular involvement, group 1 PAH. The CTD patients can have PVOD, group 1 PAH. CTD patients can have cardiac involvement, group 2 PH. The CTD patients can have ILD, lung disease, group 3 PH. CTD patients can have pulmonary artery obstruction, CTEPH, group 4 PH. So a single patient of CTD can have multiple likely probable clinical classification. And it is important to understand that the phenotype of PH in CTD is of particular importance because they have got different outcome. So what I'm going to do now, I'll have a case-based discussion where we will see what challenges we face in having clinical classification. And as we will go through the clinical classification, we will try to identify the treatable trait so that we can individualize the treatment of the CTD patients. The story starts in December 2024. 65 years male, non-smoker, obese, businessman, presents with dry cough and shortness of breath MMRC2 for 4 months. No history of exposure, arthralgia, arthritis, muscle weakness, Raynaud's, Sicca. No family history of chronic lung disease, but he is a known diabetic and hypertensive on regular treatment. On examination, the patient has facial rash. There is some vascular skin lesion in the legs, and there is skin thickening of bilateral hands reaching up to wrist joints. In the panel, we have rheumatologists sitting with us. So I would like any of the rheumatologists to identify the skin lesion, what is it, and skin thickening of hands reaching up to wrist joint has what significance? Any one of you, please.
At the hand, we can see it is edematous. So either we call it as puffy fingers, or it could be very early stage of sclerodactyly. That is, we probably label it as inflammatory phase of skin thickening. I don't know what are these venous lesions, and I think there are telangiectasias on the face.
Great.
And there is slight puffy face.
Yeah. So the patient has puffy hands and fingers, probably skin thickening, and then telangiectasia over the leg and the face. Hemodynamically stable, maintaining room air saturation of 97%, chest bibasal fine crackles. CRP 32.3. I believe the rheumatologist will understand why I'm putting this CRP here. Now the question to any of the pulmonologists is, what would you like to do the next? HRCT chest, lung function test, 6-minute walk distance test, and autoimmune serology.
Before going to HRCT chest, we should go for chest X-ray. After chest X-ray, we should evaluate what is the basic pathology, because you are telling the patient is having bilateral crackles.
Bilateral basal fine crackles.
So is there a ILD pattern is not, or reticulation in the chest X-ray is available or not? After then we can decide the patient we should go for HRCT and lung function test. And after if we get something to differential diagnosis, either patient is ILD or something like, if we find the DLCO and FVC ratio is
That I'll go
more
there.
than 1.6.
So you believe that we should have HRCT, lung function, 6-minute walk distance?
Yes.
And autoimmune?
Autoimmune, I will refer before evaluate. I want to evaluate for pulmonology aspect. Then we will send the patient.
But your patient has clear-cut autoimmune features, right? So anyway, so we are having all these tests, and I totally agree with him. So let me first place the HRCT chest lung window. So any of the pulmonologist colleague, any one of you?
As we have seen, what we seen basically basal involvement is there, and some fine reticulation we are seeing there. I'm not able to see any consolidations or any honeycombing is there, so I'm not finding that one. So some basic basal reticulations are there which are distributed, and that's all I can see.
So I'd put it like that: interstitial or alveolar?
It's interstitial.
Fibrotic, non-fibrotic?
Look like fibrotic.
Fibrotic interstitial lung disease. What are the features? No honeycombing, no traction bronchiectasis. Ground glass?
I'm not able to appreciate.
Ground glass? Agree? Yeah. Do you agree with the ground glass? Yeah. So the patient has ground glass and the patient has dilated esophagus, right? So a ground glass which is in craniocaudal distribution, which is basal predominant. So basal predominant ground glass interstitial lung disease, it's most likely fibrotic and a SIP. And as you told, the fibrosis extent seems to be very, very less, not extensive. So this is fibrotic NSIP with dilated esophagus. We have this. Do you want to say anything? There, I didn't put the mediastinal window here because it was normal. Body plethysmography and DLCO. So let me please explain both of these together. Body plethysmography.
Body plethysmography, so FE1 ratio 103% and FVC 93, and TLC 1, it is almost normal and above borderline.
So
it's showing some air trapping in the lung.
Fine.
But this is not matching the HRCT picture. The picture of body plethysmography is showing some maybe due to some emphysematous changes. But HRCT shows some fibrotic, that is not the code.
So TLC ratio is elevated,
yes,
but there is no evidence of air trapping in HRCT. What is more suggestive of? Some small airway disease. We didn't have oscillometry performed for this patient, I'm sorry. And we have this DLCO.
A significant reduction of the DLCO. So the ratio which I am calling before, FVC DLCO ratio is more than 1.6. That is the significant and warning sign for there is the pulmonary vascular involvement is the disease.
So you believe this is ILD, NSIP, fibrotic with pulmonary vascular involvement, yes, likely. Great. And this is how we should go in the clinical practice also. We have this 6-minute walk distance test. Distance seems to be fair, 364 millimeter. But to cover this distance, the patient saturation had significant fall from 95% to 81%. It's a significant desaturation on exertion or on exercise. What does it mean?
Not explaining by the CT picture because the lesion is very less.
Yes. So if it is not explained by the lung parenchymal lesion, what explains this?
So whenever we have normal or near normal FVC values and not so much radiological involvement, and but patient is clinically symptomatic, we should think of vascular pathology.
That's a great answer. So we have a lot of pointer to say that the patient has pulmonary vascular involvement. Autoimmune serology, our rheumatologist colleague.
So I think it's thankfully it is going as the clinical phenotype is suggesting. Probably those lesions on the limb were non-stellate telangiectasias. So because we have an out of proportionate FVC-DLCO ratio, we had an early systemic sclerosis phenotype. The anti-topoisomerase antibodies and Rho52 are very well going with it. And if you look at the IFA pattern also, which is AC29, is again going with the systemic sclerosis phenotype.
So this cytoplasmic pattern of influence topoisomerase all coordinated together. Yeah. What is the significance of having RO52 high positivity in a patient who has a topoisomerase positivity?
Yeah. So it actually portends a poor prognosis, which means these subset of patients may have a more severe phenotype or may progress at a faster rate. The other thing which literature tells us is they may have a vasculitic component to the pulmonary vasculature which is involved. Though classically it is seen with U1 RNP and Smith, basically in the setting of MCDD and lupus, but Rho52 indirectly tells us that there may be a vasculitic, particularly because it is 3+. Otherwise, you see a lot of noise because of Rho60, 1+, 2+ positivity, which at times we ignore if there is no phenotype pertaining to the same.
What we could get from him is the association of RO52 makes that the disease is likely to be highly progressive. And is there any chance of having myositis overlap, a myopathic form?
So there are no other clinical features.
Fine. But we did the myositis panel and it again was RO52 positive. So what is your diagnosis, any of the pulmonologists? Limited systemic sclerosis ILD or extensive systemic sclerosis ILD?
So I'll probably.
Yeah, yes, sir.
So if we go by the clinical phenotype, the disease probably is in early stage. So whenever we have to call it diffuse or extensive systemic sclerosis, the skin tightening tends to go beyond either the elbow joint or there is involvement of trunk and abdomen, which probably hasn't happened yet. But
so cutaneous, I'm fine.
Yeah.
What about
not
patient has FVC more than 70 and the patient has HRCT fibrosis less than 20. So this is limited ILD associated with systemic sclerosis.
The limited word should have come with the ILD. Actually, this is confusing whether you're talking about systemic sclerosis to be limited. Exactly. Yeah,
so,
yeah.
Right. But we say limited, when we say skin involvement limited or diffuse, we say it limited cutaneous systemic sclerosis ILD or diffuse cutaneous systemic sclerosis ILD. The nomenclature is different. But now it is clear that the patient has limited systemic sclerosis ILD, but autoimmunity tells us that the patient is at high risk of progression, correct? Right. So any of the pulmonologists, what would you like to do at this point of time? Would you like to do any other investigation? You have limited SSC ILD, your patient is symptomatic, you are telling that the patient is likely to have pulmonary vascular involvement in addition to the ILD. So you would like to have echo, right? So I have a very important take-home message here that even a patient with limited ILD in systemic sclerosis should be seriously evaluated for the pulmonary arterial hypertension. And there are 2 pointers here: disproportionate decline in DLCO comparison to FVC and normal resting oxygen saturation with significant fall during 6-minute walk distance test. So this suggests that even with limited ILD, this patient is likely to have pulmonary hypertension. This question goes to the rheumatologist or the pulmonologists. What are the risk factors in our patient for the development of PAH? Let me clear it, very clear distinction. Till now, we are thinking of pulmonary hypertension. Now, we are thinking of pulmonary arterial hypertension. So what are the risk factors to tell us that this patient has pulmonary hypertension because of pulmonary arterial hypertension? So what are the risk factors in this
So in
patient?
this we have, I think, three: age, his gender,
Yeah.
and the presence of telangiectasias.
Yeah.
These are the ones which will tell you. As far as antibodies are concerned, it is anticentromere which is more classically associated, and they can have an early pH as compared to SCL70.
That's a great answer. So what we have, yeah?
Limited system sclerosis is also a risk.
Yes, correct. So the brilliant answer. So what we got is older age. Women should be happy because CTD is common in women, but the prognosis is poor when the man have the CTD. So older age, male sex, limited cutaneous systemic sclerosis, telangiectasia, sclerodactyly, FVC by DLCO more than 1.6, and anti-SCL70, though less than the anticentromere. But we have a lot of risk factors to say that my patient has PAH. In my part of the country, because of the temperature and all, most of the patients do not present with the Raynaud's phenomenon. So how do you do? Would you like to do any test to suggest that this patient might be harboring some digital vasculopathy or Raynaud's?
Nail fold capillaroscopy we can.
Yeah, that's a great answer. And I believe every ILD clinic should run with the nail fold capillaroscope. It is a must nowadays to have when you are seeing the patients with CTD ILD. So we did this nail fold capillaroscopy. So the rheumatologist colleague, to please comment on this.
I think it is the early stage of the disease, and there are large capillaries, and there is occasional hemorrhages, microhemorrhages are there.
So splinter hemorrhage and giant capillaries, right?
Yeah, giant capillaries.
Yes. So this clearly indicates that the patient has vasculopathy. So there are a lot of indicators to tell that my patient has PAH. So finally we did this echo, which you all of you wanted. So any pulmonologist, we have been learning this since morning. What is the echocardiographic probability of PH? Low, intermediate, or high?
I think high probability because TR maximum is more than 3.4.
Yes.
That is
So it's a
3.8.
high echocardiographic probability of pulmonary hypertension. But the patient has been reported to have hypokinetic infero-posterior wall.
It also have a cardiac issues.
Yes, and he also has the left heart disease with the left ventricular ejection fraction 42%, anti-proBNP 2648. So the question is, would you like to do RHC in this patient?
Before RSC, I want to go for coronary angiography.
That would be done by the cardiologist while doing RHC.
I will refer the patient for coronary artery angiography.
So, will you do RHC or not? Oh, okay. I'm here. Sorry, I missed you. Thank you so much. Okay. Sorry, I'm so sorry. So, should we do RHC in this patient?
Definitely. All the patients of severe PH, secondary to even CTD, should undergo right heart cath and also diagnostic coronary angiography as he insisted. With a clear-cut wall motion abnormality, patient is 60 plus, he is a long-standing diabetic, hypertensive, there is a high probability of obstructive CAD, and that might also be contributing for the PH part.
So totally agree. Sorry? Right ventricular systolic pressure is elevated. Elevated. We have the value, but I haven't put it here, but it is elevated. So what additional test would you like to perform to gain insights into the clinical classification? Where once you said that RHC, that will give the idea. You said the coronary angiogram. Any other test we have been talking about since morning? VQ scan, right. So we'll have RHC, coronary angiogram, and VQ scan. Let's understand that what the guideline says to us, any patient with high echocardiographic probability of PH, or even with the intermediate probability of PH, if are found to have associated condition or condition associated with PAH, or the risk factor for the development of PAH or CTAF, must undergo right heart catheterization. So what are the risk factors or associated condition for PAH in this case? Systemic sclerosis itself, and we discussed a lot of risk factors. I would like to point one particular component of the risk factor here. There has been 4 papers published, and it says that the top say is to systolic pulmonary artery pressure, which the doctor was talking about. If it is less than 0.55, means right ventricular pulmonary artery uncoupling, if this feature is there on echocardiography, then this has high specificity and high predictive value, positive predictive value for PAH in systemic sclerosis. So another indication that we should be thinking of PAH if the patient comes out to have pulmonary hypertension. We did this right heart catheterization. Dear cardiologist, he is with us. So what is the hemodynamic classification here?
This looks like a moderate pulmonary arterial hypertension.
So both PVR and pulmonary artery wedge pressure are elevated.
It is pre-capillary and post-capillary.
So this is combined post and pre-capillary pulmonary hypertension. Fine. The patient underwent coronary angiogram, found to have coronary artery disease, underwent coronary angioplasty, and treatment of his cardiac disease was optimized with the help of a cardiologist colleague. The question is, and we asked for the lung ventilation perfusion scan. Unfortunately, ventilation perfusion scan is not being done at my center or at my place. So what we only had is a perfusion scan, and it was normal. Does this patient has group 1 PAH? Now what we have? We have high echocardiographic probability. We have ILD, which is limited. And we have post and pre combined capillary pulmonary hypertension. So do you think that this patient has PAH?
If we go by the decline in the saturation which has happened for this patient from 95 to 81, if we look at the FVC DLCO ratio, which was disproportionately high, it looks that it is multifactorial. The other clue, which is, though they don't have a very good cutoff, but if a mean PAP they say is more than 45, you have to think that the pulmonary vasculature too is getting involved, though in this case it was 43 only. So in view of this severe hypoxemia which is happening with 6-minute walk test and your PFT FVC DLCO ratio around 3.7, group 1 PH might be contributing to it, but because we also know clear cut there is pre and post capillary phenomenon which is happening here, I would still be very careful before I could think of initiating a pH specific therapy after having completely optimized his...
Anyone who is having any different opinion? There is no doubt that we have left heart disease. The patient's treatment has been optimized. The patient had undergone angioplasty, treatment optimized. But how do you explain this PVR, which is almost 5?
I think it is a combination of group 1, group 2, group 3 pH.
Group 1, group 2, group 3. So you still think that this is group 3 pH?
There may be minor contribution because of the hypoxia patient. But the dull part is not.
Your patient is not having any resting hypoxia. He is desaturating on exercise. So the patient has very limited ILD. This is why I put it there. Limited ILD with so much of PVR, unlikely to be group 3. So what the patient is having? Left heart disease with group 1 PAH as because of systemic sclerosis. Would you like to treat this patient with pulmonary vasodilator?
Before we should go the right.
But we have done the HRCT. We have already done the HRCT. HRCT shows fibrotic NSIP with dilated esophagus. There is no hint of PVOD at all. Okay. So what we did is, we had the risk stratification, which shows its, is the time up? Okay. So I'll just have to hurry on the slide. So it shows low risk, but we started, remember that the systemic sclerosis is the commonest cause of group 1 PAH. It is associated with the worst outcome in group 1 PAH. And even a patient with mild PAH having PVR between 2 to 3 should be treated in systemic sclerosis. And therefore we started the treatment. The question is, how would you treat this patient? So immunosuppression vasodilator, single immunosuppression, combined immunosuppression. Rheumatologist.
I think in systemic sclerosis, we should be very cautious in starting corticosteroids.
No,
number one.
it is about
It's combined.
immunosuppressive.
Immunosuppressive.
You will start combined?
No. Immunosuppressive will be decided by the background disease activity, other systemic involvement in systemic sclerosis. Per se, in systemic sclerosis, pH usually don't respond.
No, your
Right,
patient has systemic sclerosis, no doubt.
Yeah.
Limited ILD, no doubt.
Yeah.
Would you treat the systemic sclerosis or will you just treat the pulmonary hypertension?
Yeah, I would treat with milder immunosuppressive.
So single
because the skin is in inflammatory phase. So even at this stage, some immunosuppression would help the patient.
Single or double?
Single.
Single. So single immunosuppression with pulmonary vasodilator. Let's make it clear that in systemic sclerosis PAH till date, we do not have evidence of the role of immunosuppressive for PAH. Yes. So what we did is single pulmonary vasodilator or double pulmonary vasodilator. Why? Because the patient has associated comorbidity. The patient has diabetes, hypertension, coronary artery disease, so single pulmonary vasodilator. We treated the patient with titrating dose of sildenafil and mycophenolate mofetil. Patient did well for the next 5 months, then started progressive worsening of shortness of breath over 1 month with resting hypoxemia. Now the SpO2 is 74% at room air. 4 months he was absolutely fine. Last 1 month, increasing shortness of breath, patient became hypoxemic at rest. What would you do now?
Evaluate the patient.
We will reassess the patient.
How will you reassess the patient?
Clinically, how is the functional classification of
The patient is progressive
and
breathlessness, class 3, class 4 dyspnea.
Then the 2D echo and CT chest.
CCT chest.
Okay.
CCT chest.
So what are the possibilities? The patient might have progression of ILD, the patient might have worsening of left heart disease, and the patient might have worsening of pulmonary arterial hypertension. Two investigations that you are talking about is CT and echo. Yeah, fine. So we did this CT. Same patients 5 months later on single pulmonary vasodilator, still have a lot of dilated esophagus. It is still there. But lung parenchyma has completely changed.
Diffuse ground glass aging.
Yes, there is diffuse ground glass and there is a smooth interstitial thickening.
Some central lobular thickening is out.
Yes, correct. And the cardiologist reported it to be pulmonary edema. I am showing you the mediastinal window. Radiologist reported it to be the pulmonary edema. So we thought worsening of left heart disease. What is abnormal in mediastinal window?
Small lymph node is present.
Good amount of lymph nodes. Right paratracheal, prevascular, bilateral, hilar, all mediastinal lymph nodes are enlarged. So what is your diagnosis? PVOD. We again did the right heart catheter before also. But what has happened? Pulmonary artery wedge pressure has reduced a lot. It has reduced to 13. And the patient's PVR has increased. So pulmonary artery wedge pressure has reduced, PVR has increased, and mean pulmonary artery is almost there. So what hemodynamic component is worsening? So pre-capillary component is worsening, post-capillary is controlled or is improving. And with this CT, we are thinking of PVOD. So that's a great answer. The diagnosis of PVOD is a HRCT criteria. Triad of the finding: mediastinal lymph node enlargement, centrilobular GGOs, smooth thickening of interlobular septa. The gold standard is lung biopsy, but lung biopsy is contraindicated. So we have to diagnose PVOD based on the imaging findings. As Dr. Ramakrishnan sir was talking about, the PS therapy, we have to be a little bit careful, but we know that our patient has CTD PAH. We started pulmonary vasodilator. Patient was improving for the next 4 months, so we continued giving sildenafil. We intensified the diuretics. And then I tried to search the literature. I have found something very interesting. In CTD-PAH, any CTD-PAH, as the disease progresses, patients may belong to more than one group over the course of their lifetime. And also, a very interesting thing, in systemic sclerosis, development of PVOD may be a later complication of SSC-PAH, often occurring after several years of PAH-specific therapy. And this has been quoted from Tina Tuhi and Hossen's study in ERS 2025. So this is how in our practice we evaluate and diagnose, classify and treat the patients of CTD and treat the pulmonary hypertension. So this will be the last slide, and this is a question for all the audiences. This is not for the panelists. If any one of you gives the right answer, we have got a prize for you. The question is, what mistake was done while treating this patient? You can answer it later also, there is no issue. But if anyone has this answer right, he is going to get the prize. Fine. So thank you so much. Yeah? Fine. So thank you so much for your kind attention. Hope I made some sense out of it. And thank you so much, my brilliant panelists, to be here. Thank you so much, sir. No question? Good. Thank you, sir. मेरे को ये निकाल लेने दो. तो कैसे सेफली रिमूव करोगे? सेफली कैसे रिमूव करना है? ये नहीं, पूरा मेरे को सेफली इजेक्ट करना है, ऐसे मत इजेक्ट करना. ओके, इसको सेफली निकालना है, कैसे निकालोगे?
Thank you so much, Dr. Madhukar and Sanjeev Sharma sir and all our panelists. So for the next session, I would like to request our moderator, Dr. Brajesh Prajapat, and our expert, Dr. S. Ramakrishnan, to please join us, and our panelists, Dr. KP Singh, Dr. Rajneesh Sharma, Dr. Sanjay Sogani, Dr. Sanjeev Sidana sir, Dr. Shubhranshu, and Dr. Vimal Kant Yadav sir.
So good afternoon, everyone. I think this is the last session. So a lot has been spoken about this CTEF in beds in many sessions previously and in detail by Dr. Vivek Singh. So this is just a reiteration and more of a repetition. It's a CTEF based CTEF panel discussion. I'll start with an introduction, what it is all about. It's just a chronic thromboembolism presents in the pulmonary artery in the setting of precapillary pH, which currently is defined as mean pulmonary artery pressure more than 20, pulmonary artery wedge pressure less than 15 millimeter Hg, and pulmonary vascular resistance of more than 2 Wood units. These are two issues which is important and needs to be identified. One is mechanical obstruction and later on vascular remodeling. This is important. Okay, so this is all about how I work up my suspected CTEF patients. We screen with echocardiography. There are few fixed parameters that my cardiologist basically talk about or see. It basically moves away from his inclination towards left heart to the right heart, and then if there is things which are going haywire, yes, they tell it is positive. Then we screen the patient with the VQ scan, and we have a high VDVT, which is called as high thread space ventilation in these case patients, confirmed with the help of CT pulmonary angiography. And then yes, we do. If you have this luxury of CPAT at your center, yes, it can be done, where it can be seen that you have a high VDVT ratios and low or reduced VO2 max. Okay, so if these things are going in favor of CTEF, you basically go for right heart catheterization, where this parameter needs to be seen. So this is how you confirm the thing, and once you confirmed it, then you do not treat it alone. You should have a multidisciplinary team to tell which is the best modality to actually treat it. It can be PEA in the form of pulmonary and arterectomy. It can be BPF, balloon pulmonary angiography, and the pH-based therapy that we have, medical therapies. So I'll start with a case scenario. I'll open it up and we'll take few questions, and then I close this case. A 57-year-old female presented in emergency with chief complaints of shortness of breath for the last 5 years, increase in the last 1 month. She has been on domiciliary oxygen for the last 3 years. She had history of 2 VTE in the last 4 years, which was thrombolized twice with streptokinase 2 years apart. And she has been managed with diuretics, domiciliary oxygen, digoxin, endothelin receptor antagonist, PDE5 inhibitors for the last 18 months. So when she presented to us in the emergency, the POCUS shows massive ascites, bilateral pleural effusion, massive. POCUS echo shows RAR with dilated, PSP pressures was 96 and there was severe TR. She was planned for CTPA in view of third pulmonary embolism. So there were filling defect, not acute, but the filling defects was seen, bilateral multiple vessels were involved. So I stop my case here and we'll take few questions here. So my question to Dr. Sanjeev Sadana, sir. How do you go, this is just a repetition, but how do you differentiate CTEF from class 1 and 2 pH?
So pulmonary capillary wedge pressure we have to monitor so that we can differentiate whether it is class 1 or not. So if pulmonary capillary wedge pressure is high, then definitely it is related to left heart, but if it is normal, then it is group 1.
In this case, what do you suspect? Is it actually class 1, class 2, or straight away we are dealing with CTEF? Going
So
by the history,
this
going by the
patient is
thing.
definitely has a definite history of pulmonary embolism. So this patient is a clear-cut case. So otherwise, if there is doubtful history, then first we can do a perfusion scan, and then we can decide whether it is CTEF or not. And but in this particular case, we can go directly for the pulmonary angiography to decide whether to decide the anatomy, so that we can plan the treatment accordingly, whether patient requires
whether it is acute thrombus or chronic thromboembolism or patient requires surgical or medical therapy.
This was all the organized thing that we could see at that time, no acute thing. So just a quick question. So next question to Dr. Sanjay Sagani, sir. How would you go ahead and differentiate CTEF from the class 3 pH? But she does not have any history of any pulmonary disease. So would you still like to differentiate it with class 3 pH?
As we all know, group 3 involved respiratory disease related pH and CTEF is group 4. So respiratory related disease pH, group 3 and group 4 we can differentiate easily according to etiology, according to clinical symptoms, according to investigations, according to etiology different in both things. In CTEF, etiology is recurrent pulmonary embolism or VT or also thrombophilia, also CTT related, we can also lead to the CTF. But in pH, group 3 is a respiratory disease related, I think COPD with hypoxia, the sleep disorder, breathing, ILD, those conditions lead to the hypoxia. And clinical symptoms in CTF, there is a progressive breathlessness and also syncope, hemoptysis, and in respiratory related pH, there is a cough with expectoration and wheezing, progressive breathlessness. There is if progressive breathlessness is first and cough is last, it might be due to the other than respiratory. But cough is first, then breathlessness last, might be due to the respiratory causes.
So, although she was not giving any history of any pulmonary disease, but one thing which we could not rule out was sleep disorder breathing in that group of patients. This is which was very important. They can also contribute to class 3 pH. However, the history is pretty suggestive towards CTEF, so we are moving ahead with CTEF only. So the next question to Dr. Shubhranshu sir. When would you suspect CTEF in a follow-up patient of PE, acute PE? And does time matters here?
So whenever we have patient, when we suspect CTEF, so definitely once when there is a first event of PE, pulmonary thromboembolism, it is if it is unprovoked, if there is a massive embolism, and there are only then we should see that patient whenever comes in follow-up, we have a high degree of suspicion of CTEF.
So at what point of time would you like to?
So after 3 months of adequate anticoagulation therapy in these patients of PE, if still patient having a progressive or worsening dyspnea, having a new onset symptoms of fatigue, or if patient was apparently symptomatic during this anticoagulation therapy and now developed has dyspnea and some other signs of right ventricular strain like some pedal edema or raised JVP, so then definitely we should suspect CTEF in these patients. And definitely time matters, as I already said. After 3 months of follow-up, if patient is persistently having dyspnea and worsening of the dyspnea, then we should suspect, because if we delay the diagnosis, that the outcome may worsen.
And if the patient does not have any dyspnea, no symptom, would you still go ahead with this 3-month evaluation?
Then we can still wait for that, and after 3 to 6 months, definitely we need to evaluate for all the either patient is improving by the clinically and other parameters.
Ramakrishna sir, I want your input in that case, because this is where I have some doubt, I have some confusion. Because at the end of 3 months, if patient does not have any symptoms, some people say do not do anything, and I do.
I think if the patient is asymptomatic and has a decent 6-minute walk distance and everything else is normal, I think possibly we can leave them alone.
Okay.
I think if at all CTEP develops, it mostly develops within 2 years, but the percentages are pretty low for after pulmonary embolism. So I think 3 months to 2 years, keep them on close follow-up and then assess their exercise capacity objectively. Our patients, oftentimes what happens is they say I'm asymptomatic, but you put them to walk, they don't walk.
And if the patient is symptomatic, you usually go for with the echo or the VQ scan.
So I think echo is very easy to do. So we'll definitely do an echo and then possibly order an VQ scan Anything beyond 6 months, we wait from 3 to 6 months if they are not terribly symptomatic. Maybe around 6 months, we definitely start doing VQ scan. Not, I think very few patients are becoming extremely symptomatic within 6 months. Like.
Happily said. I think this should be the thing. It should be done 3 to 6 months if my patient is asymptomatic. But if patient is giving you symptoms, it should be done at the end of 3 months. Ongoing exercise intolerance or new onset exertional dyspnea needs relapse of post PT, VPA use and residual disease, which is my point of concern as well. When PT is such a gold standard, why do we have residual disease when you just get rid of mechanical obstruction? And that is why remodeling comes into the picture. You have residual disease, you have remodeling. So next question to Dr. Rajneesh. What do you think all are the risk factors for a patient progressing towards CTEF? And this is my special question. My favorite question. Are CTEPD and CTEF same, different, or are sharing the same spectrum?
So yes, the risk factor for CTEF, as we all know, that all the risk factor for recurrent or persistent VT, like thrombophilic conditions, like genetic variation, like factor 5 Leiden or prothrombin mutation, or increased level of factor 8 von Willebrand, or protein CS deficiencies like this. Otherwise, some acquired condition like antiphospholipid syndromes with circulating antibodies, or some acquired condition like infected pacemaker wire, or these things, or autoimmune disorders, hypothyroidism, malignancies. These are the risk factors.
They can add.
Some miscellaneous also.
They usually progress to CTEF, like the unprovoked PE, a diagnostic dilemma or delay, and identifying this PE. And yes, if you have a person's right ventricle dysfunction at the time of PE, these all are the important risk factors that my patient can progress to CTEF. There are other things. I mean, there are genetic issues like TAP2 genes, and known O blood groups are also risk factor for basically progressing towards CTEF. And yes, antiphospholipid syndrome is also, has linkage with these things. In addition to these things, malignancy and indwelling cats can lead to these things. Why do you think this CTEPD and CTEF needs to be differentiated? And if we know that my patient is having CTEPD, for how long and how frequently should I follow them?
So basically, CTPD is when there is a persistent pulmonary artery obstruction with persistent symptoms. But if there is also microvasculature remodeling, then it's CTPH along with increased pulmonary hypertension. So
Ramakrishnan sir,
if we see that patient is having pulmonary obstruction in the form of like in VQ perfusion, or in angiogram, or persistent symptoms, then it is called CTPD basically.
Sir, Dr. Ramakrishnan sir, just a quick question from you. If my echo miss this thing, CTPD.
Yeah, absolutely, it can easily miss it. Like.
So how do you pick it up?
So I think it's better to go the reverse way. I think you have if the patient is symptomatic, echo is normal, so you go for a VQ scan, and then VQ scan shows a significant defect, and you go back to right heart catheterization after a CTPA.
So this is the crux. So not if your echo is not showing anything, still your patient have some sort of symptoms related to exertion. Okay, I put it in that fashion. Mechanism of dyspnea in the CTEPD is something like mechanism of angina. This is just a classical analogy. Okay, you exert, you somehow have some issues, and then it settles down. So elevation of ventilator dead space because of this pulmonary arterial obstruction, elevation of P pressures with exercise causes this thing. So this CTEPD is a silent thing. It is not a benign thing. It can progress sometimes. It can give the symptoms to the patients as well, and it needs to be treated as well. So do not treat it as a benign thing just because your echo is normal. Go for VQ scan if you have a high suspicion of this thing, CTPD. Go for a VQ scan if it is positive. Give the benefit of your patient this BP and PT. And mind you, pH directed therapies will not going to work on this thing. Why? Because my patient does not have any pH. So no pH, no therapy will going to work. So needs to differentiate, see, evaluate, re-evaluate, and see whether my patient progress to CT, PT to CTEF or not. Because there are case reports where my patient usually go towards it. That is why it is being seen as spectrum. As Dr. Ramakrishnan sir said, I do not know which group of patient will progress, which will not progress. Okay, so it is very difficult. So we need to evaluate, we need to follow up these patients very closely. Oh, okay, please. Can we take it afterwards? Okay, perfect. Wonderful. In both of the things, okay, DLCO will be marginally reduced. In CTEF, yes, reduced. In CT-EPD, it's marginally reduced. Marginally reduced. So the next question is, how should I go for risk stratification and severity scoring for CTEF? And this question is to Dr. Sanjay Sokani, sir.
Risk stratification and severity scoring is important for the treatment part, and it can be divide into mild, intermediate, and high risk. According to European Society of Cardiology and European Respiratory Society 2022, it multi-parametric score, and it's includes 8 parameter functional classification, first and also cardiac index, pro BNP, 6-minute walk test, cardiac right ventricular size, and pericardial effusion, and these are the included in the severity score. In mild, intermediate, and high, where the high category may be systemic is required because of patient decide the further treatment line, because in high risk group there is an inoperable situation. We go for the other condition beyond the surgery.
So I think basically we borrowed this thing, the risk stratification on the same PS thing, this compare registry data, and there are 6 parameters by which we basically stratify the patients into mild, moderate, and the severe thing. And this is WHO functional classification, 6-minute walk distance, BNP parameters, and the right ventricular pressures, cardiac index, and the mixed venous saturations. So this is how it is done, and basically it is borrowed from the PH risk stratification strategy. So the next question is, what do you look in VQ scan or a CT scan chest in case of a CTEF? To you, Dr. Shipranshu, sir.
So when we have a patient of CTEF and we go ahead with VQ scan. So if we talk about VQ scan, the classical finding will be mismatched perfusion defects. It can be at the segmental or subsegmental levels. So this is a classical finding, and it is very sensitive test. If it has got a very good predictive negative value, if it is normal, then we can clearly rule out the CTEF. So then these are the findings which we can see. And added we have a SPECT VQ scan if possible, then we can also delineate the operability and the inoperability of the patients. So this is the finding in VQ scans. If we talk about the CT scan finding, definitely we can either look into the pulmonary vascular findings, then we can also give the parenchymal findings, and then we can also look at the cardiac findings. So if we talk about the vascular findings, definitely we can see the webs, we can see the organized clots, filling defects, even the bands we can be there, and network can be seen in the pulmonary vasculature. Then if we talk about this parenchymal findings, definitely we can see the mosaic, geographic mosaic pattern, where we can have a hypoperfusion patterns and the brighter, highly perfused areas also. And then we can also find simultaneously some areas of infarct.
Wonderful.
So and similarly, if we go for the cardiac side, we can also see the right ventricular enlargement. The septum can be either mid, or it can be towards the right side, left side. Then similarly we can also see the
influx of the contrast into the IVC or hepatic veins.
So in CT scan, basically what we find is the filling defects at the multiple level. There is a pruning of vessels, obviously will be there. The MPA diameter will be high in this group of patients. And in parenchyma, mind you, this is not a parenchymal problem. So why do we have a mosaic attenuation? Because some areas are heavily perfused, some areas are not. That is why you have mosaic attenuation. So whenever you have a GGO's mosaic attenuation, don't think about parenchymal defects. Sometimes think about the perfusion things as well. Okay, this is the classical VQ scan where you can see ventilation is absolutely okay. You have an issue with the perfusion, and that is why you have a problem with the VQ mismatch. So any patient who have an ILD, okay, do not go for VQ scan because ventilation impaired, perfusion impaired, you will have a VQ normal. So this is a take home message. If your patient, like the previous speaker told, if your patient is having an ILD, do not go for a VQ scan. You will not have anything. You will not be able to interpret anything. Okay, go for another. There are so many other steps. Okay, so perfusion defects presents raises an alarm in a normal parenchyma. Positive scan means uh, dead space, and negative study rules out with a sensitivity of 94 and a specificity of 96%. So very, very sensitive thing if you want to go ahead. So next question is, what specific echo parameters do you look in a case of CTEF, classical CTEF, Dr. Sanjeev Sitanaso?
So apart from the general things which we see for the pulmonary arterial hypertension like RV dilatation, hypertrophy, all these things will be there definitely, but there are few echocardiographic parameters which are specific for the CTEF. The one is that if you see, although it's very rare, if you see any thrombus in pulmonary artery or RA or RV, that is a specific sign. Second thing is if you perform a Doppler study, and on Doppler you see a nosed Doppler pattern in the pulmonary artery tracing, then that is also specific for the CTEF. And if you do a RVOT Doppler and the acceleration time is very decreased, that is less than 60 or 80 millisecond, that is a parameter for the for suggestive of CTEF. And then the asymmetrical size of pulmonary arteries, because it is there might be unequal involvement of all the lungs, so that is also suggestive of CTEF. So all these findings were said. Then the tissue Doppler, if we perform in the RV, so the tissue Doppler pattern will be very heterogeneous rather than homogeneous. So that is another tissue. And few ominous sign, definitely that is true for all the disease. Like if we perform tissue Doppler imaging and we calculate a ratio of with the RVSP, and if it is less than 0.3, that is suggestive of very severe involvement of RV.
Dr. Ramakrishna sir, would you like to point out few things? I mean, which should just make us say that I am dealing with this kind of thing, not the CETA, but I'm dealing with PH.
I think PH is.
Yes,
I think there are various signs that commonly the first and foremost thing is RRV dilatation of no cause. Like we don't find a cause, there is no ASD or a PAPVC, and you find an RRV dilatation. And obviously the easiest way to diagnose is TR velocity. The moment you get a high TR velocity, your probability increases. So if they are not there, then it actually is a typical echocardiographer game. Then possibly non-echocardiographer need not be taught about all the other things like. So I think these are the starting points. Like
you talk about the echo, usually sometimes overestimate the things if you talk about the TR jet only.
So I think this is the starting point. Like you use echo as a starting point. It's not the it's never going to tell you the full diagnosis or full prognosis. Like it's going to be the starting point where whether you want to do a right heart or whether you want to do other things, that is where the echo stands. And the most important use of echo is to rule out other diseases. So that's the most important thing. So it has to be, any pH echo has to be comprehensive. So you may be dealing with a pulmonary vein stenosis. So it has to be at least, even if you suspect, non-echographer suspects it on a simple focus ultrasound or anything, that definitely needs a detailed further echo.
Examination. Absolutely, sir. That operation, this is very important. Operator must be experienced. And mind you, this echo can over and sometimes underestimate the issues. You should focus on the right side as well. Okay, talking about the left side, but you should also focus on the right side, and it has immense role in follow-up studies. Okay.
So I think follow-up is very important. Follow-up echo, everybody relies on TR velocity, but as I told you, follow-up echo, TR velocity has not much role. The important parameters are RA volume index or RA area, TAPSE, and pericardial effusion. These are the highest yielding prognostic markers.
So my question to Dr. Vimal Khan, sir. What is your selection criteria for taking a patient for PEA? And is there any prerequisite prior to doing this PEA?
Most of the time, what we get the patients, already they shown by the cardiologist and the pulmonologist. So what we get the patients already diagnosed actually. So our criteria is the surgical, we have to see the sites. So already investigated the patients. So they have a definitely CTAP. So what we see in those patients that whether we're going to benefit them or not. So first we have to see the risk factors. Because the patients, they normally go on CPB, they should handle that CPB, and that too is what we do is TCA, total circulatory arrest in these patients for 20 minutes we have to do for 18-degree temperature. So patient should handle that. So risk stratification is must in these patients. So whether these patients will be benefited or not. So already diagnosed patients, but definitely this is a definite curative treatment. We have seen, we have operated the patients, and the RV function and the PA pressures that come down drastically on table only, and the patients get symptomatic relief like anything in these patients. So we have to stratify the risk factors in these patients, and the how much symptomatic patient is, that also we have to see. If patient is really symptomatic and we can benefit him, then we should get him operated. We only give them the operative mortality is also high, but not that much. Now the experience centers, they have less than 5% mortality. Sometimes these patients, they do have bleeding and other complications. So we have to see many things in these patients about the surgical. So it is a team approach, simple. So we have to take along others with us. Anesthetist also, they have to see the risk factors. Post-operative, also we have to see. Sometimes hemorrhage occurs in that class appearance, that we have to go for VV ECMO, or sometimes VA ECMO also we have to go on.
So what is the 2 or 3 characters that you will see and say, oh, I will take that case and I won't take that case?
First, we see how symptomatic the patient is.
One thing is.
Is
it the proximity of the disease as a proximal disease or the distal one?
That is already diagnosed. Everything is already diagnosed. I'm telling you, you already told that CT pulmonary we have already done. We have right catheterization, echo already it has been done by them. 3-month therapy already. These are guidelines are there. So we see these all. So proximity of distal segments, we cannot approach that segments. And if we approach that hemorrhage will occur in this. So segmental level, we can take out everything. And definitely it is a curative, and patient get relief on table only. You just see those patients.
So what do you think, what is the most common reason for inoperability? It is a delay or it is the patient comorbidity?
Delay, in Indian setting, it is already delayed sometimes. But sometimes the patient cannot walk. So you have to stratify the risk. Whether patient is now, so risk stratification is there. If the patient is so morbid and he don't have any choice, so either he has to go for medical management like BAV and other medical management, or if he is willing and we can definitely give him some benefit, then we should go for surgery for these patients.
I think just want to
please,
add
please,
here,
please.
like
Yeah.
I think
Yes.
if you can look at it like, so suppose if you compare it with cardiology perspective, so you have thallium or something which shows the functional abnormality because of a coronary artery obstruction, and you have a coronary artery anatomy. Same thing is working here. Do you have a anatomy with CT angiography as well as DSA? You have an anatomy, and you have a functional correlation with VQ scan. So what experienced surgeons look at is that they are going to come from median sternotomy and then put on a circulatory arrest and pull out open the artery and pull out as much muck as possible. And it comes out like a cast. The whole artery system, everything comes out like a cast. It's not so easy. I think one of the most difficult surgeries that they have. So the basic problem comes is after the surgery. So obviously one thing that is going to be there, if it is going to be distal, they cannot approach it inside the lung, which is very distal. So that is number one. Number two, what happens is there is a big discrepancy between what is found in the function and what is found in the anatomy. So for example, anatomically they find, okay, in left side it is pretty easy to remove, large chunk is there, but there is nothing functionally abnormal happening there. So these kind of cases happen. So there is a discrepancy between these two. Then the surgeon thinks, boss, I can remove it, but will I produce benefit? I can't remove right side, but right side is where the whole functional problem is happening. So this is why they want all the information, 3 information is there. The third important problem that happens is there is significant RV dysfunction and there is severe RA pressure elevation. So for many years in our patients, 10 years, the patient has been living with CTPH for long and RV is given up. Now when their gross heart failure, they are coming. The moment you open up and the whole flooding is going to happen. So the whole problem is redistribution pulmonary edema. The problem is after the surgeon has done a wonderful job, most of the patients are lost because of bleeding and redistribution pulmonary edema. So now they have now understood, I think most of the centers have now understood how do we pre-optimize the patient, what are the precautions you take, and this is where the biggest challenge happens in our country is the redistribution pulmonary edema. But I think as you made it very clearly, like for example, even AIMS, we do a lot of CTPH surgery, but beyond us also, like there are few centers in the country where we also say, no, we won't operate, but they are able to operate. So it's like, it is like a graded expertise. So you do, possibly, I think every CTPH is operable within limits. Maybe a few will be really inoperable, but in the highest experience center, most of them should be operable.
So
At least partially.
Yeah, so this is a take-home message as well. The P is this gold standard for CTF treatment. Most of the time, selection criteria is actually subjective and not objective. In operable cases, yes, more distal lesions, pH out of proportion, PVR is more than 19 or 20 Woods unit. 40% which are inoperables becomes 8% inoperable in the best of the best centers. So 40% who are labeled as inoperable can be operated in the high volume load centers. So you should always go for the second opinion. Do not. Narayana Bangalore has done, yeah.
They have done around 1,000
Yeah. So we are going. I'll be talking about that thing. So basically, inoperability is in our mind and in our expertise. Okay. So always go for a second opinion. Always go for a experience center, the center with a high volume load. Do not just label the patient as inoperable, because mind you, this is the only therapy which will settle your patients, not any PS therapy. Okay, so this is important. There is no contraindication for sickle cell, CTEF, cold agglutinin CTEF. It can be done in these group of patients as well. And for residual pH post PT, BPA could be the next best thing which can be planned. So this is what we see. What happens when you just remove the whole vessel. It can't be. I mean, it can't be cleared with my ongoing anticoagulants and my PS therapy. So next question is, when do you plan for BPA? And my place for BPA and CTF management. First, I'll go for Dr. Sidana and then Dr. Ramakrishna sir. Please, I want your enlightenment here.
So as discussed, for all the proximal involvement and for all the operable cases, definitely the endarterectomy is the first choice, and the BPA should be reserved only for the patient who are not operable and the disease is either distal segmental or subsegmental. So in that cases only we should do BPA, and few things we have to keep in mind, that all the lesions, they should not be opened up simultaneously. We have to stage the procedure, because otherwise after surgery the edema will occur and patient will have hemoptysis and the pulmonary edema. So the best will be to treat 3 or 4 lesions in one sitting, and then we stage the procedure and do all the lesions in 4 to 6 sittings. And the pressure should not be very high, because pulmonary arteries are very prone for the rupture. So therefore a moderate or mild to moderate pressure should be applied with the balloon, and depending on the sizing of the arteries. And few lesions like ring lesions and web lesions, they can be treated with the balloon angioplasty. Stents should never be used, and that is one thing. And the another thing is that the subtotal occlusions, they can be treated, and although we can treat total occlusions also, but definitely if one person is expert in treating that, then only it should be treated.
Dr. Ramakrishna sir.
I think sir has nicely summarized. I think clearly it's indicated when surgery is not possible or surgery has not cured the patient and there's a residual disease and there is a recurrence that has happened.
Its role as an upfront and a sequential to PE.
So the problem that is happening in our country is that maybe we would have attempted in at least 10 patients till now, and not even one patient has come for the 4th procedure. So everybody says, I'm all right, I'm all right, I don't want to undergo the procedure.
So can you
that has been the biggest problem. So at times we cannot overtreat the patients, like as sir pointed out. You cannot open so for example, what is happening is there is a 70 pressure, and that 70 pressure, the blood flow is going into only very few segments. And none of the segments are normal in these patients. Suddenly you open up the one full segment, that particular segment will get all the blood flow, and they get the localized pulmonary edema, and that's dangerous. That's one of the worst diseases I have seen in my life. That the post pulmonary edema, even PVBD pulmonary edemas and this peripheral PS opening and this pulmonary edema that I've seen are the worst things in my life that I've seen. As they are killing, really killing, with ECMO, without ECMO, everything is very bad. So you have to be very careful in opening. So what we do is we open up partially one, and open up less than that one, 2-3 segments we open, 2 on either side, and then we come again next time. Whatever we open partially, we open fully. We open up the few segments fresh, and then we keep on doing it. So our problem is we are never able to complete whatever we thought in even one patient. Like.
So what is the risk profile?
One more point, that the medical therapy with Riosicot should be started before attempting this. So that we can get less pulmonary edema and.
Better.
I think that is something, I don't know what is the connection between this residual CTPH and residual what many of them do very well.
And what is the incidence of vascular complication during this PPA, sir? It's pretty much.
So I think overall, I think possibly we have not had any major complication in CTPH related BPA, but overall we had a lot of this pulmonary valve balloon dilatation with severe RV dysfunction, peripheral PS with RV dysfunction. Sometimes we attempted it in some fibrosing media stenosis and all this. Possibly as a cardiologist, I would have killed more of these patients than anybody else. Like. So it's unpredictable. What I mean to say is it's really unpredictable, and it's really, so for example, in one of the PVBDs, so this is nothing related to this. It's a simple PVBD. That patient actually came from somewhere in Rajasthan only. She was treated like nephrotic syndrome. He's a kid, a 10-year-old kid. He was swollen up everywhere. He was treated like nephrotic syndrome with large pericardial effusion. He came to emergency. We tried tapping it, and then our SR picked up there is a PS and RV dysfunction. So that annulus was 18. We dilated the 8 mm balloon. Still next day we lost him. So this reperfusion pulmonary edema, I think surgeons can vouch, unbelievable, and it's unpredictable. We have not understood it. Like. It just floods like anything. You then realize you are nothing. You just can't do anything.
Next question is to Dr. KP Singh, sir. When do you want, or when should you hit with pH-based targeted therapy? We have a lot of medical therapies now. So when do you want to hit with pH-based therapies? When do you want to start these patients on the medical
once
management?
it has either been labeled when the pH-based therapy, like there are certain amount when the patient is more of symptomatic, patient cannot be considered for the surgery. The
inoperable cases,
inoperable conditions, like there has been a clot at the distal end, not at the proximal end, then we look down for the pH-based therapy. And in our scenario, being as a pulmonologist, the cornerstone is the oxygen and diuretic. Surely the oxygen has been taken care of, and then we come to the diuretic. Now what happens during the pH-based therapy is we have to, if it is a longer duration, there are symptom signs, and there has been the cornerstones that yes, these patients can end up into recurrent pH associated with pulmonary embolism later on. Then we have to put them on anticoagulants and other things. Now these sets of the patients who cannot be operated should be given a pH-based therapy at the earliest, and even pre-operatively. There have been evidence, like sir also said, that the pulmonary vasculature is slightly friable. So once you reduce down the pressure pre-operatively, they can give wonders, and the results can come out to be better. And there have been sufficient evidence that once you lower down the pH pre-operatively, there are less chances of reperfusion edema, segmental reperfusion, and less chances of rupture also.
So what medical management would you like to offer?
So reduce on the salt intake, put them on the diuretics, then you give them a supplemental oxygen, give them a good anticoagulant coverage, and as a point of a pulmonologist, give them something that make them symptom free from the disease progress of chronic COPD or element, which is the underlying cause for the disease. Once you optimize your inhalation therapy, the cornerstone lies there. Once you optimize it, probably the pressures also reduce. and then you have to keep up a good follow-up with them.
Dr. Rajneesh, what medical therapy would you like to, start your patients on? If your patients, if you know your patient is inoperable, not a candidate for BPA and the PA, what would you like to offer in this group of patients? Apart from salt restriction, anticoagulants, oxygen, digoxin, whatever you call it, any pH-based therapy would you like to offer in your?
Yeah, sir. So there are trials like chest 1 and 2 that shows that this guanylate cyclase simulator like this Riosigat, this is very well effective, and it decreases the mortality and improves the 6-minute walk test, functional capacity, and increase pro BNP level. And it's in long term also it's well accepted, so we can start Riosigat.
So apart from Riosigot, there is any other drugs, or there is any combination therapy in addition to Riosigot would you like to offer if Riosigot is not working, or maybe working suboptimally in this group of patients? Mind you, these are inoperable patients, so you can only give maximum benefit of your medical management.
So like Macitentan also is effective as in Merit-1 trial, and we can also in class 3 and 4 functional defects, advanced cases, this intravenous this
The subcutaneous PGE2 inhibitor, prostaglandins can be used. And this, the Marisendan, it basically serves as a bridge between the recontent and when you are planning to give a prostaglandins. Or this can be used alone or in combination with this.
So this is what chest 1, and through which Riosigot basically causes a FDA not, but there is actually a take-home message. It is being used as bridge therapy in all operable cases. So this drug is approved only for inoperable and persistent PT or after PEA, but we are using it left and right in all operable cases as well. So what is causing? We are basically delaying our patients. We are not sending our patient to the vascular surgeons or the CTVS surgeons. This delay in therapy is basically creating problem for our patient. Riosigot is not the culprit. We are the culprit because we are using it in all operable cases as well. So use this drug wisely in only inoperable cases. Sit with your cardiologist, sit with your CTVS and see operability, and then go ahead with that drug. So this is the CTRF trial, which basically use subcutaneous treprostinil, which reduces PVR only in inoperable cases again. Okay, this is Merit-1 trial. Mind you, Selexipag is out of the window. Okay, Japan has used it. FDA does not basically recommend this drug. Macituf trial stopped in futility, but Merit-1 says that it also reduces PVR only in inoperable cases. So use this drug cautiously once your patients are inoperable. Use that drug. Do not use it as a bridge therapy. It has been seen that if you use Riosigat and then send your patient for PEA, then sending directly to PA, there is no changes. Okay, basically you're just delaying the things. Okay, so this is what Merit-1 study is all about. And this question to all the panelists: multimodal therapy or approach, is it a practical logical approach or basically causing a delay in referral? Okay, so I'll start with Dr. KP Singh sir.
So multimodal.
This is a different thing. This is a multimodal therapy, not a multidisciplinary thing. It's a multimodal therapy.
So I think despite being a multimodal therapy, we should go for MDD first in this case, to be very honest and practical. So once we have a combined approach, yes, these patients are the selective patients which can go for the surgery, because even in the chest 1 trial, what I read was that there was a inclusion and exclusion criterion that clearly says once you have received that these are inoperable patients, then put those on risk. So once we have a cardiologist, CTBS surgeon and everything, then we should decide it rather than putting it on a multimodal approach, because multimodal approach will not give any benefit. Rather, it will delay the progress, keep him away from a good lifestyle, good therapy, and better quality of life. So, practically speaking, we should first identify which patient should be taken and what should be followed on. If we are delaying the process, probably we are taking good years from his life.
Dr. Shivranshu, because we are the first who usually see this patient. And
so rightly said by Dr.
Keep
Arora.
a watch on this patient,
Yeah.
and hold the patient.
So see, but that's true if we talk about these patients. But definitely, if we see in practical sense, so we who have a limitations of availability of the surgeons, and definitely the acceptance towards the surgery with the patient profile is also limited. Definitely, even if we advise them for surgery, then on the patient and cost is all again a constraint. So all this makes operability difficult for the surgeon itself, and the outcome is definitely poor in these poor patients.
Dr. Ramakrishna sir, your view?
I think the take-home message is for CTPH, the only therapy is surgery, surgery, surgery. So I think if surgery is not there, then you think of other therapies. So the other important thing is cost also is not a major thing. So I think possibly even the highest volume centers, I think the cost is going to be maximum 2 years drug therapy. So I think combination 2 years drug therapy cost, you can operate a patient. So I think cost is also not a big concern in this particular disease. So I think everybody should be evaluated for surgery unless really high risk surgical patient or surgery is not possible in the best of centers also for various reasons that we discussed, which is there. It's not zero. It's not like everybody can be operated. There is definitely say 10%, 15, 20% maybe in India who will not be operated for various reasons. So then you can start all this treatment. Otherwise, everything has to be surgery.
So can I add on? What basically when we are giving him a therapy, we are excluding and we are not exposing him to the surgery. At least he should understand that this is the gold standard and this is what we are giving him. So to be honest, what I do usually in my clinic practice, I once send him to the CTS surgeon, get an opinion done, and then you decide whether you want a small EMIs for your disease or you want to get it one shot and have a better life. Because at the end of the day, when he is putting up lots of money in all this therapy for 2 years, that came down to be safe, even if you get down at the best of the private center also. So, and this will also improve his 2 to 3 years of lifespan. Quality of life will be improved. He can be more happily. Otherwise, each time he had some exaggeration, he lands up in the ICU. The cost will be more exorbitant than that of the surgery. That is what my opinion is. Somebody can be different with this, but
So if you have the multimodality treatment approach, that does not mean that you exhaust your approach first and then send the patient towards another guy. It means the patient should receive the best and then it can be done rest. Okay, so it should be done. You should identify the operability of the patient. If patient is under your purview, send the patient to the cardiothoracic surgeon. Okay, let him decide operability, non-operability. If yes, go ahead. Mind you, PEA, I mean surgery, the terror is in your mind, not in your patient's mind. So if you are convinced, your patient will be convinced. Okay, convince yourself, convince your patient, send the patient as early as possible. There is no drug which is said as bridge therapy. So please do not use riociguat as a bridge therapy. Send your patient directly. Okay, inoperable patient, yes, then you can use sequential riociguat, macitentan, you can use BPA with and without. There are trials, various trials which say that BPA is more effective than riociguat. So if
do not take the word of one center.
this is what I
Three
said.
different centers, one your local center and two experienced centers who are operating on CTPH. So before that, never label anybody as inoperable because there's a wide gradation of operability in this disease.
Go and have a second opinion.
If a patient did not accept the surgery is not, patient did not accept the surgery also. When you send also, you're not going to accept it.
So first of all, we need to accept this thing. Yes. First of all, as a pulmonologist, we need to accept this thing. We need to have this thing that this can be cured or treated with this thing. And first of all, I have to be convinced. This is very important. So going, yes, doctor.
Delay is also not a contraindication for any interventions. Delay is also not a contraindication for intervention. You should go and evaluate again for the operable or not operable.
So I'll continue my case again. She was treated symptomatically initially with diuretics, thoracentesis, HFNC, NIV at my center with anticoagulants. So she was diagnosed as a case of primary polycythemia. JAK state kinase was positive. Was started on ruxolitinib 6 months back, hydroxyurea. CTPA, which we did at that time, so bilateral distal vasculature were involved. She was too frail and too decompensated for PEA at that time. She was planned for, after yes MDD, she was planned for interatrial septal stoma to unload RV at that time. She survived. She was weaned off from NIV, she was weaned off from HFNC, pressure reduced, symptom improved. But obviously this was a palliative therapy. She was continued on anticoagulation and supportive therapy, and she expired after 14 months. Okay, so key points: screen PE patients for CTEF after 3 months if they are symptomatically. If screening positive, confirm it with CTPA, DSA, RHC. Check for operability and the plan and refer for early PA if possible. In operable cases, go for second opinion. Do not start the medical management. Go for second opinion in experienced center. Still inoperable, go for BPA plus minus pH-based therapies. pH-based therapies you can have reversiguate, macitentan, or in combination. For palliation, you can have this interatrial septal stomach creation. It can relieve symptoms and RV unloading. Thank you very much. Thank you all the panelists for the wonderful discussion. Any questions? So I close the session then. Thank you very much.
Thank you so much. So moving forward to our last session, which is hands-on sessions, we are going to divide the group in two parts, and doctor will be helping you with the hands-on. Dr. S. Ramakrishnan, Dr. Sanjay Khatri sir, Dr. Hemant Chaturvedi sir.
आ जाओ भैया, एक और वैसा टेबल चाहिए, ये कुछ नहीं चाहिए और वैसा एक टेबल लगा।
Whosoever is interested for this session, kindly come in front. We'll be doing it here for the eco session.